heart block, you have to see that very common. So things which develop solely after birth, we cannot detect at that because these are the most common for which the patient get worried. VS, PDA, ASD, ductus venosus abnormality, which we usually miss also, and these are the normal shunt present during pregnancy. So you have to do the counseling whenever you are doing the patient evaluation for that. So these are the something which evolve and over the like TS, cardiomyopathy. So this is the most important step whenever you as an obstetrician or as a radiologist, they ask us how to counsel the patient. So this is like a traffic light, red, blue, and orange. So green is the one which has got the excellent outcome. It means it's almost curable. ASD, common atrium, PAPVC, large, any kind of VSD. So these are the very thing which is the curable. That means once you do the surgery, even if you diagnose also, once you do the surgery, you can tell patients very clearly that this is curable. You continue, don't give dismal prognosis. Second, it's a other thing is treatable. Even TGA, COG, HRHS, Epstein's, vascular, they are almost curable in most of the cases, but it's at least treatable with a good outcome. It's a fair outcome, 80% they will survive and they can even near normal life. So these are the two things which we have to think. And the third one, okay, once like this, you can give them a bad prognosis to decide whether you want to continue or not in our setting. Single ventricle, heterotaxy, VSD without anything was only collateral, PA intact type with sinusoids. So these are the conditions which are very dismal prognosis, which palliative number of surgeries required. So this remember these two groups we have to concentrate here because these are the groups which we tell these are not critical patients. Okay, some of this will become critical over the period, so we have to see that. So these are the common scenarios. Patient asks, diagnosis of VSD, wants to abort the baby. After birth, diagnosis of TAPVC, coronary abnormality, AP window, because these are things which can easily miss because it's not seen by best of the radiologists as well as by the best of the pediatric cardiologists. ASD, PDA, ductus venosus can persist. So you have to, when you have to counseling, you have to give that thing. This may persist because the patient come to us on the second or third day. They'll ask you why you not diagnosed PDA, why you not diagnosed ASD. So you have to tell these are the normal shunt which may get closed and initially normal but develop like arch hypoplasia, cardiomyopathy. So critical CSD decide which requires surgical intervention 24. So this will not go ahead, but the critical whenever the lesion, these are the three, they do duct dependent lesion. Severe PS, severe AS, atresia, HLHS will not go, but it present with like this. Either it will present with a shock at the birth or with the severe cyanosis. So these are the things which we have to tell. Even half of them is got a fair prognosis if you treated it well, like the critical PS, like critical AS. Once you do the balloon, they have the fair normal life. So you have to understood that what is the critical and what is not critical. So what I showed in the green and the yellow, they are even if they're critical, they have the good fair outcome. It depends on the promptness, it depends on the expertise where they got the surgery. Okay, I won't go with this. So another things which can cause fetal hypertension normal, like restricted forever over restricted. Recently, I had one case congenital heart block where they give the dexamethasone. With the dexamethasone, still the PDA becomes restricted, becomes severe TR. So now we have to stop. That means if you stop, even the child fetus was very symptomatic in the fetal age, but once you deliver, that will be normal. So you have to understand these things. Okay. So these are the common conditions when we are doing the prenatal cardiac evaluation. You have to do the fetal arrhythmia, structural heart defect, cardiac and the functional assessment, and USG and absent ductus venosus. These things you have to see. So this is the one case very important. This is the 32 years old with a UTI. So there's a normal heart, both everything was on, but on the 33 weeks, it found out there is a severe TR. The mother took the paracetamol for 5 days. So with that, everyone, if you see in our formula CYP 350, everyone has got the different sensitivity of the paracetamol. This even with the 3 days or 2 days of paracetamol, she got ductal restriction and caused the severe hydrophilic feature. So we have to stop, or if we develop the 34 to 36 weeks, you have to deliver and then you have to treat it over there. So this is like that the velocity of the ductus is almost 180 to 200. So these are the reasons which looks like critical, but it's not. It's not. It's a very good prognosis if you treat it and diagnose it very well. So we'll go with some cases. So this is the, I think my 80% of the fetal practice depends on this. I am earning only because of the echogenic focus, LSVC, mild TR, minimal pericardial collection, atrial ectopic, or persistent anatomy. If you see this, my 70 to 80% of the referral only because of this. So this is the IAS aneurysm. Because so much of the ISMV is a normal phenomenon. Until unless it develops the SVT, it's not cause any problem. So, ISMV in the fetal life is a normal phenomenon. Like that, some of the persistent right umbilical vein, it's also normal. Not all types, but few of them has got the normal outcome because it won't cause anything. Only thing, it will be of the different view on the echo, but you have to check there is no photosystemic problem, otherwise it's mostly normal. In the same way, there is a ridge you see. The importance of this ridge between the left upper and the L appendix is the chromatin ridge, this is known as warfarin ridge. When this is present, you can easily rule out TAPVC. So some people say there is a clot in the LA and they refer to us, but this is not a clot, it's a ridge which shows there is a normal pulmonary venous connection. So easily you can rule out TAPVC, although you may not rule out the PAPVC. So this is the most common echogenic focal. The parents are so worried with the calcium is there, what to do. So the literature shows, if you see the literature, only the 0.5 to 1% of them are associated with the congenital or the complex heart disease. If it's a multiple previous child having problem or the very high age or other anti-abnormalities are there, then it shows it's just a chromosome abnormality. Per se heart, it will not cause anything. Only in one case I missed, I thought it's a echogenic focus, it developed over the rhabdomyoma single. So you have to rule out only thing when it's when it's a center in the cavity, when it's on the LV chordae, when it's on the single small, mostly it's a echogenic focus. When it's attached to the myocardium, it's a larger, it's a more echogenic, then it's a more or it's a multiple, it's a more rhabdomyoma. So this is the same patient you can see. One patient we thought it's an echogenic focus, but later it developed because rhabdomyoma growth is maximum in the third trimester. So once you see, you have to follow that. That's why sometimes echogenic focus, you have to give counseling. Rarely it may go into the rhabdomyoma, otherwise it won't be a problem. So once you do the rhabdomyoma, it's a spontaneous regression is common, but central lesions as well as the arrhythmia risk are very high sometimes. So this is the last, this is the normal, this is the LSVC. So LSVC, the concept is up to third, it's only up to 2/3 of minor or major cardiac anomaly. Coarctation is associated only with 21%. Isolated, the rate of karyotype is 7%. So it's present in 0.5 to 1% of the normal population. So when LSVC, what is the only problem with LSVC? There is a mild asymmetry. Because when coronary sinus, you can see, it will bulge into the LA. So there will be little bit discrepancy. But if it discrepancy less than 1.2, your aorta and your coarctation is normal. So then you can tell it may develop the coarctation, but if its size is equal, then the chances of having the coarctation will be very less. So once the discrepancy associated with LSVC, you have to follow up. And most of the time, if it is still mild discrepancy, 80 to 90% will improve after birth. It won't cause any problem. Okay, so you can see this. Now, one of the thing, this is the, again, this you can see, this is the LSVC 4 chamber as well as the cigar sign. The cigar sign is a very common because once you show the cigar like that, that is shown in the LSVC, so that is the two. So one, I told you transient lesion in vitro very serious application, but once you treat it post excellent like ductal restriction, I told you, absent ductal not associated with total hypertension. It may present as a RV dysfunction, but once you treat that, the outcome is very good. And foramen oval restriction. So these are the things you have to look after whenever the RAR is dilated. Then you are not finding any cause, TR is there. You have to rule out these three causes. So now 33 weeks, mother is already present. Sorry. So clues for CHD, whenever you say there is a chamber asymmetry, although normal, to take a clue, altered cardiac axis, either it's a push from the outside or there is an altered geometry, altered position of the fetal heart, enlarged fetal heart or arrhythmia. These are the things when you call it as you have to think of the congenital heart disease. So now we go to two examples, all three group. Group one almost curable, BSD, ASD, common. You can see what you do. This is the you change it. So this is okay. This is a small muscular BSD. 24 weeks. What you do? Even the literature shows that 20% or 30% of the small muscular will disappear by the natal age. So you should not. The parents are coming small hole. What to do? Because the fear is more. Fear is driving the force. So once you tell the small BSD, don't worry. It's a very high chance of a spontaneous closure. If we not close, also we can easily close with the device. It's a very simple and almost curable lesion. So in the same way, this is the large muscular. So this outcome is very good prognosis. So even what are the things you can do? It's a good prognosis. Either you can do the surgery or intervention with the very good outcome. And the mortality for the VSD at present is only 0.1%. So even you can see if you do the good VSD surgical, the outcome is very good. So these are very perventricular you can do, device you can do, surgical you can do, and this is the closure rate. Less than 3 mm, even in utero, it's just 7% it will get closed. So it's a very, you should give the good counseling for the parents. Okay, in the same way, we have the various, which is the chance of closure. Now the group 2 will come. This is the most common group. Treatable, good outcome with less chances of reintervention, almost curable. Top with good size annulus, VSD, PS, coaptation, vascular and osteoid, TAP with good base. Once you do surgery, the outcome is 80 to 90%. The proper outcome is they are near normal life. Although some may need re-intervention or some morbidity, but still they are having the good life with AV canal, Epstein's or TGA, TAPVC. So these you have to categorize into curable, near curable, treatable, and the palliative. If you classify that, the counseling itself at your level becomes easy. You can see, this is the RIR dilatation, chamber asymmetry, 32-year-old, 4 chamber, and then you see there is a severe cough. Okay, so but there is no other intracardiac. So once you do the coag repair, the outcome is almost normal. So you should do a proper good counseling. You should continue because you should not give the fear for that. Second thing, the coaptation natural history, although 5 to 8% got death afterward, but if you operate at the right time, it could be very good. So coaptation, good prognosis to be explained, delivery at tertiary care center, need for prostaglandin to be explained, and corrective surgery has to be done in the newborn period. Predictor of so this is second crux of the type. This is the AV canal. This also case at 26 weeks, which has got the good outcome. So once you do the AV canal, you have to see whether it's a trisomy or not trisomy. Not trisomy, the outcome is very good if the chamber size is good. In the same way, this is the top. Top also the outcome at 5% only, moderate 95%. It's a good outcome. So these are the predictor which require early intervention. The outcome will be little worse than the normal. So you have to check for that. So so DORV, this is the same. Top absent pulmonary also is it depends on the compression on the airway. No airway compression, the outcome of this is good. So top, the truncus also it's a good outcome. See, these are the good where if you do the surgery, it will very good outcome. So pulmonary, this is a TAPVC. You can see this is the LA and the is aorta is back. So how to diagnose one? There is an increased gap between LA and the aorta. That means there is a TAPVC twin side will be there. This is one TAPVC recently operated with the coronary sinus TAPVC with the now the child is coming in 6 months follow up. This is also another which has got the infracardiac TAPVC and we operated and now doing well. So intracardiac, you can do even after birth within one day. So we are posted having one child for 2 days after the intracardiac. The last day, this is the TGA. Another thing is TR. Either it's organic, non-organic. If you do, if it not associated with the critical phase or the small RV, it has got the very good outcome. So don't see only the RV size. If it's normal, nothing to be done for that. It's a very good outcome. So this is last is a tachycardia. One of the reasons why we got referral is the ectopic. Ectopic is a very common, but tachycardia is a thing which get hydro. But if you treat it well, it will get very good outcome. So this is we treat with the sotalol. This is the fetal tachycardia with the 240 heart rate, and we treated and now the child is coming for 5 years follow. So this is now the therapy. Arrhythmia has got the very good prognosis. This is the aortic stenosis which can go mild or severe. Severe you can do the fetal balloon or the aortic balloon. Vascular ring has got the very good. It has got the near normal life. So you have to see after that. Okay, so just so last slide. This is how to disproportionate chamber enlargement. So one, it's a RV is more than LV. You have to see the restricted foramen, and LV is more than DCM, LV aneurysm. RA is more than LA than DR. Hypoplasia, it's a critical. So now, this in utero transfer depend on which it's a critical you have to do in utero. A non-critical also something which critical case you have to do in utero. So gray zone is this because we are not able to diagnose all these things, so you have to explain parents about that. So way of talking, counseling is very important. So another you have to coordinate with the obstetrician as well as the radiologist, as well as you have to detection depends. You have to explain the physiology and tell these things may be missed and this is your very good outcome. So coordination is very important. So we have to give option. Last slide, we have to give option. Don't tell it's a you have to about you have to give option and current status of the CAG and its natural history. Give the natural history and then the family to decide. We should not tell from our side. So they are very low risk. Take home message: all lesions are not critical. Maximum lesions have got a fairly good outcome. Crossing involved natural history and long-term outcome is important. Even some critical lesion can be managed with excellent and normal outcome. Fetus is evolving, so we cannot diagnose all lesions with full spectrum one period of time. Thanks a lot.
Thank you, Dr. Sudhi. And I'm proud to say that I have a team and armamentarium here of pediatric cardiologists. We have pediatric cardiac surgeon at KIMS Cuddles, Kondapur. We have a team of 4 fetal medicine specialists, and I am proud to introduce the next speaker, Dr. Shilpi Reddy. And I am so very honored to have her as a team member. She is one of the senior most fetal medicine specialists in India and a pioneer in her own field. And not only a compassionate fetal medicine specialist, she is so good at counseling and so good at doing her procedures and making sure that women do not get apprehensive when they find spurious findings. She knows a very delicate, margin where to tell them what is not to be worried and what is to be worried, and where unnecessary tests should not be done, and where necessary tests should not be missed. So this is something that I've really, really learned from her, and this is her whole armamentarium, and she's currently the director and lead consultant, Resolution Scan Center, and senior consultant at King Sunshine, Begumpet. And she is she's a visiting consultant here also. We have madam in our hospital every Wednesday from afternoon to night, and she she's head of ICOG FM certification. It's okay. Madam is so passionate to go ahead with her, talk. Thank you so much, Dr. Chinmay, to honoring us and coming here for the special moment that we want to have. Thank you.
Thank you, Dr. Shilpi and Dr. Aparna, for this very nice opportunity of interacting with all our friends on this Sunday morning. Respected Bhaskar Rao sir, thank you for sparing your time to come here and listen to us. And as humbly he said, I come here to listen to others. Thank you for your time, sir. And my previous speakers have spoken on the importance of biometry and the importance of looking at the heart. That is one aspect of looking at the fetus. But at the end of it, the topic which is closest to the obstetrician is fetal growth and a decision to deliver. And that is something which challenges us every day. So my aim is to take you from the scan finding to a solution. Fetal growth restriction is something that we all know. It's a continuous process. It should happen, and every fetus should attain whatever it is its genetically predetermined growth potential. Whenever a fetus is unable to attain that potential, we call it growth restriction. So when we have fetal growth restriction, we diagnose it by biometry, like Kirti showed us. And the Dopplers hold a very important part because they tell us about the status of fetal hemodynamics, what is the effect on maternal and fetal functions, and whether there is a decision for delivery which is valid. Delivering any fetus is very easy for an obstetrician, but the challenge today is whether you delivered at the right time. You should not be too late, you should not have done intrauterine compromise, and you should not be too early to make it preterm. So let's start with this case, which is a 26-year-old primigravida. Her first trimester screening was otherwise okay, but she had a low PAPA, 0.2 MOMs. So fetal anomaly scans were normal. Uterine artery Doppler said high resistance. And Kirti just told us that uterine artery Doppler high resistance is a prediction for placental problems. So at 28 weeks, expectedly, the growth was on 5th centile. Umbilical artery is high resistance with a positive end diastolic flow, and the MC and DV are normal. Although my topic is only umbilical artery, you cannot look at Dopplers in isolation. And therefore, before you look at Dopplers, one has to understand the importance of fetal circulation and the fact that umbilical artery is nothing but the blood that is going back from the fetus to the placenta. So it's the fetal heart pumping back to the placenta, and that carries deoxygenated blood, which is being cleared from the fetal circulation. So the umbilical artery is a measure of peripheral vascular resistance of the fetus. What happens is from the placenta, you have umbilical vein that takes in blood into the baby. And this vein goes into the ductus venosus and then to the inferior vena cava. So ductus venosus is a measure of oxygenated blood coming into the baby. And when that distribution occurs, Dr. Sudeep was showing us the circulation and the coarctation of aorta and all the effects of that. What the body does, it sends maximum oxygenated blood to the brain. But when there is growth restriction and there is compromise in hemodynamics, the resistance in the brain vessels become less to accommodate for the hypoxia. So all these three Dopplers have to be seen in combination because each Doppler has its own importance. So umbilical artery Doppler is a measure of peripheral resistance. Middle cerebral artery is a surrogate marker for fetal hypoxia, and ductus venosus is incoming blood of the to the fetus. So whenever there is fetal hypoxia, the natural redistribution occurs where the important organs, the brain, heart, and adrenal glands get more blood, whereas the gut, kidney, and lower extremities get less blood. So when you start ignoring the Dopplers, you might still have survival. But if the gut, kidney, and lower extremities have less vascularity, Dr. Aparna will face the problems in the neonatal period where there will be necrotizing enterocolitis, there will be other problems of ischemia, and that will not lead to intact survival. So our decision is to balance all this and time the delivery. So suppose you have a lady who came at 28 weeks with that increased, resistance in the umbilical artery. Will you plan delivery at this point? How many of you will think of delivery? Not at 28 weeks, isn't it? So you want to do something more. Will you consider antenatal corticosteroids? You are not anticipating delivery within 1 week. So you will wait for some more time. Now you ask the woman to come back after 1 week. She came after 2 weeks. That's standard here. So now she's 30 weeks. She was 28 weeks, it was high resistance. Now she's 30 weeks, there is absent diastolic flow. MCA redistribution, but DV is normal. Now should we deliver or should we wait? How many of you for delivery? Still you are doubtful. So whatever, we don't want to take that responsibility. There may not be a risk of death at this point, but whether intact survival will they be there or not be there, that decision has to come as a joint consultation with the neonatologist. Because you don't have to take the entire responsibility on your head. Tomorrow, if she says you should have delivered it early, you don't want to be in a spot there. So better to send to the neonatologist and take a decision together. 30 weeks, there is prematurity, absent diastolic flow, there are pros and cons of delivery. How do we go? So evidence tells us that there is a whole like a stream of abnormalities that can happen in the fetal Dopplers, and that kind of mirrors the functional problems that happen. So what starts with placental disease that is seen as umbilical Dopplers starting with high resistance, goes on to hypoxia, then goes on to acidosis, and finally culminates with fetal demise. So our challenge is to deliver a baby before strong damage happens. And where is strong damage? Acidosis is strong damage. Hypoxia is mild damage. Hypoxic problems can be reversed. Acidotic problems cannot be reversed. So now she's reached 32 weeks. She did not deliver at 30 weeks when there was absent diastolic flow. Now she reached 32 weeks and now there are reverse diastolic flow, MCA redistribution. Even the DV is high resistance. The amniotic fluid index has reduced to 4. Biophysical profile is 6/8. Now how many of you want to deliver? Most of you want to deliver. So whether you are justified or not justified in delivering this 32-weeker, there are some online support systems now. This is called the Fetal Medicine Foundation Fetal Growth Restriction Management Protocol. So if the patient is not convinced, if the patient thinks you are just delivering because you want to take more money from them and put the baby in NICU, show them that even by international standards, given your parameters, at this stage, the decision would be to consider delivery. So these are methods by which you can justify your thing, and like the topic says, from evidence to practice. So the take-home messages here is growth restriction is now a well understood entity, and we should understand the role of Dopplers here. But there is a need to constantly review the management. Don't jump at one finding in the Doppler, but constantly review it and work with your whole team. So the neonatologist has to be a very important part in counseling babies with fetal growth restriction. The funda remains the same. Establish the gestation age, follow up serially, and look at the Dopplers for decision to delivery. So umbilical artery Doppler to ductus venosus is an important journey because the umbilical artery, like I said, is just a measurement of the peripheral vascular resistance. So it will worsen from high resistance to absent flows to reversed flows. Till you have absent or reversed flows, you are not expecting acidosis. So just at increased resistance, please do not consider delivery. But once it is absent or reversed, then you talk to the neonatologist and optimize it. Now, suppose this is your situation. You are at 22 weeks. At 22 weeks, you now have absent and reversed diastolic flow. What can we do? Can we deliver this baby? Because it's a moot question, isn't it? At 22 weeks, the survival is almost nil, and already there is so much compromise. Do we deliver? Do we leave it aside? In these cases, you actually have to explain to the patient that you really cannot change the management. There is already risk of acidosis. There is a severe risk of intrauterine compromise. But then we just have to wait and watch here because nature takes its course. Unless there is a maternal indication, let the pregnancy continue and let it reach its own natural course. There will be an IUFD in this pregnancy, but this will give you the guideline to plan her next pregnancy. Because what is the reason for this early compromise of Dopplers? You have to work it up after the delivery of this fetus. Now, this is a lady who's 45-year-old. If you can see, she has a lot of comorbidities. But right now, she is at a stage where she's 25 weeks pregnant, and there are a lot of Doppler compromises here. Again, it is not difficult to diagnose this situation. So why I'm coming into this example is now IUGR itself has got redefined. There are two types of IUGR in clinical medicine now. One is called early onset IUGR and one is called late onset IUGR. So that 22-weeker case, this 25-weeker case, these are all early onset IUGRs. They are very easy to diagnose. And then the management will follow the natural course like we discussed now. Sometimes you will have an early onset IUGR, but Dopplers will be normal. And with serial growth, you will see that the baby is continuing to grow with the same kind of Dopplers. So this was a case which could go up to 36 weeks. And even if the baby was 1.8 kg, the outcome was very good because there was no change in the Dopplers. This is a 30-week IUGR. Again, the mother has epilepsy and hypertension. So what do the Dopplers tell us here? Should we deliver this baby? Normal umbilical, just high resistance umbilical artery Doppler. Do we really need to deliver? Not needed. But when you follow till 32 weeks, now you see reverse diastolic flow. So here probably you will think of. So look at the Doppler. The trend of the Dopplers tell us that now there is compromise. There is a need for considering delivery. And whenever you consider delivery, give corticosteroids and plan the NICU management with the neonatologist. And remember that till there is positive diastolic flow, you may not expect acidosis, but once absent and reverse diastolic flow starts, acidosis will set in, and therefore there will be a serial deterioration in the fetal hemodynamics. Now, the ductus venosus Doppler is a very important Doppler because it is the single most important short-term predictor of fetal death. So as long as ductus venosus is normal, you are not risking fetal death. But when ductus venosus becomes abnormal, that is, there is absent A waves or reversed A waves in the ductus venosus, then this fetus may die in utero in the next 72 hours, and then delivery becomes an imminent necessity. This we have already discussed. So this is the stage-based management for early onset IUGR, where depending on your gestational age, you balance the Doppler abnormalities and then decide whether you should deliver or continue, because you are trying to avoid prematurity and you are also trying to avoid unnecessary intrauterine compromise. This comes from this paper. You can take a picture of this paper. It is freely available on the internet. And I request all the obstetricians to go through this because very important messages regarding Dopplers, that umbilical artery should not be used as a standalone parameter. It's a very important parameter, but it should not be used as a standalone parameter. And when you see all the other parameters, then the DV becomes the strongest predictor for death. So unless there is a DV abnormality, please discuss with your neonatologist and then only take a decision for delivery. So like I told you, there are now two types of IUGR, early and late. Late is when the IUGR itself starts after 32 weeks. And in this case, it is difficult to diagnose this IUGR because the baby may be actually average for DIMS. If you see that chart, the estimated fetal weight is not less than the 5th centile. So the baby may not be less than fifth centile, and this we have read in our MBBS textbooks. The Fernando Arias had that statement long time back that all IUGR are not SGA, all SGA are not IUGR. And that has been redefined now by this entity called the late onset IUGR. And why is there late onset? Because the placenta is different. In early onset IUGR, you have a bad placenta. You don't have enough villi in the placenta. And therefore, resistance is high. Therefore, your umbilical artery Dopplers are bad. But in late onset IUGR, you see the placenta is as good as a normal placenta, but it does not function. And we cannot really look at that function very well. So what is the function of the placenta? It is to provide oxygen to the baby. So if that placenta is not functioning, there will be hypoxia. And which is the Doppler which tells us about hypoxia? The middle cerebral artery. So here the middle cerebral artery will have slight changes. So there will be slight changes in umbilical artery and slight change in the middle cerebral artery. So in an isolated manner, you may not be able to detect Doppler changes, but if you look at a ratio, which is called the cerebroplacental ratio, then you will be able to detect that there are Doppler changes in late onset IUGR. But late onset IUGR can cause IUD. It can cause unexpected IUD, and that can be a devastation for an obstetrician. And every obstetrician who has practiced more than 5 years will say, I have had this case where the baby was 2.5 kg, but there was an unexpected IUD. Why that unexpected IUD happens, I will give you a crude example. Suppose you have student A and student B. Look at the grades of student A and B right from the beginning. Student A is a poor student. Always grades are C, D, D, C, whatever. This is a case of early onset IUGR. Right from the beginning, you know that grades are bad. This child might fail. You want to start tuitions. You keep reinforcing things. And with some effort, the child finally passes. But if you look at the next student, look at the grades, A, and somewhere there is a B. You miss that B because you think always the child gets A. So what if it got a B once? But the child might have got distracted at that point, might have bought a new iPhone at that point or registered into some other thing. And suddenly the child fails in the last exam. That is an unanticipated failure. And that is why the problem with late onset IUGR is there, where the obstetrician does not anticipate these issues. The neonatologist is not called because nobody thinks there is an IUGR. You think it's a 2.5 kg baby, it is not IUGR. But this baby would have been 3.5 if there had not been late onset IUGR. And so it is very important to follow the growth curve. Always draw the charts and see where the centiles was earlier and where it is now, so that you don't miss that boat. So the Doppler changes in early and late IUGR are very different. In early IUGR, you will have the cascade of changes which we discussed in the first part of the talk. But in late IUGR, you will just have a change in the cerebroplacental ratio. Individually, the weight, the umbilical Doppler and the MCA might all be normal. And that is where you should not miss the boat. Because everything in IUGR is about the decision to delivery, which will give you the optimal outcome. So before we finish, quick recovery. 26-year-old primigravida, healthy, estimated fetal weight less than third centile at 28 weeks. Absent diastolic flow in umbilical artery, MCA distribution, DV normal. Should we deliver or should we wait? We'll wait. Because it's just umbilical absent end diastolic flow. Now, the same case, but instead of 28 weeks, she's 35 weeks. Should we deliver or should we wait? So what has changed? The Doppler is the same. The gestation age. So you are not treating the Doppler. You are treating the whole patient. So don't get stuck with Doppler. You know, what is the Doppler? You have to look at the whole patient. 26-year-old primigravida, severe PIH, imminent eclampsia, third centile growth, increased resistance. These Dopplers are better than the last Dopplers. The last Dopplers were absent diastolic flow. Now it's only increased resistance. Will you deliver? Will you wait? Everyone will deliver because she is imminent eclampsia. So you don't close your eyes to maternal morbidity. 29-year-old primigravida, healthy, less than first centile, 28 weeks, less than first centile, 580 grams, absent diastolic flow, redistribution in DV, aortic isthmus. She's a primigravida, otherwise healthy, and she's 29 years. Deliver or wait? Anyone who thinks differently? Any senior obstetrician who feels This baby might not make it. Dr. Aparna will kill me if I say that, but anyone who thinks, some people will think, because if she is conceived very easily and this baby doesn't have a great prognosis, you do not want to give her a cesarean section scar for a 580 grammer. There will be people who will think like that, and that might be justified. However, if this is the history, married life 7 years, 4 attempts of IVF, history of endometriosis, treatment for septate uterus, family keen on saving the baby, then what do? Deliver or wait? Deliver. Then you call Dr. Aparna and say that now you show your prowess and give this baby. And she has done it in many cases. So that will happen. So this is where you have to understand that it's not the Dopplers that we treat. We treat the whole patient and the whole clinical condition put together. So Dopplers tell us about fetal dynamics. They tell us about the prognosis of intrauterine environment. We use it for many other things like transfusions and other things. But overall, if you use your Doppler properly, you will improve the perinatal outcome. So William Osler once said, listen to your patients. Listen to your patients because they may be telling you the diagnosis. Not the Google Trend patients who come and read their diagnosis, but the patient who gives the symptoms, you understand their diagnosis. So listen to the Dopplers. They may be actually telling you what is the situation of the baby inside. So some things about Doppler is not going to change. These basics of Dopplers we've been revising again and again and again, and that is not going to change. What will change is the way we look at these Dopplers. So we've been doing umbilical Dopplers for the last 20-25 years, but the way we look at it changes. And gradually there is a redefinition of these Dopplers where we are not only understanding the Doppler as a hemodynamic parameter for today, but we are being able to correlate it with long-term outcomes. So the decision to deliver will depend on what is the risk of autism in this condition, what is the risk of other neurological morbidity in this condition, and that can be done by revisiting the Dopplers again and again. So till you know better, do your best, and when you know better, do better. Thank you very much for a very patient.
Thank you, ma'am, for your excellent elucidation of the evolution of umbilical arterial Doppler abnormalities, talking about arterial versus venous abnormalities, and beautifully bringing out contrasting scenarios where umbilical Dopplers help us in decision making, but not solely are the only tool for decision making. I request you, ma'am, and the other two speakers, Dr. Kirti and Dr. Sudeep, to please join us in the chairs in front of the screen. We are now open to take maybe 2-3 questions. We have an esteemed team of speakers. So can we have the volunteers take the wireless mics around for questions? So maybe until we set the ball rolling, I have a question for Dr. Chinmay, ma'am. One is you spoke about the role of uterine artery Doppler. So could you please elaborate on where uterine artery Doppler, in contrast to umbilical Dopplers, come into relevance?
So the uterine artery Doppler is the blood supply that goes to the uterus. So the role of uterine artery Doppler now is in prediction of placentation. So when we do the uterine artery Doppler in the first trimester, the first wave of placentation is happening, and therefore the resistance of the uterine artery Doppler is an indication of how good the placenta is setting in. Placenta is an organ that is starting in pregnancy, and it is formed because of trophoblastic invasion of the spiral arterioles. So when the spiral arterioles lose that muscular layer and become a low resistance circulation, the resistance of the uterine artery should come down. If that resistance has not come down in first trimester, then it is a predictor that this placenta may not be very good. But the prediction is best in the second trimester because the second wave of placentation happens around 18 to 20 weeks. The problem is once you predict, you cannot do anything in the second trimester. So in the first trimester, the role of uterine artery Doppler is to be part of the screening for low placental problems, which are like growth restriction and preeclampsia, and starting a medicine called acetyl salicylic acid, that is low dose aspirin at 150 milligrams at bedtime, which starts around 12 weeks and continues to 36 weeks. And that brings down the risk of preterm preeclampsia by good about 60 to 70%. So there's almost a 70% reduction in preeclampsia in the high-risk cases.
when we are taking the umbilical artery Doppler's, if I take it one place, the PA will be 0.3. And if I take it one place, the PA will be 1.1. Which Doppler should we take into that?
No, that is very common. So if you take your blood pressure now and you take your blood pressure after 5 minutes, it will be different because it's a dynamic thing. So typically the umbilical artery, the way it is placed, when you go towards the placenta, you have less resistance. When you go towards the fetus, you have high resistance. And that is why even Kirti mentioned in her talk that the umbilical Doppler should be done in a free loop. So a free loop is generally a free loop. Rarely, if you are seeing nothing wrong in the baby and you're seeing an abnormality in the Doppler, put the mother on the left lateral side. Just wait for some time. Sometimes the baby might be clutching the cord. Sometimes the cord might be around some part of the baby that it's giving you a high resistance. So give the baby time to, reorganize itself. So there is no hurry. Send the patient for a walk, call her back after 15 minutes, and then you test it. But if you are getting a persistently high resistance, then you take the worst reading because you are doing it as a screening tool.
And another question, at 36 weeks, umbilical artery Doppler is normal, MCA Doppler is normal, but we are getting CPR at third centile. Greater than 1, but third centile. What should we do?
So what is the growth?
Normal. 35, so think the 30th centile or 29th centile. Like
So I don't want to know if the growth is on 29 centile now. I want to know what is the change in the growth. So if the change in the growth from the mid trimester to now is more than 2 quartiles, that means about 50 centiles. Suppose it was at 75th centile and now it's at 24th centile. Then it is a case of late onset IUGR. Then you take it to 37 weeks and at 37 weeks discuss delivery.
not only cesarean section.
Not only cesarean section, because when the Dopplers are normal, the obstetricians will not hesitate to give a trial of labor or even induction. If there is a positive diastolic flow in the umbilical artery, the baby can take the risk of labor. If there is an absent diastolic flow, then there is no point of doing a normal delivery. You will do a cesarean section. But if the growth is 85th centile and this is happening, that can be a physiological redistribution. So in those cases, we don't deliver at 37 weeks, but we keep them on like NSTs maybe twice weekly or once weekly. And that it's an indication for surveillance, not an indication for delivery.
And AFI is 3 centimeters and 32 weeks. Or should I
Measure it again. There has to be a reason for AFI to be 3 centimeters with everything else being normal.
It's not an indication for delivery.
No.
Term
No.
AFI.
Isolated oligoamnios is not an indication for delivery because you now have Dopplers, you have biophysical profile, you have the NST, and you have thinking obstetricians. That is more important. You need an obstetrician who can think. So you worry why is it become 3 at 32 weeks? She may be having a high leak for all you know. So you do her perspectivum examination, you check other things. Why should it suddenly become 3? If the growth is fine, kidneys are being perfused, why should you have it? So there has to be some other reason. That reason is your read.
Thank you so much.
Yes, go ahead.
Ma'am, I have a doubt about large for gestational age, ma'am. I have a patient, she have no comorbidities and she is now 40 weeks with 4.25 kgs baby and she want to come after 1 week because she have a final exams now. So can we wait till 1 week? Her pelvis is adequate, but I don't think she will deliver normally. Even for posting her for C-section also, she don't want to come till 1 week because she have final exams.
At the outset, you have to counsel the patients properly and tell them well in advance that, this is a pregnancy and this is a very important part of your life. So exams and all can sometimes be rescheduled and other things, but do not compromise with clinical care. Secondly, what is the reason for a 4.25 kg? So find out the family members' birth weights. If you ask their mothers or their aunties, they will tell you what is the average birth weight of that family. So sometimes all the babies in the families are 4.5 kgs. So then that will be a physiological LGA. Then you need not worry. The only problem is your method of delivery, because as the baby becomes bigger and bigger, you will have difficulty in delivering a baby more than 4 kgs. But if everyone else was very average, maybe she is an undetected case of diabetes. There could be subclinical hyperglycemia leading to that problem. And for that, you have to screen properly.
Yes, ma'am, I have screened her. Everything is normal. Only she have polyhydramnios, but no sugar. Sugars are normal, ma'am.
Very difficult to believe that she
Very
has
difficult.
LDA and polyhydramnios, and please check all
Maybe she's
sugars.
overeating. It can be overeating also.
Overeating will manifest because of
Yes.
hyperglycemia. So she may be having subclinical hyperglycemia.
And such patients are very, very high risk for intrauterine fetal death.
A baby which is used to hyperglycemia also has high insulin levels. And that is the reason for the macrosomia. So suddenly, if there is a delivery or something like that, there can be hypoglycemia, which is fatal.
Yes. it
Even
is very
one meal she can miss, and that can have an IUD. So if you are not able, anybody who is not able to counsel the patient, and you think that the patient is not doing something rational, we have so many people here, no?
No, ma'am.
Just
actually,
refer to a colleague. Let her hear the same thing from two doctors. Your responsibility goes off.
till 40 weeks, she have consulted in Hyderabad only, ma'am. Because her gynecologist have told her to do C-section, she came there.
No problem. You tell her. I mean, see, the second opinion need not always be a different opinion.
Yes, ma'am.
All of us should accept the fact that sometimes the first opinion is the correct opinion.
Yes.
So that's fine. She doesn't like it, she doesn't like it. Let her go and look for a doctor who likes it. It's better to lose these patients than to.
Yes, it's inviting problems. And in Indians, we have observed such high incidence compared to Western world of IUFDs, which are happening in outside countries when people are asked to stay back 41 weeks or 42 weeks in UK and US. There are sudden IUFDs and they call us, take online appointments and they cry over the phone.
No,
That
because
is
the
really
Asian
high.
placentas are not known to function. Our
Yes.
incidence of meconium staining is more
Yes.
after 40 weeks.
Yes,
Till 40 weeks, no problem. But after 40 weeks, you're taking a risk. And you can't use the same guidelines which were there, and their guidelines will change because their population is changing.
yes.
The number of Indians and Asians there is changing. So I'm
They,
sure
they
they're
still apply their protocols only on Indians. And at least we don't leave our patients so beyond, but we should understand that things are happening there. It means that Indians will be Indians anywhere they go, and we have to be very stringent on such norms and make sure that we do follow certain guidelines.
So the point is, the question is, what is the recommended number of growth scans? The point is, what is the purpose of a pregnancy? What is the purpose of a pregnancy? It's to have a healthy fetus. How do you see that fetus? By doing an ultrasound scan. So why should the ultrasound scan be treated so differently? So you need scans for specific purposes in pregnancy. First scan at 6 to 8 weeks to establish intrauterine pregnancy, viability, number of fetuses. That's it. And the dating of the pregnancy. Next scan between 11 and 14 weeks for first trimester screening, establishing anatomy, doing the preeclampsia screening. Next scan around, if you are confident, then just do it around 22 weeks and do one scan and finish it off. But all obstetricians get hyper by 16, 17 weeks and send the patient for an anomaly scan. Now, 16, 17 weeks is not a great time to see everything. So you need to again see around 20, 21 weeks to not miss what Dr. Sudeep said, that PA, PVC and all those things at that point. So 22 weeks, once you have seen, you need to see one growth at least around 28 to 30 weeks. And now that you have late onset IUGR, you need one more around 34 to 35 weeks. So at least 2 growth scans. If cost is not an issue, if outcome is a very important thing, which I think is important for all of us, then I would suggest 4 to 6 week scans in the third trimester. Because a patient who cannot afford a scan today can definitely afford a lawyer to come back to us. So there is no need for us to think about why they cannot. You advise, if they don't do, it's their problem. It's a very transient difference. It's not such a big difference that it has been documented in evidence. Sometimes what madam is asking is interpretation of Doppler after giving the steroid. We know that steroids are fight, flight, and flight molecules. So when we give the steroid, we sometimes see a transient improvement in the Doppler. That's not a problem. Anyway, we have to wait for 28 to 48 hours. After that, it will usually revert to its original state. It seldom happens that it completely reverses.
It's only a feel-good feeling for some time.
Thank you.
So we'll take more questions in the break time.
With that, we thank the speakers for the first module on fetal medicine for beginning the show. Big round of applause to Dr. Shilpi Reddy, Dr. Kirti, and Dr. Sudhi. The mementos will be distributed in the outside the hall, beside the banner. So for the interest of saving time, we will move ahead with the session. And we now have a brief lamp lighting before we go on to the next module on medical complications in pregnancy. I kindly request our Chairman and Managing Director, Dr. Bhaskar Rao sir, to come over to the stage. Dr. Sudhi, Regional Medical Director. I'm not sure if Dr. Sudhakar is here. We also request Dr. Ravi Kumar Alluri sir, Head of the Department Cardiology. Dr. Shilpi Reddy ma'am, Head of the Department of Obstetrics Gynaecology. Dr. Chinmay Rath to also please join us for the lamp lighting.
टीवी बैठ जाके जानते ही
Thank you, everyone. May I now request Bhaskar Rao sir to please share a couple of words.
Good morning, all of you. I've come here not to give any lecture. Rather, I thought Chinmay already said any meeting I'm coming that I should learn something. Here, two important things I learned. One, previously we were thinking about the entire birth will be taken care by only one person. Today, it is going to be a team of people. Two important aspects here is one, to protect ourselves. Second, to protect the baby. The day when we are able to think this way, then we don't have any problems going to the courts or medical legal issues doesn't come. Even if it comes, it is the Doppler person will be able to bear on that. So she should be very, very careful about what the diagnosis that they are going to get. When you want to go into a teamwork, there is one problem we all face. First thing in our mind comes, if I refer to a patient to a team people, they think that we lose the patient. It is a very, very a myth. We always call one word called ATR, action taken report. That means whenever any number of patients you refer for a high risk pregnancy for a reputed institute with a team people, and how many people you lost, if you're able to follow 1 or 2 years, then you know that is a myth. So that actually it improves our practice drastically. These patients will be able to go and convey or market you that if I go there, I'm very safe. If she can do 100%. If she can't, she will take the help of other people. That is the concept that we all should be able to build. With this note, I practiced the same thing since I started my practice as a cardiac surgeon. That's why I could be able to grow so much. The example is, when I started my practice, when I patient refers to me to the cardiologist. Few of my initial cardiologists told me, you have to send it back the patient to me. Then I took it as a very positive note. Afterwards, most of the times, many patients doesn't know that I'm a cardiac surgeon. When I asked who are all the operation done, people used to say, Dr. Rajgopal Raju, Dr. Dayasagar Rao. Hardly I see these patients except during the theatre. Maybe one or two post-op reviews. That gives me immense strength to do my entrepreneurial journey. So that the entire burden of pre-op, intra-op and post-op is taken care by, and follow-up is taken care by my cardiologist, including the intensive care. They used to come and rounds, all these things. So I have a lot of free time. With that free time, what else I should do? That's why we started. I used to operate in every district hospitals and come back to Hyderabad and 3-4 surgeries. So that's why the entire teamwork is more important. Ultimately, the outcome of your patient should be much, much superior than you do alone. One. Second important thing is the medical legal issues will not come. Third important thing is when you refer to a patient of a team who are being expertised in that, you enrich your knowledge so that it will be useful for the next patients to follow. That's how we need to be able to improve our communications and improve our knowledge so that ultimately the entire benefit goes to the patients. Once again, thank you very much for all the three speakers enlightened very well about the significance of the high-risk pregnancies, the importance of the pregnancies, how we need to be able to tackle, and that's the reason the Shilpi and Aparna was telling about the entire team of KIMS Cuddles and all specialists we involve, so that the way it is going to improve the quality care of the high risk and obstetrics, so that we can able to prevent infant mortality and maternal mortality. That mortality sometimes will take off at least 6 months or 1 year of our age, and the mental peace, if you don't, for a small things, if you're able to compromise yourself or neglect yourself. Is the most important things which I learned from this. I think I will want to convey to you. And again, I congratulate the entire Cuddles and the NNF Telangana, who has been conducting this type of conferences that will be able to enrich. And that too, especially on Sunday, so many female people have come. It is the greatest. And very, that means I can able to understand the amount of enthusiasm that you people have to improve the quality care in this field. Thank you very much.
Thank you, sir. Your words of encouragement have driven us a lot for doing CMEs like this. And at this moment, I sincerely thank the support and cooperation from the Kondapur team, operations team headed by Dr. Sudhir, assisted ably by Bernard, Dr. Sudhakar and Rohini for helping us pull off this huge gathering. We anticipated an initial registration number of around 70 to 80, but we ended up with 157 registrations, despite closing registrations 48 hours before the CME because of the unexpected response. And even last night we had a lot of calls and we had to make some special arrangements to accommodate more delegates within this hall, and we have made a standby hall where the sessions are being relayed live, where the audience can also interact back with the speakers connected through live conferencing. So thank you very much, team, without whom we could not have pulled it off. We'll move ahead with the next part of the segment, for which we take great pleasure in inviting the two senior chairpersons, Dr. Ravi Kumar Alluri sir, head of the department cardiology, and Dr. Papa Rao sir, who was internal medicine chief at KIMS Hospital, Kondapur earlier. Currently is heading the department of internal medicine at Citizens Hospital. We request both of you to please take the chairs here, sir, and to kindly introduce the speakers. I'll introduce both of them. Dr. Ravi Kumar Alluri, sir, is heading our cardiology department. He's been leading this department through excellence and has performed over 4,000 coronary angioplasties. including some very complex procedures. Dr. Papa Rao sir needs no introduction to most of us, a great academician and head of Department Internal Medicine at Citizens Specialty Hospital. He has received Special Appreciation Award for his services in the field of medicine by St. John's Ambulance Services, honored by the Governor of Andhra Pradesh. I'll pass on the mic to both of you, sir, to begin with the sessions and to introduce the first speaker, Dr. Aarti Bellari, to speak on gestational diabetes complicating pregnancy.
Morning to all of you. There is Dr. Aarti Bellari. She is a well-known physician here. And she has, for her achievements, fellowship in gestational diabetes, fellowship in geriatric medicine, and fellowship in advanced metabolic diseases, etc. So now we want to utilize the fellowship in gestational diabetes. She is going to talk us on gestational diabetes and the management. Thank you.
Yes. Good morning, everyone. Thank you so much, Dr. Papa Rao sir, I'm so delighted that you're here. Dr. Ravi sir, to have both of you as chairpersons, I'm truly honored. And thanks, Dr. Aparna, for having us included in neonatology CME. So this is a very, like I said, I've done a fellowship in gestational diabetes, and this is very close to my heart. One, I take this as an opportunity because there are a whole lot of obstetricians and gynecologists here. So gestational diabetes, one disease, two lives at stake. And this is my own selfish reason why I would want the gynecologists and obstetricians to know here what I'm talking about. So from almost 1960s, we have been talking about fetal origin hypothesis. There has been a lot of studies over, evolution, the new science of fetal origins. So this was published in the Time magazine in 2012, how the first 9 months shape the rest of your life. As a physician, I would like to take you through a journey that is how a fetal, the baby when it is born, or within the intrauterine environment when the baby is in the womb, how it's going to shape its thing later, much later in life, like, whether it's going to become a diabetic, whether the child is going to develop a metabolic disease, whether the child is going to develop autism, lot of things. So this new science of fetal origin, this study was sort of, evolved through ages. So initially what they saw was there was only maternal malnutrition, which could lead to low birth weight, and that low birth weight child could go on to develop few issues. But now the focus is mostly on the intrauterine environment. That means at 10 weeks, what could be the way that the child could go on to develop a disease, or at 12 weeks or at 24 weeks. So the fetal origin hypothesis has led to such an evolution that not just the baby born, but we are talking about the next generation epigenetics. That means the intrauterine environment, if you're going to control your intrauterine environment with good food, pollution less, less noise, a lot of things. If the baby is born in a healthy intrauterine environment, we have the power to change the epigenetics, that is the DNA of the future generations. That means if there's a healthy baby, for a whole lot of people, then the epigenetics are better. We're going to see less diabetes later in life. So we have that kind of power in the intrauterine environment. To understand that you have a power to, save the future generations in terms of epigenetics is all about the new science of fetal origins. And one of the primary and most common is gestational diabetes. Gestational diabetes is so common, like 1 in 10 pregnancies is associated with diabetes, 90% of which are GDM. And inadequate or undiagnosed
treated diabetes, GDMs, can lead to significant maternal and fetal complications. Women with GDM and their offsprings are at increased risk of developing type 2 diabetes later in life. So this is what we need to remember. It's not just about how do we deliver the baby, how much is the baby's weight, how much is the health. We are looking at, I think, 20 years ahead. How healthy is this baby going to be? So if you develop that long-term thing of what is going to be this baby's future, then I think all the parameters, the growth scans and everything we are doing falls into place. So the problem is in India, prevalence is approximately 10%, much higher than the West. West is probably about 6%. In view of high prevalence of GDM in Indian women, Government of India had released the national guidelines for the diagnosis and management of GDM. So the pathophysiology, I think, is well known. I'll run through these slides. It's well known that GDM is characterized by hyperinsulinemia and insulin resistance. Now, both are going to happen in pregnancy. It's like a parasitic growth which is there in your body. So pregnancy itself is diabetic environment. Now you have to play through the diabetic environment there. So in first trimester and early second trimester, there is increased insulin because of high levels of estrogen. In late second and third, early third trimester, there's insulin resistance. So even though we think that post 16 or post 20 weeks, we see GDMs, we do see even in the early first trimester could be GDM and not diabetes itself. So now high blood glucose levels in mother brings extra glucose to baby, and baby, it's a simple way to just say. But what is this implication of diabetes in pregnancy? The risk of serious injury at birth doubles. The likelihood of cesarean delivery and issues associated with triples. The incidence of NICU admissions quadruples. So our idea is to sort of decrease all these risks. Now, during pregnancy, we know that there is altered carbohydrate metabolism and impaired insulin action. There is accelerated starvation. There is high risk of ketoacidosis. All these things accelerate the vascular changes. So maternal hyperglycemia, basically it causes fetal hyperglycemia, fetal osmotic diuresis, thereby polyhydramnios. So like you said, there is polyhydramnios, somebody was asking. Definitely, like we mentioned, definitely there is maternal hyperglycemia. If you measure their sugars all 6 times, you will definitely see there is maternal hyperglycemia. There will not be a normal sugars and high body weight baby. There is going to be some amount of maternal hyperglycemia. Then also this leads to decreased cortisol production, thereby decreased surfactant synthesis in lungs, leading to respiratory distress. To some extent, giving steroids at this time would help. And fetal hyperinsulinemia leading to further fetal hypoglycemia, fetal macrosomia, obstructed labor, shoulder dystocia. You all know about these complications. Now, usually hyperglycemia in first trimester is very, very dangerous because it causes impaired organogenesis, thereby leading to congenital anomalies. So for a long time, they thought if the patient was fine earlier, the sugars used to be tested only in the second trimester, beginning of second trimester. Even now in a lot of periphery centers, we see that the sugars, the basic GRBs, what can be measured is sometimes missed. So even if it is the first day of pregnancy, the patient has just had a UPT positive, it is best to know what their baseline sugars are. Because in first trimester, it does lead to congenital abnormalities. Now, chronic maternal hyperglycemia, because many patients feel that pregnancy is a time when they can eat a lot or, baby needs food, she needs food. There's a lot of myths around their nutritional levels. Added to that, the family pressure and all that. So usually if they stay in a lot of chronic maternal hyperglycemia, it leads to increased fetal oxygen demand, eventually leading to increased lactates and acidemia. So basically neonatal hyperbilirubemia, all these things are well explained. But first trimester, second trimester, frequently monitor their sugars. And the sugars need to be strictly followed. I think the fetal growth by the scans, by the percentile, we're easily able to make out based on the sugar levels. If there have been enough studies to say that if the fasting sugars are going above 92, 95, 100, then also we see that, baby's weight is increasing significantly. So to maintain sugars in a very strict fashion needs to be done. Now, who are at this risk factors? Now, this is everybody right now is at the risk of developing GDM. So age more than 25 years, BMI more than 25, increased weight gain during pregnancy, previous history of large gestational age babies, previous histories of GDMs, previous stillbirths, ethnic groups, all these patients, a family history of diabetes, family history of GDM, go back and ask if they have heart diseases in the family, diabetes of parents, aunts, uncles, you should take a detailed history. All these people are at increased risk. So, and then they have an elevated fasting sugars. And this is a challenge we face clinically also, to bring down their elevated fasting sugars. Their postprandial, we are able to control throughout the day. We are able to control by giving them a good diet plan, restricting their calories, nutritionally, we are keeping them. But when it comes to fasting sugars, it becomes a little challenge for us to control them. And babies, mothers who have higher fasting sugars end up having larger babies. So, and also this indicates, elevated fasting sugar also indicates that these patients can go on to develop diabetes in later age, even if they start off as GDM. It's sort of an indicator. If you're not able to control their fasting sugars, it's an indicator to watch them more carefully. Family history of diabetes in first degree relatives, history of metabolic syndrome, history of type 1, and any unexplained fetal loss, GDM has to be kept in mind. So these are maternal complications, I think, sort of discussed. So during pregnancy, during labor, and post-delivery, what are the usual maternal complications? During pregnancy, there can be abortions, preterm labors, preeclampsias, maternal distress, microangiopathies, large vessel diseases. So many a times pregnancy is a place where you forget about other medical complications which can happen otherwise also. So, but if the mother has GDM, she is at risk of any other diabetic related complications as well, especially considering they are in 30s. We are seeing heart attacks even in pregnancy also. So still regular medical complications also have to be considered in pregnancy too. And during labor, they have prolonged labor, they have shoulder dystocias, PPH, operative interference, increased risk of cesarean delivery. And post GDM, I think this is so common. They land in UTI, sepsis. If their sugars are not controlled, we see a lot of problems. The wound site healing doesn't happen. There's lactational failure in many patients if their sugars are not well controlled. Now, coming to fetal, I think this was all discussed earlier. First trimester, we see congenital abnormalities like cardiac diseases, sacral agenesis, PCKDs, renal agenesis, duodenal atresia, where all the specialties will be called for. But first trimester, checking their sugars and monitoring is going to prevent whole lot of congenital abnormalities. And if you see at a first trimester high sugars, please counsel them for congenital abnormalities, because many a times their HbA1cs were not checked in the first trimester. You have to be very aggressive when it comes to the sugars and blood pressure monitoring. If they develop in second trimester, of course, macrosomia is one of the fetal complications, which leads to birth asphyxias and shoulder dystocias. After delivery, of course, neonatal hypoglycemia, it was mentioned earlier also. Even the mother missing one meal could lead to neonatal hypoglycemia, increasing lactates, and intrauterine death is quite common. Yeah. This is about the classification of the Priscilla-White classification. Basically, gestational diabetes is class A1 and class A2. Class A1 is diet controlled and class A2 is medication controlled. Of course, second set of group is diabetes which existed before pregnancy. More relevant here would be diet controlled and medication controlled. Principles of management, Dr. Krishna Reddy is going to explain. But this is the general guidelines. These are the tests we do. This is over all the recommendations from the ADA, ACOG, WHO, and IADP-SG. So 75 gram OGTT. Basically, fasting sugars less than 92, 1 hour less than 180, 2 hours less than 153 is our target. Fasting sugars should be around 90 to 95 is where we keep this. So from here, I leave it to Dr. Krishna Reddy to continue the management.
CV paper. Madam.
Technologist, and he's interested more. He is from pediatric background, so he can elaborate more on gestational diabetes as well. Has many publications, he has part of investigator in many clinical trials as well. He has a lot of national and international publications. Over to Dr. Krishna, please.
Thank you. Very good morning, everyone. Right, so in the interest of the time, so I will make it more interacting, and I would like to take more questions rather than presenting a lecture. So mainly I will be focusing on what's happening across the globe, what is the newer updates and what's happening. So we'll be discussing today. So as rightly said, the diagnosis of GDM. So many bodies, different stakeholders are there giving different guidelines, different cutoffs. So what is exactly why there is so much discrepancies and so much knowledge gaps, and why we are not able to come to some single conclusion? It's mainly because there is no much randomized clinical trials done to actually exactly look at what is glucose is doing to the baby as well as to the mother. Because there is always ethical dilemma. And if you cannot keep the baby, cannot keep the mother's glucose around 120, 130 and wait for the delivery to look at the complications. So it's not ethical. So there is not much research done in the management part and the outcomes trials. So do all the GDMs are same? So definitely it's not. So there is so much nomenclature is changing day to day. So for example, if you look at the recent nomenclature, gestational diabetes mellitus, usually which happens after 20 weeks. Another thing is that diabetes mellitus in gestation, so which happens earlier, just at the time of conception, at the initial trimesters. So there's a nomenclature change. Why we need to change this nomenclature? It's mainly to look at the fetal outcomes, because if a gestational diabetes mellitus, usually it's a transient phenomena which can further progress to type 2 diabetes in the future. But if it is a diabetes mellitus in gestation, it will have a larger complications, and mostly the fetal complications will be higher, and even that congenital anomalies, everything will be higher. And regarding the cutoffs, so only one big randomized clinical trial is done. That is the HABO trial. Everybody must be knowing this trial. So around 25,000 pregnant females has been enrolled into this trial. And they have looked at the neonatal outcomes mainly, neonatal hypoglycemia, C-peptide, C-peptide levels, and what is the gestation weight of the birth weight of the child. So in this trial, there is no clear-cut demarcation where the high sugars will cause the bad fetal outcomes. What is coming, that 92 is actually an arbitrary cutoff. It's not exactly cutoff. In adult diabetics, which is actually from 126 sugars, fasting sugars, you will have a clear-cut increase in the complications of the microvascular complications. There is a clear-cut demarcation is there. So that's why from 1997, we're using 126 as an adult cutoff, type 2 diabetes or type 1 diabetes. But in case of gestational diabetes, there is a linear increase in the fetal growth, even at the sugars of 82, 80, 86, 90. So whatever the fasting blood sugars, there is a increased risk for the macrosomia. So actually there is no clear-cut cutoffs. Then Madam has discussed one case, I think, that's the last for the gestation age babe. So definitely it's a case of some amount of hyperglycemia is there to cause that type of clinical picture. And regarding the classifications, we are moving more towards the further defining the classifications. For example, recently one paper showing that the fetuses, the mothers which is on OGTT basis. So G0 means only fasting hyperglycemia. G1 is 1 hour hyperglycemia only. G2 is 2nd hour hyperglycemia. So to combine all these things, Z0 plus 1, Z0 plus 2, Z0 plus 1 plus 2. So there's a different confluences. So all which clusters I can say. So the cluster which is having a faster hyperglycemia, so there is a higher risk for the complications which they have observed rather than the 1 hour and 2nd hour higher glucose values. Right. So, and as well as another thing I want to discuss about the OGTT testing. So when you're in random sugar checking, the sugars are high, many patients will be conscious. So they will be cutting down the carbohydrates. They will be, sometimes they will be cheating. Going for the OGTT, you may not be detecting the proper diagnosis. So that's it. And also lab related issues also there. If you delay the process of the glucose testing in a sample, so you may be getting the lower values. Especially I have seen few labs which is actually giving lesser value compared to the HbA1c. Even HbA1c is also not a good diagnostic marker in pregnant women. So far, any questions regarding diagnosis or anything you want to discuss the diagnosis and how the cutoffs defined, anything?
It's your talk?
Yeah.
You can come. You can sit there. Both of you. You still have?
I just finished my
Finished.
Now come to the management part. Is mostly lifestyle management. So everybody will be know what is lifestyle. It is medical nutrition therapy as well as exercise. Exercise in pregnant women we cannot do much, even though we are doing something, but we cannot do aggressively exercise part. And regarding medical nutrition therapy, one point I want to emphasize that don't restrict too much carbohydrate, especially complex carbohydrate. You have to give to the mother. Otherwise, the baby's will get affected. As Aarti is discussing the Barker's hypothesis, if you give the maternal starvation, especially during the fetal anabolism, it will going to affect the future generations. So that way, at least 175 grams of carbohydrate should be, that too complex carbohydrate should be included in the maternal diet. Regarding metformin, so how many of you feel safe giving metformin in pregnancy? How many of you not feel safe giving metformin in pregnancy? Anybody? Right. So metformin, there's a lot of controversy, and most of the boys they will advise it as a second line medication because metformin is actually having effect at the mitochondria, the babies, even that it will cross the placental unit, so it will go to the baby. Its main effect is on the mitochondria. So most of the studies that are done with the metformin in the first trimester, especially PCOS women exposing to the metformin in the first trimester, so they actually doesn't have any congenital anomalies increase because in the first trimester the mitochondrial maturity is less. So there is no much congenital anomalies. But in second and third trimester, there is a maturity of the mitochondria and fetal effects of the metformin is seen, especially in the form of HGS. So this HGS in the follow-up trials, the 7 years, 9 years, 14 years follow-up trials, they are shown to cause excessive adiposity at the visceral point. Less subcutaneous fat, more visceral fat. So which will translate into the more cardiovascular diseases. And sometimes this more PCOS patterns in the offscripts of the GDMs managed with the metformin. As well as because of this high visceral adiposity and early more catch-up, so this will translate into the precocious puberties also. So we don't know what is happening is going to in the future because there is no good follow-up data with the metformin. So we should always conscious before giving the metformin to the babies. And Regarding glyburide, anybody has used glyburide in the diabetes? This is also approved in some countries, especially in UK and other areas. Only thing, the problem is they don't cross it because of the high protein binding, but it can cause the neonatal hypoglycemia. And any doubts in the metformin or anything? You want to get clarifications on that? So most of the studies, they have started with 500 twice a daily. They went up to 2000. Some trials went up to 2500 also.
Sustained form, not immediate release.
Yeah. So it is not FDA approved for the treatment of gestational diabetes. As well, also DCG is also not approved. But day before yesterday, we have a recommendation from CDSCO to have an approval for the metformin sustained release 500 mg twice a daily for treatment in the pregnant woman. There's a recent change. Yeah.
There are many papers, especially South African, where they have continued till up to 16 weeks. And those were the papers which have actually told that there is no role of metformin in teratogenicity. But beyond this point, I need little bit of clarification about the amount of metformin to be given to a pregnant patient, if at all we need to continue in the cases of GDM.
Definitely, ma'am. Because in PCOS, if you give metformin, after conception, if you suddenly stop it, there is a high risk of dysglycemia. So that is the reason we'll be continuing at least for the end of the first time till the embryogenesis period is over. We'll be continuing till 12 weeks or 16 weeks. But after that, you take a call based on the dysglycemia, whether to continue or whether you can just manage with the lifestyle changes, especially nutrition and other changes.
Now, if you complete the presentation, we'll discuss it.
Right. So regarding insulin, so you all know the best way is the basal bolus regimen. So there are latest insulin, second generation, third generation insulin, which are best for the decrease the risk of hypoglycemia. At any cost, you have to prevent the hypoglycemia. That is more important. And more sophisticated insulins have come. And I would like to tell you should emphasize that all your consultants discourage the practice of mixed start. It's a bad way to treat the gestational diabetes. Okay, so in mixed start, you cannot balance you cannot properly adjust the postprandial as well as the fasting hyperglycemia. So you need to give a 3 ml prandial insulin as well as 1 basal insulin to have a proper effect. Any doubts? So we can discuss now.
Please come out to the task. So basically, as we understand GDM, it is from the increase of human placental lactogen. Though they are cortisol, estrogens, so many other placental hormones, basically it is the human placental lactogen which starts producing at the 15th week of pregnancy and which is abundant from 20th week of pregnancy. That's why earlier we were thinking that GDMA comes after 20th week. Now ADA has redefined any glucose intolerance after 15th week should be considered as GDM. That's number one. And as Madam asked, the PCO, earlier there were trials whether metformin can prevent GDM. The studies have shown metformin cannot prevent GDM in any form. Basically, it is the release of human placental lactogen, which causes an effect called contra-insulin effect. Basically, this is responsible for the high postprandial sugars. Contra-insulin effect comes when it is postprandial surge of glucose levels. So, in the first absorption of glucose, all the simple sugars get absorbed and raises the blood sugar levels. That's why the role of first hour has come. Earlier, it is fasting blood sugar. Now, though there is no consensus, there had to be some guidelines. RSSDI and Indian guideline shows the target is less than 95 fasting blood sugar, 140 first hour, 140 milligrams, 130 second hour. So this first, earlier we were seeing only fasting and 2 hours postprandial. Now what is most significant is first hour it surges. That's why the role of what is the correct Nutrition also we are not very clear. Probably, as Dr. Krishna Reddy told, it is simple sugars. That is sweets, ice cream, milkshake, chocolate, biscuit, bakery, which absorbs and raises the first phase of glucose absorption. And this the high blood sugar, goes to the fetus, and fetus secretes more insulin. Insulin is a growth hormone, causes macrosomes. So any other questions to Dr. Krishna Reddy, to the speakers?
Second dose is 120. Second dose is 120.
Second dose 120. So 130, 95, 130 and 120. This is the
121.
Recommended glucose monitoring during
The best way, if the patient is high risk patients, the bestest way I can say is the CGM. So where you can see the minute differences in hyperglycemia, as that case we have seen the 4 kg baby, we can detect that. So most of the time the patients might be cheating while testing on the day of testing. So they may be showing the normal values, but other day it could be different scenarios. So definitely at least 4 times a day, ideally whole week you have to monitor 4 times a day till delivery. So that is the best way. Or else CGM, it is available if affordable. So that is the best way to monitor the patients.
I think checking the profile for 48 hours, first 48 hours, give you what is fasting, what is 1 hour postprandial, 2 hours postprandial, and also next day fasting. This gives a profile. Best is 8-point or CGM, as Dr. Krishna Reddy told. So once you get the profile, you know how much basal insulin you have to give, how much bolus you have to give each time.
Any role of combining metformin and insulin?
If at all the patient is suitable for insulin, go with the insulin first. Okay. Only in case of the metformin indication pregnancy are overweight patients who we are going to expect there is a high requirement for the insulins, and you are expecting a very large babies. Okay. And the PCOS patients who are already on metformin, you can continue them. So first choice always should be insulins.
There is also combined.
Adding up the metformin will reduce the insulin doses and maternal weight gain will be reduced. So overweight, definitely you have to use the metformin along with the insulin.
Women come with increased glycosylated hemoglobin in early pregnancy.
Yes.
So very many times it has not been detected earlier and there is say 10 or 11%.
Yes.
How do you counsel? I mean, is there any indication to consider termination of an early pregnancy just because the HbA1c is high? I want to know your perspective.
According to MTP Act, there is no indication of termination for diabetes alone. And if the only fetal malformation is detected, then only it's an indication. So most of the time, the scenario, what I see, even some people will come with a sugar of 150, 200 also fasting sugars. They may be having delivery normal babies. And sugars having a 105 fasting borderline, sometimes they may be having a congenital anomalies. So which baby is going to have going to get affected, we don't know. So many multiple players might be there, genetic players. Yes, it's definitely it's not an indication.
This is a case of diabetes, de novo diabetes started during pregnancy. Started just that coincidence.
So
detected at that time.
So what I counsel them is there is a 10 to 15% risk for the congenital anomalies. You need to control the sugars as fast as possible. Then do a TFA scan by 2 experts at least. And if the baby is fine, then go with the delivery.
Maternal hyperglycemia up to 16th week has very little effect on the growing fetus. Very little effect. So anyway, control the blood sugar levels. Fetal growth doesn't depend on maternal hyperglycemia first 16 weeks.
Somebody has said you might terminate this. Not
as of now, MTP doesn't warrant any abortion under diabetes mellitus alone.
In more than 10, there is increased risk of congenital anomalies. No.
Better than in a lot more detail. So we can even try and do
Okay.
That's why during the first visit, one has to do a blood sugar profile. The first visit, antenatal checkup.
So now we're moving towards the more of universal screening itself in the initial conception, because we are getting older pregnant women, high risk for PCOS already, family history of type 2 diabetes. Most of them are overweight and obese because Asian cutoffs for the overweight and obesity is different. I generally, yes. That's a very easy convenient for the rural population. For in urban setups, I think single step method is still the best and gold standard.
Any other questions?
Yeah, ma'am.
The last question.
Good morning, chairpersons. I'm Dr. Sarojini. So I would like to ask about insulin. Means recently that Foxy guideline has recommended the use of long-acting insulin, Glargine. That is now we have started using it. So actually I don't have experience on it. But for last 2-3 months we are using. But because I am in a medical college, so we are using. But earlier we used to do mixed and other things like human actrapid, mixed other things. But what is your say on it, sir? Can we use this long acting?
Right. So definitely, ma'am. Recently, the problem with the Glargine insulin is it has high affinity for the IGF. So IGF is actually the main important growth factor for the initial from birth in embryo to the first 2 years of life. So there is some concerns because of its maybe teratogenic or maybe that is affecting the fetus also. But most of sometimes the patients already using Glargine who become pregnant, there is no increased risk of the congenital anomalies with the Glargine.
For those patients we are continuing, but suppose the patient has not used any insulin.
So the data, based on that data, now we are recommending that Glargine is also can be initiated and can be initiated in the pregnancy itself. So Tresiba is also, I mean, that insulin degludec is also approved. So that is also you can use.
So what is the ideal time to use it? Because it is acting for 24 hours, no sir, duration of action. So either evening time or morning time.
So best is post dinner, because although they say 24 hours, it may not act for the 18 to 24 hours. The range is different, intra-individual, inter-individual variations are more. So that's why give the post dinner, because we are targeting the fasting. So if you give post dinner, the fasting sugars will be well controlled.
But pregnant ladies, they don't eat dinner properly, no sir. So when
the myth is most of the time the myth is we check the post dinner, give the Glargine. That's a very wrong way of doing it, because Glargine actually controls the fasting sugar, not the post dinner.
Okay, sir. Okay.
So you need to focus on the fasting sugar rather than on the post dinner values. So even the sugars is 100, you can safely give Glargine. It's a very slow acting. So it will take care of the fasting sugars.
So whenever I have referred to physician, they have already usually advised to take a dinner, post dinner. This long acting.
That is the standard.
So I had doubts, sir. Okay.
No, basically, insulins are two types. One basal, which are 24 hours. The Detimer is the choice earlier. Now even Glargine and degludec are also approved in pregnancy. Other is short acting, which comes under which rescues the postprandial, which is most important, because human contra-insulin effect is maximum with postprandial blood sugars. So there have been short acting like Lispro and human mixed compared. Lispro was superior, and even ultra short acting Fiasp has come now. Fast acting insulin aspart. This is more suitable if the blood sugar levels are high in the first hour or second hour. So combination of these two ideal, as Dr. Krishna Reddy told, it is basal and bolus. If the fasting is high, you start on a small dose of basal insulin. If the fasting is not high, only postprandial elevations are there, give only short acting or ultra-short acting.
And then
along with medical nutrition therapy.
Then after giving insulin, means how many times we should monitor the blood glucose? Is it 7 times or just 3 times enough?
What I usually do is I'll look at the OGTT. So whether first hour value is high or second hour value is high. So based on that, I will monitor fasting sugars either 1 hour or second hour. If there's still the fetal macrosomia is there or fluid is higher, so I will make it more 1 hour, second hour, 1 hour, second hour values also I need to, I have to check. Or CGM is the ideal.
Routinely, when the patient is
Routinely.
already admitted in the hospital.
Right.
So should we do those 3 times daily or
4 times.
4 times daily?
Yeah, I think we are running short of time.
Okay, sir.
Dr.
Okay, thank
Krishna
you, sir.
Reddy will take
Thank you so much, sir. Yeah.
questions during lunch hour. Over to Dr. Aparna.
For the next session, we invite Dr. Ramya, who is our critical care specialist. She's going to be talking on hypertensive emergencies during pregnancy. All our speakers are going to be available until lunchtime. So we request the speakers to reserve some of your questions for the want of time. You can discuss it with them during the lunch hour. I hand over the mic over to the chairpersons to introduce Dr. Ramya.
Dr. Ramya, I have been associated with her. She is a brilliant critical care expert. And she is now working as senior consultant in critical care medicine in this hospital. She is a gold medalist with over a decade of experience in critical care medicine. She has indexed the published journals in national repute. She is a faculty in various state and national conferences. Over to Dr. Ramya.
Thank you, sir. Thank you for the kind introduction. Thank you, organizing team, for making me a part of this CME. Good morning, everyone. Today we'll discuss about one of the most critical issues in the pregnancy, which affects both the expectant mother and the fetus as well. So over the next 15 minutes, we'll be discussing about what is the nomenclature for the different different hypertensive disorders in pregnancy and the risk factors associated and the potential outcomes, and also the latest management strategies by which we can improve the outcome of both the mother and the fetus. So why is it so important? Because it's one of the leading cause of maternal mortality globally, secondary to obstetric hemorrhage. And despite advances in the prenatal care, they pose significant challenges to both mother and the fetus. And these can lead to serious complications if not identified and managed properly. So timely diagnosis and optimum management can prove vital in preventing the long-term multimodality. So the spectrum involves the chronic hypertension, gestational hypertension, preeclampsia, eclampsia, and preeclampsia superimposed on chronic hypertension. So what is chronic hypertension? This pregnant patient is already a more hypertensive patient, and now she becomes pregnant. Oral hypertension is diagnosed before 20 weeks of gestation. That is BP, systolic BP of more than 140 and or diastolic BP of more than 90 mm of Hg. And if it is diagnosed de novo, this is diagnosed de novo during the pregnancy before 20 weeks of gestation, it persists for more than 12 weeks post-delivery. What is gestational hypertension? This is new onset of hypertension, that is SBP of more than 140 mm of Hg and or DBP of more than 90 mm of Hg, or at least 2 occasions 4 hours apart, that is detected first time after 20 weeks of gestation, and there is no proteinuria and no target organ involvement. Whereas preeclampsia is diagnosed hypertension after 20 weeks of gestation in a woman with previously normal BP. We say it as severe preeclampsia when the BP is more than 160 by 110 mm of Hg. Along with that, we should have either proteinuria or target organ involvement. Priorly, it is assumed that preeclampsia is always associated with the proteinuria, but now without proteinuria also, if the target organ involvement is present, we can label it as preeclampsia. So how do we quantify proteinuria? It is more than 300 mg for 24-hour urine collection, or protein creat ratio of 30 mg per millimole, or dipstick reading of 1+ and albumin creat ratio of 8 mg per millimole. And what are the target organs we need to look for in the absence of proteinuria? Thrombocytopenia, platelet counts less than 1 lakh, the creatinine of more than 1.1 milligram per deciliter, or doubling of serum creatinine concentration in the absence of other kidney diseases, elevated transaminases twice the normal concentration, pulmonary edema, and new onset headache and visual symptoms which are not responsive to medication and not accounted by alternative diagnosis. So what is preeclampsia superimposed on chronic hypertension? The name itself says that the patient is already a known chronic hypertensive patient and the preeclampsia is superimposed. Means there is increase in the requirement for the antihypertensive drugs, increase in the need to escalate the antihypertensive therapy, and there is new onset of proteinuria or target organ involvement consistent with the preeclampsia after 20 weeks of gestation. So I'll not go much into the pathophysiology of preeclampsia, but the main thing I want to highlight here is we all know that there is defective cytotrophoblastic invasion into the spiral arteries. But there are other roles, other factor roles also which are involved in the pathophysiology, like autoimmune components where the maternal intolerance to the placental and fetal antigens, and also the imbalance of the angiogenic and anti-angiogenic factors, which all lead to the endothelial dysfunction, leading to vasospasm and end organ damages. So now that we have discussed the nomenclature and also the pathophysiology, let's see how do we manage these patients. So coming to the chronic hypertensive patient, whenever chronic hypertensive patient presents to us, if she is planning a pregnancy or if she becomes a pregnant, first we have to review the antihypertensives, because if she is using any ACE inhibitors or ARBs or diuretics, we have to stop them because of their teratogenic effects, and we have to switch her to the newer alternatives of antihypertensives. And as she is chronic hypertension, there are chances that there is chronic end organ dysfunction might be present. So we need to do certain tests like ECG today to see for any concentric LDL changes. We have to get her retina checked to see for the hypertensive retinopathy changes, and also to get an RFT done and check for the proteinuria. So the safer antihypertensive agents would be labetalol and nifedipine. And what should be our target of BP? It's like 135 by 85 mm of Hg. And now that we know that this chronic hypertensive patient may progress, she's the highest candidate for progressing into preeclampsia. So we have to do the enhanced first trimester screening, which includes the history, body mass index, mean arterial pressure, uterine artery Doppler, and double marker test plus placental growth factor to calculate the risk of preeclampsia. And if she is found to be high risk, we have to start aspirin 150 mg till 36 weeks. And how do we ask her for the antenatal visits? We have to plan, if the BP is well controlled, ask her to come every 2 to 4 weeks. And if it is poorly controlled, antenatal visits should be scheduled weekly. And the timing of birth is after 37 weeks, unless and otherwise there are other maternal indications or other indications for the ending the pregnancy. So how do we monitor in the postnatal period? How do we monitor the BP? Daily for the first 2 days after the birth, and between 3 to 5 days at least once. And if there is new change in the antihypertensive, any changes in the antihypertensive treatment as clinically indicated, we need to monitor. And we have to get the antihypertensive review. If she is on methyl dopa, avoid methyl dopa because of the postural hypertension and postpartum depressions and headaches, which can be confusing with the eclampsia. And the antihypertensive treatment has to be reviewed at 2 weeks and 6 to 8 weeks with the general physician. Now coming to the gestational hypertension, how do we manage the gestational hypertension? As we all know, gestational hypertension is new onset pregnancy, new onset hypertension in the pregnancy after 20 weeks without proteinuria and target organ involvement. We have to start the safer antihypertensive drugs as mentioned. And the timing of birth is usually after 13 weeks, as long as the blood pressure is less than 160 by 110 with no other medical indication. And the postnatal management is similar to the chronic hypertension, that is BP has to be monitored daily for 2 days after the birth and at least once between day 3 and 5. And as this is gestational hypertension, post-delivery, the BP can normalize. So the reduced antihypertensive treatment if BP falls below 130/80, and review the antihypertensive treatments at 2 weeks and 6 to 8 weeks after the birth with the GP. Now, how do we manage the preeclampsia? These are the risk factors. I'm not reading it out loud. You can refer it later. So there are non-modifiable and modifiable risk factors. And whenever there is fast exposure to chorionic villi, superabundant exposure to chorionic villi, and the history, all these are the risk factors for the preeclampsia. So how do we manage? So if at all the patient is having at least one high risk factor, these are the mentioned high risk factors. All the 2 moderate risk factors, this patient is potential for developing the preeclampsia. So to prevent that, we give antiplatelet agents 150 mg aspirin daily from 12 weeks until 36 weeks of gestation. So this is a tabular form for the management. So in gestational hypertension, and this is the preeclampsia and the preeclampsia with severe features. So admission to the hospital is usually not needed in the gestational hypertension, but in preeclampsia, if the clinical concerns or the risk model shows high risk, we need to admit, and preeclampsia with severe features, we admit all the patients. And the target for the BP treatment is BP more than 140 by 90, and the target BP is target for less than 135 by 80. And The BP has to be measured once or twice a week in gestational hypertension, whereas in preeclampsia every 48 hours or more frequently if the patient is admitted. Whereas preeclampsia with severe features, we have to measure the BP every 15 to 30 minutes until the BP is less than 160 by 110 mm of Hg. And the dipstick proteinuria in gestational hypertension is done once or twice a week, whereas in preeclampsia and preeclampsia with severe features only if clinically indicated. And the blood tests like CBC, LFT, RFT are done in gestational hypertension weekly, whereas in preeclampsia it's twice weekly, and preeclampsia with severe features it's 3 times a week. So the timing of birth usually 37 weeks onwards, but in certain conditions, we plan the birth early before 37 weeks, especially if we are unable to control the maternal BP, despite using 3 or more classes of antihypertensive drugs in appropriate doses and dropping saturations and progressive deterioration in the laboratory tests and clinical features, abruption placenta, and when the fetus is at compromise. And when we are planning the delivery preterm, offer antenatal corticosteroids and magnesium sulfate in preeclampsia with severe features. So how do we monitor intrapartum? During the labor, we have to monitor the BP regularly, every 15 to 30 minutes until the BP is less than 160 by 110. And do not preload the woman with severe preeclampsia because there is a chance that she might land up with pulmonary edema. So the antihypertensives which we use in emergency are IV labetalol and oral IV hydrolysine and oral nifedipine. So these are the drugs which you can refer later. So I want to just emphasize that labetalol, if we are giving infusion, the maximum dose can be 1 to 2 mg per minute, and it is started at 10 to 20 mg IV and then increased at gradual intervals to a maximum dose of 300 mg. So, as this is a preeclampsia patient, consider reducing antihypertensive if the BP falls below 140/90, but we have to definitely reduce the antihypertensive if BP falls below 130/80, and the medical review at 2 weeks and 6 to 8 weeks. And if the patient is having persistent proteinuria at 6 to 8 weeks after the birth of normal RFT after 3 months of delivery, then refer her to GP or nephrologist respectively. I'm skipping the eclampsia because of the time constraint. Thank you.
Please come sit down here, Dr. Amir. Next, we have our beloved cardiologist, Dr. Shilpi Reddy, to talk on pregnancy and valvular heart disease. He doesn't need any introduction, so I bypass the introduction.
We also would like to involve Dr. Shubhya as one of the chairpersons. Please join the stage. Dr. Shubhya is an expert in high-risk obstetrics, and she works at Vignesh Nursing Home. She has done her high-risk obstetrics fellowship from Fernandez, and thank you, Dr. Shubhya, for joining the panel. Over to Dr. Shubhya.
Good morning, all. Thank you for giving this opportunity. So today we'll be discussing about valvular heart disease and pregnancy. I'll try to keep it brief. So as we know, probably in pregnant women, we say around valvular heart disease in around 1 to 4% of the patients. We being the rheumatic heart disease being very common, even though as time is passing on, we're seeing very few cases, but still the prevalence of rheumatic heart disease is still very much in the rural area. So we end up seeing a significant amount of valvular heart disease. And also congenital heart disease, such as a bicuspid valve, which would cause these things. So why do we need to consider cardiac in pregnancy? Because a lot of hemodynamic changes which occur during pregnancy. Firstly, the plasma volume increases. So it starts increasing by the first few weeks, and by the second trimester, it increases to about 50 to 75%. Because it has to meet the great circulatory demands of the placenta as well as the maternal organs. Similarly, to compensate, the erythropoietin also rises to increase the red cell mass, but it's only by 20 to 30%. So we have a relative dilution. So what is called as anemia, physiological anemia in pregnancy. Similarly, during the pregnancy, the systemic vascular cells drops. First, to increase in plasma volume, it has to be. So there's some vasodilatation, also vascular remodeling. The HbF starts decreasing the first trimester and falls by 25 to 35% in the second trimester. This is potentiated by the progesterone and the estrogen-induced vasodilatation. And also the uterine blood flow increases in placental growth, and this is fall in blood resistance. So this all contributes to the fall in systemic vascular resistance. So this starts in the first trimester and probably peaks by the second trimester and plateaus after that. Consistently, so there is an increase in cardiac output, both to meet the maternal as well as fetal demands. So the increase by around 50% during the pregnancy. It starts by 5 weeks and peaks at around 80 to 24 weeks. In between gestations, it might go as low as 75%. So what we see is that this cardiac output is not entirely achieved by either stroke volume or heart rate. So cardiac output, the stroke volume increases, but there is also increase in the heart rate of 10 to 15 beats per minute by the trimester due to the increased sympathetic system, which causes the increase in the cardiac output. So to briefly say, the plasma volume increased by around 50%, which is which causes an adaptive decrease in systemic vasodilation of 25%, and the cardiac output increased by 50% by around the second trimester. And what we also consider is not only pregnancy. There are a lot of changes which occurs during labor and delivery. So during the labor, there are abrupt hemodynamic changes which we see in the labor. What we see is that during labor and immediate postpartum, the maximum cardiac output is safe during pregnancy. Similarly, during labor, patient who has repeated valves of madness, very too much of fluctuation in cardiac output. It might go as high as 10 liters, and also the preload also might suddenly drop. And we have to understand that each uterine contraction displaces about 300 to 500 ml of blood back into the maternal circulation. Apart from that, pain and anxiety, which causes tachycardia, vasoconstriction, causes a lot of changes in the cardiac output as well as blood pressure. So, and what also immediately after the delivery, once the gravity uterus is removed, there is a release of compression of the IVC. So there's a lot of blood which is released back. The preload increases, auto transfusion occurs. So a lot of hemodynamic strain on the heart. Similarly, normal vaginal might have an approximately 400 blood is lost. In cesarean section, it might go to as high as 800 ml. So there is some amount of hypovolemia which is induced. So these fluctuations can cause a lot of trouble to patients with lateral disease. And this is the time where most of the people can go into pulmonary. And most of the changes usually settle down by 2 weeks. So what we have to understand is that seeing these hemodynamic changes, stenotic valvular lesions all carry higher pregnancy risk when compared to resistant lesions. The reason because as the gestation increases, the cardiac output is increasing, which increases the transvalvular gradient, and therefore the upstream pressure starts increasing. And also, there is a fall in peripheral vasculature, which we have known will cause fluid retention and volume expansion, which is more marked, especially with stenotic lesions, and because they will not be able to respond to the pressure drop with increase in cardiac output, because of stenosis, they can't respond. So definitely, they'll have more fluid retention and volume expansion. And also, tachycardia, which starts in the second trimester and goes on to the third, and also which increases further during delivery, will cause a lot of problems for stenotic because there's less time filling for the left ventricle to fill, and there's not adequate diastolic filling. So definitely stenotic lesions are very bad, especially during pregnancy. Regurgitant lesions, because there is afterload reduction and also tachycardia, there is less volume load on the LV. So most of the regurgitant lesions are good and probably will not cause much of the problem during pregnancy and during delivery and labor. So as consequence of these changes, most of the stenotic lesions will cause shortness of breath, heart failure, and arrhythmia in these most of these patients. So now we know that patients have varied valvular diseases, various problems, and we know what the pregnancy-induced hemodynamic changes are there. So how do we risk stratify? I mean, how can we differentiate these patients? Who is going to be land in trouble? Who is going to do good? Where the fetal issues are not there. So during course of time, many scoring tools have been identified. The first one, CARPET, which was identified in 2001. This was from the Canadian registry. This had 4 risk factors, one for each factor. So 0 points had a risk of 5% maternal risk, greater than 1 point as a risk of 75%. But it was very broad. It was not able to give a very clear cut. So next came the Dutch study from the Dutch, this thing Zahara. So this was a much more comprehensive, considering 8 factors. This was out of a ACH registry. It is adult congenital heart disease registry. So probably this had a better role. Then going down, there was CARPET 2, which include another 4 criteria. But again, these are all risk scores. These they help you much, but they don't give you a specific indication what to do and what not to do. So WHO came with a modified WHO risk stratification tool. This is a disease-specific classification. So it is not a risk score, but is a risk stratification tool where different diseases, depending upon the severity, the intensity, are stratified into 4 categories. The one category is one which is the least risk, 4 is the one which is the most absolute risk. So to say examples, mild pulmonary stenosis, small ASDs, small VSDs, small PDAs, mitral valve collapse with minimal MR, successfully repaired shunts, ASD, VSD, PDA, all considered WHO1 criteria. These only need to be reviewed once or twice during their pregnancy course and can be delivered at a local hospital. No risk is much required. WHO categories are unrepaired, moderate to large size ASDs or VSDs, repaired tetrajet pallets, Turner syndrome without identification. Again, every trimester, probably 3 visits are good enough for these patients, can be delivered at local hospitals. Then comes category 2 to 3, 3 and 4, which are increasing severities. Probably you can take note of these things. I'm not going to details. What we need to understand is category 4. Conditions where pregnancy is not recommended. Pulmonary arterial hypertension, severe systemic ventricular dysfunction, moderate right-sided ventricular dysfunction, severe mitral stenosis, several symptomatic aortic stenosis. We have to remember, not aortic, simple aortic stenosis. It is severe symptomatic aortic stenosis. Asymptomatic aortic stenosis goes into category 3. So probably that still can be these things. Severe aortic dilatation, vascular Ehlers-Danlos, severe recoaptation, and Fontan's with any complication is considered as category 4. So what we have to understand is that when considering Marfan's and bicuspid valves, aortic dilatation is also very significant. In a Marfan's, aorta more than 45 mm and in a bicuspid more than 50 mm, again are considered as a highly risk categories. These have to be followed rigorously. The patient has become pregnant and probably has to be facilitated at a center where you have facilities to handle these cases. So again, newer strategies are coming where they take the initially categorize the patients by modified WHO criteria, then use the CARPEC2 criteria to differentiate. But what we have to understand is that most of them are based on ACHT, but not on valve. We Indians face a lot of valvular disease compared to other entities. So Indians have come with a new score, that is Devi score. This is a valvular heart disease specific score. It has around 8 factors from which it can categorize. So severe mitral stenosis +4, moderate stenosis +2. So probably this was across few studies has shown that probably this is more helpful in risk stratifying the patient for further. So to briefly summarize, we take MWHO classification, categorize the patient, and to probably further stratify, we can use either CARPEC2 score or Davis score to categorize these patients. So this other slide, this goes on to show that any patient with severe mitral stenosis, severe symptomatic aortic stenosis, any pulmonary arterial hypertension, severe systemic ventricular dysfunction that is less than 30%, or NYHA class 3-4, considered as class 4. So we'll go to the individual walls. What individual lesions, what happens with each lesion. So mitral stenosis, mild, with the mild MS with area is more 1.5 centimeters. Asymptomatic, low risk, nothing much to do. Moderate to severe. Patient is moderate to severe mitral stenosis. She's planning for pregnancy. Patient is amenable to PVMB or pelvic valvotomy. First do the valvotomy, stabilize the patient, and probably then she can plan a pregnancy as early as possible after the PPM. But patient present to us with moderate to severe MS, then the chance of mortality is high as around 3%. They might develop heart failure, they might develop arrhythmias. And the more problem with the fetus, 20 to 30% will have prematurity, intrauterine growth retardation seen around 5 to 20%, stillbirths around 1 to 2%. And so these patients have to be carefully monitored. Beta blockers are the first choice. Metoprolol is the choice because it's a beta-1 selective. It doesn't have much effect on the uterine contractions. Diuretics, if patients are symptomatic. Furosemide and torsemide both are recommended, can be used. Aldactone has not to be used in these conditions. Suppose patient develops a digoxin, still can be used. Again, beta blockers are the first choice. And these patients, if they are not have any clots, probably can undergo cardioversion because cardioversion is extremely safe in pregnancy. Suppose if the patient is still symptomatic, probably in the second trimester or starting the third trimester can undergo percutaneous mitral commissurectomy, especially if the functional class 3, 4 of the PA patients are more than 50, they can be done successfully. My research topic was pregnancy, PTMC in pregnant ladies. And I think we had a very large data from Sri Chitra. It's extremely safe, can be done safely at second trimester. The outcomes are very, very, very good. Coming to aortic stenosis, symptomatic aortic stenosis, again, they're very high risk. Asymptomatic need to be followed. Again, these patients need to be, the blood pressures needs to be controlled, the rates have to be done. Third is pulmonary stenosis. Pulmonary stenosis is rare, but the only thing with pulmonary stenosis we have to depend is pulmonary stenosis doesn't occur in alone. The main problem with pulmonary stenosis is recurrence. If we know NANS, the patient is a known NAN, has pulmonary stenosis, the chance of recurrence in the children is 50%. Without no NANS or anything other, still the risk chance around 3 to 6%. So when we're dealing with pulmonary stenosis, even though it's rare, probably we need much more multidisciplinary approach to these patients. Most of the pulmonary stenosis patients, unless and until they have RV dysfunction, do well, very good in the pregnancy. Similarly, tricuspid stenosis is rare, mostly associated with rheumatic heart disease. Again, most of the times we might not see isolated stenosis. And most of the times it might be just present during pregnancy only because of the increased gradients and increased right-sided heart flow. And most of these patients do good and probably unless it needed, we might not need to intervene. Coming to registration regions, mitral, aortic, registration, tricuspid, unless until they have ILV dysfunctions and RV dysfunctions, most of them are well tolerated. Only thing is that we can use nitrates and hydralazine for these patients, especially with aortic registrations, to decrease vascular resistance or probably decrease the afterload in these conditions. Secondly, tricuspid registrations. Most important thing is prosthetic valves. Pregnancy is a prothrombotic state and is to increase the valve thrombus in patients with prosthetic heart valves. Therefore, this becomes a very challenge. With so much of rheumatic heart disease, probably we see a lot of patients with prosthetic valves who land up with pregnancies, and how to balance it is the most difficult thing. Warfarin has been our gold standard for anticoagulation throughout the years, but main problem with warfarin is embryopathy. So when used within 6 to 12 weeks, causes embryopathy, which consists of nasal hypoplasia, stapler epiphysis, and coronal atresia. Late exposure is associated with central nurses abnormalities and intracranial hemorrhage. Most common fatal event is miscarriage and fetal demise. Warfarin has a dose-dependent effects. Less than 5 mg has less side effects compared to more than 5 mg. So the problem, the discussion comes, is warfarin good or low molecular heparin good? This slide clearly tells what happens with each. Suppose a patient has been using warfarin throughout the pregnancy. So the maternal mortality and thromboembolism maternal outcomes are very good. 0.9% maternal mortality and thromboembolism 2.5. But we see the live birth ratio is only 64.5. Suppose if you use low molecular heparin alone throughout these things, the live birth rate is around 92%. But what we see, the maternal outcomes, thromboembolism is around 10%. So low molecular heparin, even though it is good, especially in high-risk patients, the chance of thromboembolism and maternal risks are very high. So sequential treatment with warfarin and anticoagulation can be an alternative, wherein the live birth rate is around 80% and the thromboembolism comes up to 5.8%. Sir, please conclude. Yeah. So anticoagulation strategies, once the patient is diagnosed between 6 to 12, try to avoid warfarin. After the restart warfarin, again before 36 of pregnancy. Antenatal cardiology follow-up, the frequency depends upon these things. Basically low risk, maybe once or twice, but moderate receiver lesions probably every trimester visits are needed. And valve surgeries and interventions can be planned very well in the surgery during the pregnancy. Labor and delivery management, vaginal delivery is the choice, unless until it's an obstetric needed, because it's only the patients with moderate or severe probably will need some help during the second stage of labor to decrease the strain or defect the valsalva. Cesarean delivery should be for those severe heart failure, high risk diabetes, and severe form of hypertension. And probably warfarin has to be stopped at least 36 weeks. Heparin has to be ceased 12 hours before. Endocarditis prophylaxis, no endocarditis prophylaxis needed for vaginal or cesareans, because as cesarean you will always be giving antibiotics. As per this, no specific recommendation for endocarditis. Thank you.
Thank you very much. Dr. Shyam. So not to understand too much about that, anyway, we'll refer to either Dr. Ravi or Dr. Shilpi. Next, we have Dr. Abhinay Kulche. He is a brilliant neurophysician working in this hospital, and he is going to talk about stress syndrome. Dr. Abhinay.
Very good morning. So when I reached the hospital, the security person asks me, he doesn't allow me to go to the parking, and then he says that the parking is full. So then I ask him, I have to go to this conference. Arey sir, wo to mother or baby ka conference hai. Aap kya kar rahe hain wahan? So then I tell him that, there's some pressure on the mother's brain and on the baby. So I'm going to release that pressure today, and my topic is stress. So what's going to be my agenda for today? What's in a name by Shakespeare? There's a lot in name, is what I feel. And then I'm going to tell you why. I'm going to also touch upon the clinical and the radiological aspects. Why does stress happen? That's the pathogenesis. And obviously treatment and what's the outcome. So I always like to mention a few real life stories, because my boss has always mentioned that, stories stick into the mind. And that is how we've been trained in neurology as well. My bosses used to tell us a lot of stories. And I start with my first real life case vignette. And this is a 34-year-old lady, and she underwent a cesarean on 4th of January last year. This was outside, not here. And then 9th January, she woke up and she had a terrible headache. Such headache that she was saying that my head would burst. And then she visited a local physician. Blood pressure was slightly high, 150 by 90. But then the headache relieved within an hour or so. So, she carried on. And another week later, on 15th of January, she again started having a terrible headache. And this time, the headache did not come down. And as you all know, I have seen this trend wherein, headache, and then they first go to the eye doctor, not the head doctor. And she obviously visits the eye doctor, and the eye doctor does a detailed examination, including a fundus examination. And you can see that here, the fundus is showing swelling. We call it papilledema, which means there is high pressure in the brain. And she was admitted under the physician, and the physician involved me. And she had already undergone a CT scan, which was normal. So the job was difficult for me. So obviously, I examine her first. I don't resort to a scan immediately. I examine her. She's okay. She's in pain, but she's in her senses. She's oriented, and there was no focal neurological deficit. And a CT scan had already been done, and the blood pressure was not very high. With a small dose of an antihypertensive, she was doing okay. So how do you approach a lady in the peripartum or postpartum with a severe headache? And the protocol is, we resort to an MRI scan, and we do two particular sequences. We have to check the veins and we have to check the arteries. So in the peripartum period, press is all about the blood vessels. Just remember this fact. It's all about the blood vessels, and there are two types of blood vessels. That's the veins and the arteries. So this was the venogram. Because one of the differential diagnoses is also cerebral venous sinus thrombosis. And the venogram was perfectly normal. This is the MRI. It's not possible. Oops. I halted this. Is there a marker here? It's not working. It's not working. So if you can see, there is some whitish thing in the sulci. So the brain is okay, but then there's some whitish material in the sulci. And this is another sequence which tells us about blood and calcium. And you can see that it is black. We call it blooming. So the radiologist also did not agree with me. I told him this is nothing but subarachnoid hemorrhage. So the brain is covered by 3 plastic coverings is what you can presume. And there was blood in those coverings in the subarachnoid space. So that was causing the headache. And as I told you, the veins were normal and the arteries were normal. And this is a scan, which is a follow-up scan 4 days later, which shows that the hemorrhage was resolving. But have you noticed the difference between the first angiogram on 16th? So the blood vessels are looking healthy. And look at the blood vessels on 20th. You can see that the blood vessels have narrowed down. The lumen, they were all plumpy here. Can you notice the difference? Yes. So basically this was spasm of the blood vessels. The blood vessels went into a state of vasospasm. So I obviously did a lumbar puncture because the radiologist was not sure, but I was very sure. So I did a lumbar puncture and the pathologist gives me a call and tells me that the fluid is filled with RBCs. So there was no doubt. The diagnosis was confirmed even pathologically. So this is one of the few instances wherein subarachnoid hemorrhage in clinical practice is usually either trauma or an aneurysm like a balloon in the blood vessel. But this is one of the circumstances, we call it cortical SAH, and this is because of vasospasm, usually very common in the peripartum period. I think you might not have heard about this condition. So this condition is basically reversible cerebral vasoconstriction syndrome. We call it RCVS. And what happens is because of the rise in blood pressure, the blood vessels go into a state of spasm, then dilate, spasm, dilate. And that is why the small blood vessels in the pial spaces that rupture and cause the subarachnoid hemorrhage. And this is one of the very few instances wherein a neurologist is treating a subarachnoid hemorrhage because a subarachnoid hemorrhage usually needs a surgery. And what was the classical presentation here? We call it a thunderclap headache. A headache which she's never experienced in her life and a headache that peaks within 1 minute. That is the actual definition. So that is why history is very important. She just woke up with a terrible headache that peaked within a minute. Okay. So that was RCVS. And I'm going to tell you that it shares a continuum with press. And this is my second case vignette. And this is a typical scenario. I think you might have dealt with all this scenario. And she's a 23-year-old lady, underwent a cesarean, went home. And 1 week later, she comes with a headache and seizure. And the blood pressure is high, 160/90. And in the ER, she was in the post-ictal state, but she was moving all her 4 limbs. Is that time for me? Time up for me? 2 minutes. 2 minutes remaining. Oh, okay, fine. I have to hurry up. Okay. So this is the typical MRI, which shows bilateral hyperintensities in the occipital lobe. And that's because, again, the blood vessels go into a state of spasm, dilate, spasm, dilate. That is why blood leaks out into the cerebral parenchyma. The first was a hemorrhage. This is basically edema and swelling in the brain that is causing a seizure. So just remember these two conditions, PRESS and RCVS. PRESS is the edema spectrum, the swelling spectrum, whereas RCVS is the vasospasm spectrum. So PRESS will cause seizures because of the edema, whereas RCVS usually presents with a thunderclap headache. And MRI shows edema in PRESS, whereas in RCVS you might see a normal MRI, you might see subarachnoid hemorrhage, and rarely you might see the vasospasm. And differential diagnosis is very important. And that is why the new terminology is RCVS or reversible leukoencephalopathy syndrome or postpartum angiopathy. And as I told you, either the autoregulation of the lady fails or the autoregulation is hyperactive. So what do? You know, the position of the lady is most important. Put her into a lateral position, head down so that the saliva comes out. See to it that she breathes comfortably. And I always remember about cabbage. What is cabbage? Circulation, airway, breathing, and glucose. That's most important. And then yes, you might have already administered magnesium sulfate, but then if the lady is into status, we need anti-seizure medications. and midazolam. I think I'm done with the time. I'll be coming to the last slide. So the outcome depends on the underlying disease. And because pregnancy is not a disease, it's a physiological condition. So the outcome is going to be very great. And most of them completely recover. And what about seizures? So this is not going to turn into epilepsy. Seizures are different and epilepsy is different. Epilepsy is a recurrent tendency to throw seizures, whereas this is because of the edema and the vasospasm that the lady threw a seizure. So anti-seizure medications would be going on for a month or two. Once the blood pressure normalizes, the scan normalizes, everything okay. So differential diagnosis, as I told you, rule out a venous sinus thrombosis, rule out a stroke. And I'm just going to show a short video of a lady that, not all headaches are serious. Again, the audio is not playing. Okay.
కడుపు నుంచి నీళ్ళు కారుతుంది ఈ కూడా పశ్చిమ పట్టినట్టు శ్వాస ఆడదు
ఎప్పుడు వస్తుంది
నైట్ టైం వస్తుంది
ఏ టైం రఫ్లీ
11
So this is the picture, the selfie shot by the lady wherein the left eye is watering, and this is nothing but a primary headache which looks very, very serious. So it's called trigeminal autonomic cephalalgia. Ladies, all said and done, their lifestyle changes, their sleep gets disturbed, they start using a lot of cell phone, and that can cause this. The scan was normal. So what are the takeaways? This is a syndrome of the hyperactive nerves and hyperactive blood vessels. Just remember that. It's high pressure that leads to a focal swelling in the brain or triggers a vasospasm. The seizures are usually self-limiting. It doesn't evolve into epilepsy. Thunderclap headaches should alarm you towards RCVS and subarachnoid hemorrhage, and treatment is supportive and short-term with good outcomes. I would just like to highlight one lady wherein I saw she was devouring on shatavari, and then I realized, she had no history of PIH, but shatavari contains licorice roots, and that has steroidal properties, and that shot up her blood pressure. So we should be very careful with these supplements as well. And my last slide is do not react, but just respond.
Thank you, Dr. Abudi. Can you come here and have you take your seat? Dr. Ramya, Dr. Shyam, please come over to the dais. Now it's open for questions. Anybody carrying the mic?
So we have the luxury of having a fleet of cardiologists, a fleet of intensive care specialists, and also a fleet of neurophysicians looking at our pregnant women here. And it gives me immense pleasure that how we can improve the outcomes of every pregnant woman by coordinating interdepartmentally and making sure that the referral is given at the right time. The moment the referral is given at the right time, we not only look at preventive strategies, we also can use a lot of interventions that can better the outcomes of both the mother and the child, especially in pregnancies when we're dealing with two lives at a time. So any questions?
Sir, this is for the cardiologist. I just had one question, sir. It's a clinical case scenario. I have seen almost 4 or 5 years back. There was one patient, term pregnancy, of course not with us, but she came at around 38 weeks. Referred from a cardiologist, of course, because it was a medical college. And the diagnosis was peripartum cardiomyopathy. When the patient came to us, she had a heart rate of around between 160 and 170. And baby was okay. The oxygen saturations were between 85 to 90. So the question was, my question to you is, how do I go about this? Because it was peripartum cardiomyopathy diagnosed also outside because she had a ventricular cardiomyopathy. And the ejection fraction, if I remember, it was around 42 to 46%. So would the delivery would help? Because as far as my knowledge goes, peripartum cardiomyopathy is not because of pregnancy. So would delivery of the patient at that time would change any scenario for her?
It's
Because sir, the reason why I'm telling you is, I forced whatever it was my lead decision that we should deliver the patient. We should deliver, but patient
on any day we should deliver the baby.
But patient died.
But that might happen, madam. But I think so. Probably we'll at least save the baby. So any patient with class 3, class 4 heart failure, it could be any cause.
Sir, the reason why I'm asking is because it was not because of pregnancy, right? Is it that we have to stabilize the patient first and then go about for the delivery, or we should deliver and treat the patient?
Both can be happen simultaneously now, madam. So you start stabilizing the patient, intubate her, stabilize her, take care of a pregnancy, take care of a delivery. Okay, do LSES, cesarean section. Then subsequently it has to be. The main thing is that what you have to see is that when you are taking these patients, the hemodynamics have to be monitored and maintained. So in this sort of situation, the patients, if you have seen the scores or these things, the patient comes in an emergency or anything, the scores are always high. The mortality rate might be as high as 75%.
Yeah, see, basically, stabilization is not an issue. It's not going to be an important thing here. Patient has to be delivered, no doubt regarding that, because the physiological condition there is that there's no way you can stabilize unless you deliver.
Because sir, the reason was even baby was in HPE too.
Yeah, whatever you try to save the mother, you try to save the baby.
Overload scenarios also are there. Post-op overload is something that causes more trouble.
Because if we deliver her, we are increasing the load on the heart. So how was it helping the patient? Because already the hypoxia which was happening to the baby is happening.
But that's the only way we are going to probably save the baby or save the mother. It's a hairy situation, more than 70% mortality or morbidity, whatever. So definitely we have to go ahead and deliver the baby and try to stay. I mean, once that is done, then reducing the afterload situation and all that comes in.
Because I have seen, in spite of giving amiodarone, the heart rate was not coming down.
It won't come down.
It will take at least 48 hours for the patient to stabilize it. So the most important thing is that in this set of cases, it's not only the delivery. That first 24 to 48 hours are very, very important to stabilize the patient.
Yeah. So the risk stays even after delivery.
If you would have probably delayed delivery, maybe the baby might also would have crashed.
Second thing is that clinically we also do come across many of the obstetricians. This is the second case scenario. In the first pregnancy, cesarean section was done. Baby died, whatever may be the reason. Second was cesarean section was done in US, where she was diagnosed as a case of peripartum cardiomyopathy. Sir, if you remember, I have sent the case to you only because patient was asking that whether now I can become, I want to conceive again. So what is your take on this, sir? Because I told her recent recommendation says if the heart, if cardiomyopathy is okay and the ejection fraction is above 60%, counsel the patient and the patient should take the call.
So the present recommendation says that peripartum cardiomyopathy, the LV function is normalized, still can be considered. But again, the risk would be again somewhere around 4 to 10% of recurrence would be definitely there. So again, but again, it's a decision which the family has to take. Neither we can push them or push. But any amount of LV dysfunction, it's a strict no, or we shouldn't recommend. But yet the EF is completely normal. Probably take an opinion from 2 different cardiologists regarding the ejection fraction. And probably then take a call. But again, that still would be keep the patient at stage 2 to 3 or 3, what way the risk factors, what would you say? She would fall into that category.
Okay, sir. My third question is, if the patient is on acetylene in mitral valve replacement, we convert it into a low molecular weight heparin. So when would you again switch back to acetylene, in which week?
Usually, post-delivery, within, if it's a cesarean, we start back heparin in 12 hours. If it's a vaginal delivery, we start heparin in 6 weeks, 6 hours. Yeah. The thing is that azithromycin warfarin has no bearing for feeding. So if there is no bleeding issues or anything, it has to be started as early as possible.
Sir, because we are in the corporate setup, I have worked in the peripheries where I have seen that the patient is switched on to azithromycin back once she comes to 20 weeks. So I wanted to
It
ask
can be
this.
done actually after probably, yes, after 12 weeks, you can switch back to oral anticoagulation. And then again, during the last trimester, no, she was asking about during the pregnancy.
During the pregnancy, sir, during the pregnancy.
During the pregnancy at 20 weeks time, definitely you can switch over to oral anticoagulation.
So present recommendations.
I mean, if the requirement is more than 5 milligrams of warfarin, okay, as long as the requirement is less than 5 milligrams, it doesn't make a difference whether the patient is on low molecular weight heparin or positive.
Oh, thank you, sir.
What about salt restriction during pregnancy and hypertension? This is a general notion to restrict salt.
Usually salt restriction is not advised just to prevent the preeclampsia, sir.
Why?
So no need of salt restriction.
Why?
Pardon? I didn't get you.
No extra salt.
Yeah.
No extra salt.
Basically, pregnancy is a state where there is central oligemia. Central oligemia is the blood in the heart, major vessels and the renal vessels. This is called central effective blood volume. If we reduce this central effective blood volume, it can influence on the uteroplacental flow, circulation. So then the fetus will be deprived. So salt restriction is not at all recommended in pregnancy and use hypertension. So you said volume expansion. So most of the volume expansion is the peripheral expansion. It's not the central expansion. Any questions to Dr. Abhinay?
My question to Dr. Ramya. Madam, in a cases of chronic hypertension, of course, we do send the patient for the screening of retina also. So if in the retinal screening, if it comes as a papilledema and blurring of the edges, so what should be the take? What to consult the patient?
Not sure.
Yeah.
What is your question?
Sir, I've got one patient who is a case of a chronic hypertension, and patient blood pressure was, when she conceived, her blood pressure was at around 150/100, and she was on NVAS, if I'm not wrong. So we switched on to Labiclot. So we have sent her for the screening of all, like renal vasculature and heart, 2D echo of the heart, retina. So, and even because her HB was constantly being maintained between 9 and 10, of course, even HB electrophoresis, she came as beta thalassemia trait, which was diagnosed for the first time, in spite of her obstetric history being G4, P1, D1, 2 IVF failures, 1 ectopic pregnancy, and this is the other pregnancy. During the retina, they have written it as a papilledema and blurring of the margins. So does the patient is having papilledema? Would we say to terminate the pregnancy?
No. Papilledema is only a surrogate mark. We need not bother about papilledema. It is because of hypertension. We just control the hypertension with, as you said, labetalol is the drug of choice. In pregnancy, many of the countries now, labetalol is only approved drug in pregnancy, not even calcium blockers and, I think papilledema is just a surrogate mark. Don't bother about papilledema, which is reversible, just control the blood pressure.
Oh, thank you, sir.
Any questions to Dr. Abhinay? This is one of the wonderful, when to suspect this press and so vague, and if you see the picture, it is like cluster headache, watering, edema.
Absolutely, that was cluster headache, and that was because the sleep cycle was disturbed. And cluster headache is basically because of the biological clock, that's the hypothalamus. So that gets affected, and the pain arises from there. So now there are a few. See, headache is a common situation in pregnancy. How do I deal with it? So the first question that I ask them is, have you had headaches in your school, in your college? And many come up with the answer that, they've had history of headaches. And then I ask them, the second question is the nature of the headache similar or is it different? Okay. And then obviously there are other clinical examination markers like a dilated fundus examination, which is showing papilledema, which means there is definitely increase in the intracranial pressure. And then examination also, if there's any extraocular movement palsy, then obviously then it's a secondary headache. But then frankly speaking, in the setting of preeclampsia, PIH, proteinuria, then you suspect that the headache could go on to eclampsia. So that's the thing.
You suspect press, you made a positive diagnosis. Yes. Now, how do you treat press?
So press, the amazing thing or the amusing thing is it resolves on its own most of the time. So our magical touch heals the patients.
We are worried that something is missing from us.
Sorry?
We are worried that, we are missing something.
Absolutely, sir. So there are a few markers which will tell us that this is an atypical press or it's moving towards the severe spectrum. One is clinically. If the patient goes into a status epilepticus, then obviously it's going to become critical because she might need intubation and she might need a cesarean as well. Because a status, think about the fetus. She's seizing and then the blood flow to the fetus is going to get affected. Fetal bradycardia, which goes on for more than 10-15 minutes. Obviously, it's a urgent C-section. And then if the blood pressure is dramatically risen, again, that thing. And then MRI. MRI, if you see those typical findings wherein the occipital lobes are showing edema, then it's okay. But then there are some atypical press situations wherein I have seen a few, wherein the pons and the cerebellum, the posterior fossa gets severely affected. And that is where the patient becomes comatose and doesn't come out. And then the prognosis changes.
So when the patient sees you and when you start examining, our part is done. When do we call you? I mean, see, headache is so common. And headache can happen to any woman after birth. We start suspecting spinal headache first. We start suspecting a lot of other things. Are we delaying the diagnosis? Are we doing harm by not calling you early?
So, no, I don't think so. But then, the patient tells us that there's something wrong. This headache is.
What is it that an average obstetrician should think?
So, for us, there is a mnemonic called as SPOON. SPOON is basically which conditions can mark a secondary or a serious headache. Obviously, as I told you, any systemic disease, like she has had SLE or she's had another systemic disease and then she's getting a headache, then obviously. And then any sort of seizure or focal neurological deficit wherein she says that she has slurred speech or she says she has blurred vision or she says she has double vision. Obviously, again, that's a marker. And any postural change in the headache. So you raised the query about post-spinal headache or a post-dural puncture headache. That headache is not headache actually. It's neck pain. And I'll tell you the short theory. So what is happening is you punctured the dura in the spine and brain is a nice ball swimming in the swimming pool in the CSF. And because you created a puncture, the brain is sinking. But when does it sink? It sinks when you're sitting. When you're lying down, it's again floating. So what happens is there's traction on the meninges and that's causing more of a neck pain. So it's a postural headache. So what do you mean by a postural headache? The headaches appear when she's sitting or when she's standing. And then they disappear on lying down. So we call it an orthostatic headache actually.
I think any unconventional headache need to call Dr. Aparna. Thank you very much, my speakers, Dr. Shyam, Dr. Ramya.
Dr. Abhinay's skills for examining a patient are applauded because we always have if anything is going wrong, just call Dr. Abhinay because he's very good at differential diagnosis and giving solution. So
sweet of you, madam. Thank you.
Thank you.
Good afternoon, everyone. Thank you for giving me this opportunity. Actually, I wanted to share one of my experiences regarding a case regarding rheumatic heart disease, which I encountered recently in my practice. So she is an uncomplicated pregnancy. Otherwise, she's primate around 20 weeks gestation. She was referred to me for termination in your fetal anomaly. Some lethal renal anomaly was there. She was planned for termination, and blood count, everything was normal. Renal anomaly, renal agenesis.
Bilateral renal agenesis.
Fetus. So maternal no other maternal complications were there for her. So the process went on smoothly. But she required this manual removal of placenta for the suction evacuation because of retained placenta. And during the time, she had PPH of almost 1 liter and her HB went to around 7. So initially also the clinical examination was done by referring the obstetrician there and myself and anesthetist during the procedure. Everything was absolutely normal. But later, 2 days later, suddenly one night, she came with SOB. That time, and it was just like, so SOB increasing in supine position and she's better on sitting position. And that time, I could hear this MDMA diastolic murmur was there, which I didn't expect till that time. And next day, we got a echo done, which confirmed that the moderate MS was there. And she was referred to the cardiologist. And after her anemia got corrected with blood transfusions, the murmur also, we couldn't hear that murmur. So I wanted to emphasize that sometimes anemia also could unmask the undetected murmurs. So we should make a point to do auscultation every time, not only in the first visit, each and every time, and before discharge also, we should auscultate the mother. I learned from that case. Thank you.
And another very, very important take-home message is any woman pregnant with moderate to severe cardiac problems, the problem does not end at delivery. The problem begins after delivery and it can extend for as long as 1 week to 6 weeks. That's why peripartum is very, very important and we need to be very watchful. Any symptoms of mild breathlessness or any stuffiness has to be reported. We in fact had one woman who came after 6 weeks with postpartum peripartum cardiomyopathy or postpartum cardiomyopathy, and she succumbed in Secunderabad because that was an emergency admission. Within 12 hours, she succumbed because of an underlying cardiac problem. Yes, fourth trimester of pregnancy, and everybody was in a celebratory mode because she had a normal delivery, and everybody after the baby. And postpartum mothers not only have postpartum blues, they need extra attention in terms of rest, taking care of hemodynamic situations also.
It's highly commendable. A gynecologist appreciates a mid-diastolic murmur where we are forgetting nowadays.
Thank everyone, the chairpersons and the panelist speakers for the session. We are running 1 hour late. I think in the interest of covering all the sessions, we'll quickly move on to the next session. We request Dr. Jayanti ma'am, celebrated obstetrician and director of JJ Hospital, for chairing the next session. And ma'am will be introducing the next speakers, Dr. Ramya and Archana from our team. Good afternoon to everybody. At the outset, I'd like to thank Dr. Aparna and Dr. Shilpi for giving me this opportunity. And as we are talking about the postpartum care, as well as the importance of what's we having our postnatal clinics, we are not actually so much into, yes, we have a board there, postnatal clinic, but we don't insist and tell our mothers, yes, you have to visit us at 15 days. And that's the time we may see a breast abscess, and that's the time we may see something that may be going wrong with her lactation, which may be leading to a breast abscess. And it's very important that we have to diagnose this very early, because so often when they come early and within 48 hours, we give them the antibiotics, it subsides and there's nothing, no abscess formation. So prevention also is very important. Our postnatal clinic, like for all the other conditions, plus also the most important thing for the future of humanity, and that is breastfeeding, which is very close to my heart. I now call upon our first speaker, Dr. Ramya C. Balliveru, to come and give her talk on breast infections from mastitis to breast abscess. So we hope one day after your talk and all that, we will not see this condition. Go ahead, ma.
Good afternoon, everyone. I work in oncology department, but I'm party and friends with Cuddles, so I'll keep it very short.
Can I have my presentation, please? So lactational mastitis to breast abscess. Breast milk is the best feed for the newborn. We all know that. But for various reasons, mothers get very stressed about breastfeeding. So to keep it short, if there is inflammation in the breast tissue around the time of lactation, it is called as lactational mastitis. So the most common reason why it happens is there is some stasis of milk which gets infected with pathogenic bacteria. There is normally flora that is there, but if there is infection in the residual milk, in the staged milk, then it causes inflammation. That is lactational mastitis. It can cause both local breast symptoms and systemic symptoms depending on the severity. We usually see this in the new mothers in less than 3 months post-delivery because for various reasons, maybe they're still adjusting to how lactation goes on, maybe the baby is still adjusting to lactation. And so because of various reasons, it is more commonly seen in the first initial few months after delivery. And as I said, there is varied degrees of severity. We see this in about 5 to 20% of breastfeeding mothers. And this is how the breast is going to look in lactational mastitis. There is an area or maybe the entire breast sometimes is slightly reddish, swollen, and there may be tenderness and signs of inflammation. So the patient comes with pain, firm redness, and tenderness in an area or entire breast. In advanced cases, there could be a large area of breast swelling with overlying skin inflammation. And systemic symptoms, if it becomes neglected or if it gets worse, like that of a flu, fever, chills, palpitations, and in advanced cases, sometimes, of course, there could be abscess formation and sepsis features, but this is rare because it's such a painful condition and the mother is feeding, so they come quite early to us at least. So it's a very simple thing. There is milk coming into the glands of the breast that has to be let out. So I tell women the example that if you keep the milk in the glass overnight, what happens? It gets spoiled. Similarly, if you don't empty the breasts, your milk is going to get clogged and there's going to be infection with pathogenic bacteria. It's a very, very simple thing. So the glands that secrete the milk and these are conducted through the ducts which have to be emptied out from the nipple. So any problem in this system is going to cause stasis of the milk. So whatever milk is coming in has to be let out. There are various etiologies that one can think of. The most common reason is a duct blockage. So duct blockage can be because of various anatomical reasons like maybe a slight nipple inversion or a clog formation within the duct. And again, clog formation within the milk duct is because of poor hydration. So I always highlight to the patients, women, breastfeeding mothers, that your breast milk is predominantly water. So if they get dehydrated, especially working women nowadays, if they don't take enough water, there's going to be clog formation within the duct. It blocks the duct and there is going to be stasis in the system, and that is going to cause all these problems. So there are some functional issues. Sometimes maybe there is not enough motility, and that is very rare. But most commonly, it's because of poor hydration and maybe slight nipple inversion and nipple trauma. So poor latching can cause nipple cracking, and that can make an entry point for the bacteria, pathogenic bacteria, to enter inside. And again, poor latching, no proper emptying of the breast, that worsens the condition. And dysbiosis, change in the flora of the bacteria in the breast milk, and repeated usage of breast pump in an improper way, which can cause micro trauma within the ductal system, that can also increase the breast's tendency to develop infections. Incomplete emptying and infrequent feeds. Of course, it's very logically understood that it can cause stasis and pressure from tight breast here. So all these can cause lactational mastitis. So clinical examination, it's very obvious. We know there are signs of inflammation, and high resolution ultrasound clinches the diagnosis, whether is there any abscess formation or not. If there's no abscess and if there's leukocytosis and if there are no systemic symptoms, we're going to treat with simple antibiotics. For us, the most common bacteria that we isolate in abscess, so maybe we extrapolate it to the lactation mastitis also, is MRSA. And the choice for us is to then give amoxicillin, clavulanic acid, and sometimes we add clindamycin. So the press that we have heard by neurologists in the brain, the press of the breast is engorgement. There is only interstitial edema because of the sudden inflow of the milk. That is different from mastitis. Usually engorgement resolves in 24 hours. So the treatment for lactation mastitis is correct feeding and lactation latching technique, complete emptying of the breast, adequate frequency of feeding, hydration, breast supportive clothing, and hot and cold compresses, manual massage to relieve sometimes the areolar edema or a duct blockage. And if there is a nipple bleb, of course, that has to be also treated. So abscess is there is a collection of pus. We all understand what is an abscess, and in physical examination, we might also sometimes see a skin change like a necrosis, or an ultrasound can give the diagnosis. So this is a advanced case of lactational abscess where there is a necrosis of the skin because of the pus trickling in up to the subcutaneous planes. And the treatment, what we follow is, as much as possible, try not to interfere with the feeding. Try to aspirate in early stages, repeated aspirations and letting out of the pus, send it for culture and treat accordingly, antibiotics as per the culture sensitivity. And if on repeated aspirations it's not settling on, that is when we take for incision and drainage under sedation or GA. So we want to allow it to heal by secondary intention, because if we close it primarily, there is a chance of again milk accumulating and causing reinfection. But in rare cases, when the if you want to really close it and put a drain in a distant area where it doesn't interfere with the baby's latching, we start. And it's important to emphasize to the ladies to continue feeding while still they are undergoing all this from the other breast. From the ipsilateral, from the breast that is being treated, they can start once we see that the drain of fluid is now almost like milk. So that is very important, because if they stop feeding again, the process can repeat. So a special situation that I want to highlight is a axillary breast abscess, where there is accumulation of milk within the axillary breast, which is not connected. It has all the gland tissue, but there is no connection to ductal outlet. So there are women who suffer like that. So for them, the only way is to incision and drain if aspiration doesn't help. So this is in nutshell about lactational abscess and lactational mastitis. Thank you.
Thank you. I will take the question after the next talk. I follow Mrs. Archana. And she's a lactational specialist. She's going to talk to you about how to improve the lactation. What are the various intrapartum interventions to improve breastfeeding?
Good afternoon, everybody. So today I'm going to talk about intrapartum interventions to improve breastfeeding. So I'll just start with a few statistics here. So mainly first, as everybody has spoken now, that breastfeeding is very essential for both mother and baby, and how the team of healthcare players will play a very key role in supporting the breastfeeding during the intrapartum period. So what are the recommendations? So here the recommendations are WHO and UNICEF recommendation, early initiation, that is first within 1 hour of birth, breastfeeding should happen, exclusive breastfeeding till 6 months, for 6 months without giving anything else, and continue breastfeeding up to 2 years and beyond. But where are we? Now, as of NFHS 5 indications, children under age 3, breastfeeding within 1 hour goes only up to 41.8%. That is not even half. Okay, and coming to the institutional births, if you can see the institutional births, it is around 88.6% of all the births happening in India are institutional births. But the first hour of breastfeeding is happening not even half. And what about Telangana? Right now, Telangana is in a very, very poor state. That is only 33.8% of percentage is happening in Telangana for first 1 hour of breastfeeding. So what are the different factors that is affecting breastfeeding and early initiation? There are different factors like maternal factors, hospital factors, and also neonatal factors.
So coming to maternal factors, first is mode of delivery. What kind of delivery that mother is having, whether it is vaginal delivery, assisted vaginal delivery, or cesarean section. Then maternal medications and anesthesia and maternal health conditions like we have already discussed, some preeclampsia, heart diseases, diabetes, all these things we have already discussed. Then coming to neonatal factors, gestational age and birth weight of the baby. Yes, definitely if the baby is premature and if it is low birth weight baby and any infant medical conditions which require immediate attention, then that is again affecting the early initiation. Then comes hospital and healthcare factors. So early separations, NICU admissions, or separating the baby and mother immediately after delivery, and lack of skin-to-skin contact with the mother, and delayed breastfeeding support and education, and also hospital practices and routine policies of a hospital, which will again delay in breastfeeding in first within 1 hour. So cesarean and breastfeeding support. How can we support during the cesarean session? So encouraging early and uninterrupted skin to skin as soon as possible. Then breastfeeding within 1 hour, that is called as golden hour. Using comfortable breastfeeding positions for the mother. If she's in OT table also, if you can see the picture there in OT table also, it is like we can keep in different positions and breastfeed the baby. And last and final thing I would like to talk here is antenatal colostrum harvesting. If you can see the picture there, this is a case of mine where the mother was very keen in breastfeeding. GDM mother, first baby, she couldn't do breastfeeding due to various factors. So she was very keen on breastfeeding. So with the permission of the gynecologist, we could harvest this colostrum antenatally before the baby got into before the mother got into the OT table. We have harvested the colostrum and the first feed for the baby was given this colostrum. So this is one more important and very useful thing which we can do again with the consents of both family and also the treating gynecologist. And breast crawl. This is one more important thing which I would like to talk is breast crawl. This is a age-old practice, has been practicing from many years. And in India also there are institutes who are encouraging breast crawl, where the baby has been taken out after cord clamping, kept on baby's chest and let the baby's reflexes follow to the breast, natural instincts of the baby through the senses like touch and smell, go to the breast and start breastfeeding. There are beautiful videos in YouTube which happened not only outside India but also in India where breast crawl happening. Then skin to skin, like kangaroo care or skin to skin contact, what are the benefits? Immediately after birth, if the skin to skin is given to the baby, like it is stabilizing the heart rate, it will also control the temperature, because most of the time we are worried about the temperature of the baby going into hypothermia, and because of the OT temperatures and labor room temperatures are very high. So that is why. And what is the best is with uninterrupted skin to skin first 1 hour of birth. And again, effect of labor medications. What are the effects of labor medication is it delays the suck of the baby. It will make the baby more sleepy, not very active during first 1 hour. So that is also one of the reasons why we should also go for non-medicative pain medication, non-medicative pain management for the mothers. Then what we can delay you after birth, immediately after birth, weight check. If the baby has a good cry and there is no RDS or TTNV, then we can definitely take the baby weighing measurements, then injections, and also showing it to the parents, showing it to the people who are standing outside can be delayed, and first breastfeeding and skin to skin can be done, and then we can definitely take about all these things. Then coming to rooming in, this is again another very important factor, because it will show the mother if the baby is hungry. Demand feeding can be established and it will reduce both maternal and baby stress, and it will also reduce the supplementation. Prenatal education plays an important role for all the postnatal help what the mother is required. Prenatal education is very, very important. And training the hospital care staff. You might not have a specialized lactation support in your clinics or hospital, but yes, definitely we can train your staff for the basic lactation skills and provide lactation support to the mothers, and also avoiding artificial teats and nipple introduction at an early stage also plays an important role here. Then coming to avoiding supplementation. So it is always better to get the risks of allergies and all to be spoken to the parents before starting any supplementation, and teaching hand expression and cup feeding and parada feeding for the mothers who are having, and encouraging colostrum expression plays a very, very important role here. So this is the one simple steps which if we can follow, this will give all the other postpartum help what the mother requires for successful breastfeeding. So here I would conclude like breastfeeding is a team sport, and here are the team players. So everybody who are involved in the mother and support labor team is very, very important for a successful breastfeeding rate. Thank you so much.
Well said, Archana. Definitely it goes beyond saying that it is a team effort. And I would like to say that in a cesarean section, I would invite Dr. Ramya and Archana. Please take the seat, and the question, the house is open now for any questions. But during the cesarean section, we have implemented a way where we can transfer the baby under the sheets to the neonatologist or the nursing staff who's standing on the other side, and the placenta along. Actually, we don't cut the cord immediately. So the placenta is removed and put it in the tray and also transferred under the sheets to the thing, and then the nurse will take care of the baby and the lactation. So this is one question. Most people have this question. I'm going to have after incision and drainage, can I breastfeed from the ipsilateral breast? You have answered it well.
Yes, ma'am. So the idea is we would have used betadine, hydrogen peroxide, and still there might be some bacteria pus left. So even after we wash. So once we are confident that the output is clear now, I think it's safe to feed. So I usually observe that in 24 hours it gets, and I make sure that the next day when I do the dressing, I do it myself, and we give only normal saline wash. I don't use betadine because we don't want the stuff to go inside babies now. So
yeah, because it's a very common question asked to us.
And because of the pain, they don't again express or feed from the ipsilateral breast. So I specifically emphasize that. Yes. I know it's painful. We give you painkillers and you must empty it. Otherwise, it's gonna continue.
Yes. And they always say, so there's some smell coming. That is why my baby does not like to drink milk from this. So I tell them,
I can pump and throw it away also. That is also another option.
So I give them actually extra gadget pads, and I tell them keep changing so that the baby doesn't get any of this.
Yes, ma'am.
Any questions from the audience, please?
If there is fever, if there is there are features of systemic infection, then we give antibiotics. So we don't want it to become a problem. So amoxicillin clavulanic acid is the first choice. If it is not reducing and without any abscess formation, there is only a mastitis which is not reducing with the clav, then we add on clindamycin. So that's how I follow here. So yeah, that's what book says, but extrapolating what we see in the abscesses. In our center, we see them and yeah, fluoxetine. It is correct. But in our center, when we have done the antibiogram, so for us, amoxicillin works. I think every center should look at their data, what is the organism that they are having, and then use that, right? So if it is done under GA or sedation, It is safe to feed once 4 to 6 hours after the procedure is done from the other breast. From ipsilateral breast, as we were just discussing, once you are sure, confident that the draining fluid is not having any contaminants, we can start from feeding from the other breast. Even before that, if we want to empty it, we can use pump and throw it out from the infected breast
to prevent engorgement.
Prevent engorgement. Thank you.
Any more questions from the audience? So breast health has a lot of myths and continuous ongoing education and you have to elaborate care and postpartum tips and everything throughout the antenatal period. So me and Dr. Aparna have done a course on it's an online course that any pregnant couple can sit down and watch. It has got about 40 to 60 videos where we elaborated entire scenarios that can cause good lactation, problematic lactation, and its solutions and everything. And that's a course that is available online. It's a parcel of the www.newmoms.in program. And this is how we are trying to empower pregnant couples all during pregnancy and post-delivery. And especially during pregnancy, they have enough time to understand the details of lactation, post-lactation care, and how the mother can gear up for all these scenarios. So that is very important. Thank you.
So one more small thing here, coming to mastitis, there is always the risk of recurrent mastitis if the root cause is not been identified. So most of the time for mastitis, the root cause is poor latching. That is a basic thing. Actually, the mother has to be taught. So poor latching is one more thing, and infrequent feeds, as Dr. Ramya mentioned. Most of the mothers, what they think, they can take rest during the night times and sleep so that their sleep cycle is not getting disturbed. But yes, if they want to take rest also, it is always advised they get up and pump at least every 3 to 4 hourly so that their breast is getting drained.
Thank you, Dr.
And very important point, for all the mothers whose babies are in NICU, they are not expressing in the nights. So if they don't express milk in the nights, then the flow might come down, and if there is engorgement, they can land into these kind of problems. So they have to be counseled. Even for mothers whose babies are in NICU, they need to express breast milk on a regular basis, including nights. And night feeding is very, very important for ongoing breastfeeding rates and a healthy output from the breast.
Hydration is very important, according to me.
As simple as hydration. 1 glass of water before you feed the baby and 1 glass of water after you feed the baby makes a lot of difference. It's a simple tip, but it makes a lot of difference. No fancy food stuffs needed if you take care of your normal, regular protein diet and hydration.
A simple message I would like to express here is that if when you're going on rounds, just look at the nipple of the nipple, and if you find that it is cracked, and if you find it is sore, and you ask a simple question to the mother, is the latch painful? That's all. Then you know that this particular mother requires to help, and the baby also requires help to have the good latch. So just by looking, please make it a point when you're doing rounds that you have to look at the nipples. Thank you for this wonderful session, Dr. Ram. And Dr. Thank you.
Thank you, Jayanti ma'am, for chairing this session. A very important session on breastfeeding, which I think all of us should be very passionate about, because it's one of the most important interventions shown to reduce infections, mortality, and morbidity. We have a small change in the program moving forward from now. We are preponing the panel discussion on prenatal genetics because we are running a little late and one of the faculty has to leave. And to do this, we would like to again invite our chairpersons, Dr. Aparna Reddy ma'am. I hope ma'am is here, head of the department of St. Teresa Hospital. Thank you, Aruna ma'am, for joining us today. Please join us on the stage. We also would like to invite Dr. Chinmay Rath ma'am. Ma'am needs no introduction. You have already listened to her session. So we have this very interesting panel discussion on different case scenarios dealing with situations where we need prenatal diagnostics, prenatal genetics, where we take the help of experts like Dr. Pragya Ranganath. And to introduce Dr. Pragya Ranganath, I'll hand over the mic to our chairpersons.
Dr. Pragya is a lifesaver for a lot of us. She is a very well-trained geneticist and she's done her DM in medical genetics from the ACE Institute. You know that SGPGI Lucknow has been one of the mother institutes of genetics, and Dr. Shubha Phadke has been one of the master trainers of genetics, I'd say, in this country. And Dr. Pragya comes from that same institute. And she is heading the division of medical genetics in Nizam Institutes of Medical Sciences, Panjakutta. I would say she's a lifesaver because after her counseling, a lot of unwarranted terminations get saved. The number of genetic tests we are having nowadays, it's very difficult for us to take that responsibility as lay people in genetics. I would say all of us are lay people in genetics. We understand what is there, but the exact significance of that is not there. And it is in the interest of all of us to talk to clinical geneticists. And we are lucky that they have a department here. And she has very good handwriting in addition to all other things. And not only that, she takes the pain of writing the entire management in a beautiful sequential way so that the patients know exactly what to do. Thank you, Dr. Pragya, for all the good work that you do. And we're so happy to have you here. So over to you.
Thank you so much, Dr. Chinmay. I've known Dr. Chinmay for several years now, and it's always a pleasure to interact with her. So thank you so much for that kind introduction. And also at the outset, I'd like to thank the organizing team today for this opportunity, and in particular, Dr. Aparna for the invitation, and also a special thanks for advancing the session and accommodating our request. So today's panel discussion is going to be on prenatal genetic testing, and I would like to invite the panelists on stage, Dr. Chandrika, Dr. Vamshi Krishna, Dr. Harshita, and Dr. Jayant. Dr. Chandrika is Senior Consultant in Obstetrics and Gynaecology and also a robotic and laparoscopic surgeon in KIMS Cuddles, Kondapur. Dr. Vamshi Krishna is a Consultant Neonatologist and Pediatrician here in KIMS. Dr. Lakshmi Harshita Bodla, she's also working in KIMS, Kondapur. She's the Consultant Fetal Medicine Specialist. And Dr. Jayant Krishna. So Dr. Jayant also did his fellowship with us we have a 3-month SIMG clinical genetics fellowship, and he did that with us in NIMS. So it's again a big pleasure to have him here as a part of the panel today. And he's working as a pediatric neurologist and clinical geneticist here in KIMS. So, and I'm your moderator for today, Dr. Pragya from NIMS, Hyderabad. So now we'll move on to the panel per se. So a quick background on what prenatal genetic testing entails. So these are basically tests which are done during pregnancy to determine if the fetus has a genetic condition or a birth defect. And broadly, you can classify them as prenatal screening tests and prenatal diagnostic tests. So prenatal screening is where you screen all antenatal mothers, including the low-risk ones, to identify pregnancies which may be at risk for the common genetic disorders. So that's the most important point here, that screening is done for all. It's a universal thing, and it's done for common genetic disorders. Whereas prenatal diagnosis, on the other hand, is the confirmatory testing that you offer for specific genetic disorders for which the increased risk has been identified. So now, first we'll talk about prenatal genetic screening. And Dr. Chandrika, my first question is for you. What are the disorders for which prenatal genetic screening is usually done?
It's basically the common.
Yes.
Madam, prenatal genetic screening is usually done, as you said, for all the women low risk, high risk, we all do. It is maternal age with an NT scan and double markers, which we generally do between 11 to 13 weeks. And if a woman is over there, then we can go for a triple marker and a quadruple test also. And the other one is NIPT test. Yeah, these are the basic screening tests which we do.
Apart from that, ultrasound soft markers also at around 16 weeks.
So essentially, mostly the commonly used prenatal screening tests are meant for the detection of common chromosomal aneuploidies. And when we say aneuploidy, we mean the numerical chromosomal anomalies. Most of them where we expect a trisomy, that is extra copy of a chromosome. So the common ones, of course, being trisomy 21, that is Down syndrome, and trisomy 13 and 18. And sometimes you can also have a reduced copy of a chromosome that's called a monosomy. Autosomal monosomies are usually not compatible with survival and result in very early pregnancy losses. But the monosomy that can survive is monosomy X, that is Turner syndrome. So that is also usually included in the prenatal screening panels. So Dr. Vamshi, why is it important to screen for these common chromosomal disorders?
Actually, all the chromosomal disorders can have a very morbidities, and some majority of them have mortality, especially first year of life. Like trisomy 13 and 18, they usually get in the first 6 months to 1 year of life. So any mother who carry these babies and have this kind of outcomes will be very heartbreaking to them. And as a neonatologist, when we see any baby who has a genetic anomaly, especially syndromic babies, we feel very difficult to counsel the parent and also to explain the prognosis. So as far as possible, if you identify them, we can terminate them as early as possible so that they don't be much attachment for the baby. Suppose if sometimes like Down syndrome babies who have a morbidities but they can survive. So these babies can be delivered in a center where they have all the facilities to treat them, monitor them for the long term.
Thank you, Dr. Vamshi. And these are fairly common. Down syndrome is known to occur about 1 in 700 live births. And in fact, with the increasing maternal age, the risk may be further increased. And of course, the other aneuploidies, which are also relatively common, trisomy 13 around 1 in 8,000, trisomy 18 around 1 in 5,000, and Turner syndrome around 1 in 2,000 to 2,500 live births. So because these are fairly common, that's the reason. And of course, as Dr. Vamshi pointed out, they have significant morbidity associated, also mortality in case of the other trisomies. And therefore, it's best to screen for these common conditions. Dr. Harshita, what are the various available tests and modalities for prenatal genetic screening?
We have various screening tests depending upon the gestational age of the fetus. In first trimester, that is between 11 to 13 weeks of gestation, we have combined screening tests where we use the maternal age and nuchal translucency, which is measured during the first trimester screening test like NT scan. Along with that, we have serum biochemical markers like beta HCG and PAPA values. This is called as combined test, which improves the detection rate up to 85 to 95%. When we combine the ultrasound markers like nasal bone, ductus venosus flow, and tricuspid flow, this increases the detection rate to 93 to 95%, with false positive rate being 2.5%. In second trimester, we have quadruple test, which is done between 15 to 20 weeks of gestation. In this, we will use the maternal age and other biochemical markers like alpha fetoprotein, free beta HCG, estradiol, and inhibin A, which improves the detection rate to 70 to 75% with false positive rate of being 5%. So usually we'll advise in first trimester, we'll advise a double marker test or combined screening test. If the patient misses the first trimesters, then we'll go to the quadruple test.
Thank you so much, Dr. Harshita. And Dr. Harshita, can you also answer this question, please? What is non-invasive prenatal testing and what is the role of NIPT in prenatal genetic screening?
Non-invasive prenatal testing is also called as NIPT. In this, we'll get the fetal DNA from the maternal plasma. So we have, with this NIPT test, we have direct access to the fetal DNA. So this NIPT is primarily designed to detect the trisomy 21 with detection rate being 99.9% with false positive rate of 0.1%. But NIPT can also detect other chromosomes like trisomy 18 and 13 with detection rate being 95% and for sex chromosomes being 99%.
Yeah, thank you. So as of now, NIPT is not well standardized for monogenic disorders, although a lot of studies are going on in that respect. And NIPT can also be used for determining the RHD status of the fetus. Now moving on to prenatal genetic diagnosis. So Dr. Chandrika, my next question is for you. What are the various clinical scenarios where prenatal genetic diagnosis is often sought?
When we do the screening and screening shows that she comes into an high risk, that is one scenario. Second is if in her obstetric history, if any of the previous children have suffered from any anomalies, or if she gives us any family history, both the couple as well as the genetic tree or the children which are born, madam. And that's it.
Yeah, and of course, if you have the antenatal ultrasound showing you the fetal anomalies or the soft markers, etc. So these are the scenarios where typically prenatal diagnosis is done. And Dr. Harshita, what are the various prenatal sampling procedures which are available?
Most commonly used invasive testing are chorionic villus sampling and amniocentesis, and we have also cord sampling or chordosynthesis also. In first trimester during 11 to 13 weeks of gestation, the most common done invasive procedure is chorionic villus sampling. This is done under ultrasound. It is an ultrasound guided procedure, and in this, we'll use 18-gauge spinal needle, which is introduced into the placental tissue. By applying the negative suction pressure, some of the placental villi are collected and it's sent for the testing. With chorionic villus sampling, there might be a risk of fetal loss being 0.5%. In second trimester, we have amniocentesis invasive procedure, which is done between 16 to 20 weeks of gestation. In this, it is also an ultrasound guided procedure. Under strict precautions, we will use the needle between 20 to 22 gauge spinal needle, which is inserted into the free loop of amniotic cavity, so that any of the fetal parts or cord should not be included in the cavity, which are in the free fluid which we are choosing for the test. So about 15 to 20 ml of the fluid is collected depending upon the test which we are sending, and initial 2 ml of the fluid should be discarded in order to avoid the maternal cell contamination. And with the amniocentesis, we have the risk of fetal loss being 0.1%.
Thank you, Dr. Ashita. So now that we have understood the basic concepts, we'll now move on to the illustrative clinical scenarios. So this is the first scenario. So this is a second-degree consanguineous couple, maternal uncle-niece marriage, which we commonly encounter in our population. They have been referred for prenatal genetic counseling and testing. This is the third ongoing pregnancy at 12 weeks of gestation. The first child, as you can see, is affected. Now, this child has a neurodegenerative disorder. The second child is normal. And these are the details of the affected child, the index child, the proband. This child was apparently normal till 1.5 years of age. After that, started developing regression of motor milestones, then developed seizures and cognitive impairment from 2 years of age. On examination, the child was found to have pyramidal signs, cognitive impairment, and the MRI brain showed periventricular white matter hyperintensities suggestive of leukodystrophy. Now, Dr. Jayant, my question to you is, how do you counsel this couple? Will you advise direct whole exome sequencing of the fetal DNA?
I think it's a very common situation that a lot of people are now tempted to directly go for next exome sequencing or whole exome sequencing in the prenatal testing, but that's going to be a disaster, because before we do next or whole exome sequencing or NGS-based testing in prenatal, we need to confirm the diagnosis of the proband. If you see the first child who is having the neurodegenerative disorder, we don't have the exact diagnosis of the first baby. So first we need to try to clinically phenotype the first baby. If you can see, and go to the previous slide, this child clearly has a history of regression, and the MRI is also suggestive of a leukodystrophy. So this pattern most likely fits into a probable genetic leukoencephalopathy, that is metachromatic leukodystrophy. So with this clinical phenotype, I would like to confirm the diagnosis in this baby first with whole exome sequencing to see for the pathogenic mutation in this baby, and also doubly confirm with an enzyme assay like iron sulfatase. So once I'm sure that this baby, I know the clinical phenotype and have a genetic diagnosis for this child, then I'll counsel the parents that we have a clear-cut diagnosis in the first baby. We can go for a targeted sequencing in the current pregnancy. So that would be the most ideal situation, because for the second question, if we directly do a whole exome sequencing in the current pregnancy, that is going to be disastrous, because you'll have a lot of variants of uncertain significance coming up. And then I think the gynecologist and the treating physician and even geneticist will not be able to exactly pinpoint which is disease causing and which is not. So ideally, we need to confirm the diagnosis in the proband and then go for the targeting testing of the current pregnancy.
Thank you, Dr. Jayant. Aptly put. And yes, it's very, very essential to first establish the diagnosis in the proband. Although the clinical features, the neuroimaging findings were fitting into metachromatic leukodystrophy, we cannot go with that assumption. We have to confirm the diagnosis in the proband first, identify the exact disease-causing variants in the proband, and then prenatal testing is always done through targeted variant testing. If at all there is a time constraint, if the family presents to you later in gestation, you might do things a little differently, but even there it is essential to establish the diagnosis in the proband. If at all, if you're very sure that the first child has a genetic etiology, but it is yet to be established, and let's say the family presents to you at about 22 weeks, although it's not very ideal, just in view of the time constraints, it may be okay to go ahead with the amniocentesis and send the amniotic fluid sample for genetic testing. But even there, parallelly, the testing of the proband has to be done, and the lab can start processing the AFDNA, extract the DNA, keep the DNA ready, rule out the maternal cell contamination, and as soon as the proband's mutations are identified, then in the AFDNA, the targeted variant testing can be done, even in that scenario of a presentation at a later gestational age. But ideally, the testing should always be done in the proband first. If the proband is no longer alive, in the carrier parents, the variants can be identified, and the target for the prenatal testing, it's always the targeted variant testing, which is done in the prenatal sample. So that was what was done in this family. The child was found to have, the proband was found to have metachromatic leukodystrophy, was identified to have a homozygous pathogenic variant in the ARSA gene, which codes for aryl sulfatase A, which is the enzyme which is deficient in this condition. So the diagnosis for the child was established. Now that we know that it is MLD, we know that this has an autosomal recessive pattern of inheritance with a 25% risk of recurrence in each offspring, and hence you are now very much justified in offering prenatal testing. So amniocentesis was done. Now, as you can see, for the proband, we did exome sequencing, but for the fetus now, we are doing targeted Sanger sequencing. Unfortunately, the fetal DNA was found to be homozygous for the same variant, and the fetus was found to be affected. The couple was counseled accordingly. They opted for termination of pregnancy. So this case was just meant to highlight these points, that it's always important to first establish the diagnosis, identify the exact disease-causing variants in the proband, and then only do targeted testing for the same in the fetal DNA. Now, moving on to the next case scenario. This is a 24 years old second gravida, third degree consanguineous parents, third degree consanguineous marriage, referred for prenatal genetic counseling in the third pregnancy at 8 weeks of gestation. As you can see here, the first child died on day 4, the second child died on day 7. First one was a male child, second one was a female child. Both had weak cry, poor movement since birth, and when the medical records of both the offspring were checked, it was documented to be perinatal asphyxia. So Dr. Vamshi, my question for you is, should we counsel the family that no prenatal testing is required, as both previous offspring were documented to have perinatal asphyxia? And also, if there is a need for doing any genetic testing, what are the genetic conditions that can mimic birth asphyxia?
So whenever we have recurrent episodes of asphyxia kind of related deaths in the family, so it can't be related to just plain asphyxia because of decrease in the blood flow or having any fetal deceleration that led to the asphyxia. There might be something that might not supported the baby to initiate the breath. So there are, if it is recurrence is happening after we monitored the heart rate, everything, and the baby after the baby has born, baby is not crying, not having good efforts, it means that there is something abnormal that is running in the family. It could be any structural lesions in the brain which affected the initiation of the breath, or it could be any other muscle related disorders like a congenital myopathy. So in the case of recurrent asphyxia, we should not just believe that this only because of asphyxia. We should do the investigation to find out what are the cause for recurrent asphyxia. One of the most thing is congenital myopathies, like Neonatal myopathies, can have this kind of asphyxias where the baby's muscle tone is much weaker, so they cannot initiate the breath.
Thank you, Dr. Vamshi. So particularly in this case, even otherwise, you should not always assume it as perinatal asphyxia. And particularly in this case, there were 2 offspring who had a similar pattern. So that again raises the suspicion of a genetic etiology. And therefore, it was very good that the cord sample of the second baby was stored, and we were able to extract the DNA from the cord sample for the second baby, do a whole exome sequencing even after the child had passed away, and we were able to confirm that the child did indeed have a congenital myopathy, and autosomal recessive Nemeline myopathy was in fact the diagnosis which was established. Both parents were confirmed to be heterozygous carriers for this variant. And then targeted variant testing could be offered for the next pregnancy. Fortunately, the fetus was not affected. So please remember, perinatal asphyxia, sepsis are not the only conditions to be considered in sick neonates. If the index child is not alive, try to go through all the medical records, and then if a sample is stored, that's the best possible scenario. You can do the testing in the deceased baby sample. Even if you do not have the deceased baby samples, based on your clinical suspicion, you can evaluate the parents, do expanded carrier screening of the couple, and try to identify the variants which can explain the phenotype of the previous affected deceased offspring. And this is for the neonatologists especially, and also for the pediatricians. If you have a sick child, especially a suspected IEM or any other genetic disorder, and you think the baby is not going to make it, at least preserve a sample and keep at least 2 to 3 ml of EDTA blood sample would suffice, so that even after the child passes away, you can look for genetic causes to help the family for their future pregnancies. Now, moving on to the next case scenario. So this is a primigravida who presented at 18 weeks of gestation. Evidence of fetal hydrops, double bubble sign, posterior fossa cyst in the antenatal ultrasound, amniocentesis and fetal chromosomal microarray were done. So now, okay, I've mentioned that microarray was already done, or rather we advise that, but as such, Dr. Chandrika, what prenatal genetic counseling and testing would be recommended for this couple? And do you think we should have offered an NIPT rather than a chromosomal microarray as a first line test in this scenario?
Ma'am, NIPT is a screening test. So at this point, I think there is no role for any screening test. As such, the baby is showing anomalies, we should go for a diagnostic test only. So I would that we should go for with the CME and whole exome.
So yeah, so the first line test in this case would mostly be a chromosomal microarray. And we can ask the lab to preserve the DNA and keep, so that if the chromosomal microarray comes out to be negative, then we can, because chromosomal microarray helps us.
If it is negative, then whole exome.
Then whole exome. Because chromosomal microarray helps us look for the chromosomal anomalies and the copy number variations. It doesn't give us information about
then we should go into a deeper
for the monogenic disorders. Yes. So if the family had decided to terminate the pregnancy anyway, how would your counseling differ in that case scenario? Would you tell them there is no need to do a genetic evaluation? If they have anyway decided to go for termination based on the scan findings,
we should advise for the genetic testing, because they have to plan for their future generation, future pregnancies also.
Yes.
Definitely yes.
Yes, definitely yes. And if they are going for termination, can we give them some other option as well? Is amniocentesis absolutely essential in that scenario?
Yes, ma'am.
Okay.
But
so
if
yes,
they are going for a termination, then we can go for that portrait also.
that's right. So I think ma'am actually properly highlighted the importance of going for a genetic evaluation anyway, even if they're going for termination, for the sake of identifying the diagnosis, for the sake of the future pregnancies, in order to determine the risk of recurrence for the future pregnancies, in order to know what prenatal and pre-implantation genetic testing options to offer for the future pregnancies. And here, of course, amniocentesis was done. But if they are planning for termination anyway, amniocentesis prior to termination is, of course, an option. And it also provides you access to live cells, which will help you gives you a kind of ensures that you are going to get a good quality and sufficient quantity of DNA if you're going to be doing a pre-termination amniocentesis. But for some reason, if the family, if the couple are not very much in favor of going for a pre-termination amniocentesis, the samples can also be collected at the time of termination. The cord blood can be collected. You can collect a bit of the cord per se. You can collect a bit of the skin. And of course, the fetus can also be subjected to autopsy so that you have more information and you are able to identify the diagnosis for the sake of the future pregnancies to counsel them appropriately. So here they decided to go for a pre-termination amniocentesis. Microarray was done, and that showed this partial trisomy of chromosome 3p. And whenever you get some anomaly like this in the baby, you should always do karyotyping of both partners. And in this particular case, we found that the mother was actually a carrier of a balanced translocation involving chromosomes 1 and 3. You can see here, there's extra material here, and there's a little reduced material here. So there's actually a translocation. In the mother, it is balanced, and therefore she is normal. But this balanced translocation can lead to imbalance in the offspring. And that was what happened. The baby had a partial trisomy of this chromosome 3p region and therefore had the anomalies. And now that we know that one of the parents is a carrier, we know that the empiric risk of recurrence of similar fetal anomalies is about 10 to 30%. So in fact, fetal autopsy was also done after termination. You can appreciate the hydrops. There was actually pyloric atresia. There was mild bilateral hydronephrosis as well. And bilateral ventriculomegaly and hypoplastic cerebellar vermis were also documented. So as Dr. Chandrika mentioned, if you have detected fetal anomalies in the antenatal scan, there is no role for NIPT. And here it's best to go for invasive sampling or post-termination sampling and testing. In such anomalies, you can do microarray as the first line. And then if it's negative, you go for whole exome sequencing for the monogenic causes. Sometimes your pattern of anomalies is suggestive of a monogenic etiology like a skeletal dysplasia, in which case you would go with whole exome as the first line. Moving on to the next family, this is a non-consanguineous couple referred for prenatal genetic counseling and testing in the second pregnancy at 11 weeks gestation. The first male child has global developmental delay, and the second pregnancy now is at about 11 weeks of gestation. MRI brain has not shown any significant abnormality. Whole exome sequencing was done for the proband. Now, this showed a homozygous variant of uncertain significance in a PHG. Chromosomal microarray also was done for the proband. That was negative. So, Dr. Jayan, should we offer prenatal testing for this variant of uncertain significance which has been identified in the PHG?
So I think here the situation is a little different than the previous case. So if you go back, this child has a phenotype which is very not clear. There's global developmental delay and a very non-specific phenotype which does not match with the genetic diagnosis. And the genetic diagnosis is PAH. This is a gene which is associated with phenylketonuria, and it is a variant of uncertain significance. So when I'm not sure whether the phenotype of this baby is not matching with the genetic variant identified, and that too it's reported as variant of uncertain significance, I would doubly confirm with, are we dealing with the correct diagnosis or not? So when we have variant of uncertain significance, then we try to use other ancillary tests, like supportive diagnosis. Like for example, I would definitely go for an MRI, and MRI was done, which is normal. So I didn't get any clue from that. So when you actually go and look at phenylketonuria, you have deficiency of the enzyme which causes elevation of phenylalanine. So I would like to look at metabolic workup, GCMS, TMS, to look for the levels of phenylalanine. If the phenylalanine is elevated, that matches the phenotype of the child, then I would consider probably that no, this is the pathogenic variant or disease-causing variant. So when we went ahead with the GCMS, TMS, we can see phenylalanine is in the reference range. So it's supposed to be elevated if the child had seizures. So I would very likely think that this is not the disease-causing variant. So whenever you have variant of uncertain significance and the clinical match is not perfect, or you have partial match, I think we should wait before we advise a prenatal targeted testing and further evaluate this child to find the correct diagnosis.
Yeah. So Dr. Jayan, as he rightly pointed out, we should not offer prenatal testing for variants of uncertain significance without further corroboration. And this family was counseled accordingly. And of course, the child needs further evaluation for etiology. But for this ongoing pregnancy, we can't really offer any targeted prenatal testing now because we do not have an etiology established. And please remember this, do not offer prenatal testing for variants of uncertain significance unless you have sufficient corroboration. The next case, this is a second gravida who presented at 19 weeks of gestation. The fetal anomaly scan showed a unilateral cleft lip. Growth parameters were normal, LIPA was normal, no other obvious anomalies. Dr. Harshita, should we offer prenatal genetic testing for this pregnancy? And if yes, what testing should be done?
Usually, unilateral cleft lip will be associated in about 25% of the pregnancies. If it is isolated condition, then it is very less likely associated with the chromosomal aneuploidies. But it can be associated with various genetic syndromes. Hence, option of testing should be advised to the couple. So, if they are willing for the testing, at least we have to send for chromosomal microarray, and some of the samples should be stored for DNA storage. We can evaluate later if we found any variants.
So the microarray came normal. And of course, the follow-up scan was normal except for the unilateral cleft lip. Fetal echocardiogram is also normal. So Dr. Vamshi, now if the couple comes to you to discuss the postnatal outcomes and postnatal management options, how would you counsel them?
As Harshita said that isolated unilateral cleft lip or palate, if it is not associated with any other syndromes, so the outcomes is pretty good. Only thing, the initial part of the time is if establishment of the oral fits might play a difficult. But we have a special kind of techniques where we can have the oral feeding, even some breastfeeding also can be possible if the cleft palate is not affecting too much about the making the seal. Another after the certain point of time, after 6 months or 6 months, then we can go for a cleft lip repair. And around 9 to 12 months, we can go for the cleft palate repair. If there is no other structural anomalies as there, then the outcomes will be pretty good.
Yeah. Thank you, Dr. Vamshi. So please remember, many isolated malformations are multifactorial. They may not have a specific identifiable genetic basis. But of course, in some scenarios, you may have to go for a genetic testing and of course, detailed scan has to be done to rule out associated anomalies before we say it's an isolated finding. And some of them have a favorable prognosis, may be correctable after birth. So finally, I would request each of our panelists to give us the most important take-home messages from this panel. Dr. Harshita.
So whenever we are dealing with any pregnant case, if we are not finding any solution, when we are encountering anything suspicious or anything, we have to make sure to involve all the team like obstetrician, fetal medicine and geneticist in order to acquire a solution, because we never know what is the recurrence of that condition and we never know how it will be affected to the babies. So better every case should be evaluated, even if we don't know the cause of death, at least through the history, we should ask thoroughly what is the cause of death and what might be the reason. And we should not just take it like that maybe it is due to some term because of the delivery or asphyxia, whatever may be the cause. We have to evaluate every case very carefully and we have to involve all the team so that we can find the best solution to the parents.
Thank you, Dr. Harshita. Dr. Jayant.
I think with our two cases, I think the first case clearly says that before we establish the correct diagnosis in the proband, we should not be going for prenatal testing. Like the first child actually had MLD. So once the diagnosis is confirmed, then we should go for prenatal targeted testing and never go for whole exome sequencing prenatally. You have to go for Sanger or targeted sequencing. The second one, whenever you encounter variant of uncertain significance, it's always better not to offer prenatal testing because we'll end up having, ambiguous results because you have variant of uncertain significance. You try to clinically correlate with other investigations, get an MRI, do metabolic tests, try to reevaluate and do more diagnostic tests to establish the diagnosis in the proband, and then offer a prenatal testing and not directly offer a prenatal testing in this situation. So these are the two messages.
Dr. Chandrika.
As an obstetrician, ma'am, I feel that everyone should be offered genetic screening because I have very recently come to Hyderabad. I have come from Rajahmundry, where actually we used to hesitate even to offer the screening test. I still remember Chinmay ma'am coming 2 years back and giving us a lecture that yes, everyone should be offered. At the time, that was the first click when I started as an obstetrician, that to counsel each and every girl, even if she was 21, go for an NT if she's affordable.
So screening is a universal thing always. Dr. Vamshi.
From neonatology perspective point, whenever you identify this condition, we have proven the genetics that the baby is having this syndrome. and or any anomaly, and we are trying to conserve the baby and go for the delivery things, we need to involve the neonatologist also a bit ahead, so that we have a plan, sit with the parents, discuss along with our obstetrician genetics. So we'll make a plan and we'll explain what is the postnatal things, outcomes, and how do we want to manage the babies. When is the subsequent studies or the corrective procedures will be done.
Thank you. So, and this is the final slide, that we need to understand all these concepts very clearly ourselves. Only then will we be able to convey these clearly to our families and to our patients. And whatever we do, whatever genetic testing, screening, diagnosis, whatever it may be, a proper pre-test and post-test counseling are absolutely essential. Thank you so much.
Thank you, Dr. Pragya. And before we embark on lunch, I think this was a very productive discussion. Few points which I feel that as general gynecologists and obstetricians, we have to be very, very careful. One case we recently came across, that the first child was having neurodevelopmental delay. And a whole exome was done on that child, which was normal. And then the couple were told that unless we find the reason, you cannot have another pregnancy. So they were advised a trio analysis again. They could not afford that trio analysis, so delayed the pregnancy for 5 or 6 years. And this time when they came and they are pregnant, and they were very guilty because their doctor said, why did you get pregnant till you finished your genetic test? And when she came, the first child had this. So this MRI was available. And all we did was we sent the MRI to the neurologist, because the woman's blood group was negative and her ICT was positive. And when we took a history, that first she had a termination, then she had a child, and that child was in the NICU for about 30 days. The bilirubin was 30 when they discharged the baby. And they took the baby off because they could not afford care. So when we sent the MRI to the neurologist said that all this is a result of the connectorist at that point. So this was not a genetic case. Every neurodevelopmental delay is not because of a genetic problem, especially in terms of consanguinity. So this was a case which was not genetic, but everything was delayed because of that. The other thing, Dr. Pragya, I want your opinion on this also, that very many times when there is an autosomal recessive condition found in a child, immediately we send for the parents' mutation testing. That invariably will come positive because the child is having an autosomal recessive homozygous condition, and you test only for that mutation. Now, the next prenatal diagnosis, if you just test that mutation, and we know in consanguineous couples, they could have multiple genes which are there. So should we not be advising a comprehensive couple carrier screening in these cases, as opposed to just matching that particular mutation, which we already know?
Thank you, Dr. Chinmay, for highlighting that. So that's what we are actually doing now. So we are actually offering expanded carrier screening for all couples who are consanguineous. Whether they do it or not is of course their choice, but we are definitely offering it. And what we usually suggest is a whole exome sequencing of both partners, along with SMN1 MLP of at least one partner, because SMA is common and the mutation is generally not picked up in whole exome sequencing. So you, as you rightly said, even if the previous child's diagnosis has been established to be a particular genetic disorder, before we plan the next pregnancy, it would be good to offer expanded carrier screening just to make sure and look for any additional carrier status for any other autosomal recessive disorders. And of course, sometimes X-linked recessive disorders also in the mother. That's very much possible. In fact, before we started offering expanded carrier screening, which we are doing for the past 2 years or so, before that, we had at least 3 families where we did a prenatal testing for a autosomal recessive disorder identified in the first child. That was negative. They continued the pregnancy, but after birth, the second child was found to have an altogether different genetic disorder. So it's definitely important to offer expanded carrier screening for all couples, especially, if they have consanguinity. We don't generally offer it for non-consanguineous couples. Yeah. And was there anything else?
I think one more thing you need to tell everyone is the screening, preconceptional screening for thalassemia and SMA.
Yes, so that's something we are offering as a routine carrier screening for all couples, irrespective of consanguinity. We advise hemoglobin HPLC of both partners, primarily to screen for beta thalassemia and sickle cell carrier status. And we also offer this SMN1 MLPA for at least one partner for SMA carrier screening for all couples, because these are very common in the general population and can exist. The risk can be there even in the absence of consanguinity because of the high carrier frequency in the general population itself. Thank you for highlighting that important aspect.
In a low-income group, actually, the screening tests are being missed. As Jessica pointed out, irrespective of age of the mother or irrespective of consanguinity, screening has to be done for everyone. So, do you prefer double markers or NIPT?
So as of now, because the cost of NIPT is higher, we do not want to miss out on the structural anomalies, of course. So the best thing to do is to do an NT scan with double marker in the first trimester. That would be good for, that is something that should be offered for all. NIPT can be probably reserved for the higher risk cases. Of course, if some couples opt for NIPT upfront, that's also fine. But NT scan, of course, has to be done. There's no replacement for an NT scan.
And how about 2D echo for the baby?
Fetal echo, generally, we do not recommend as a routine. So TIFA, of course, is done routinely for all. Fetal echo is reserved for cases where there is a suspicion of a cardiac anomaly in TIFA. Also, sometimes for an echogenic cardiac focus. And also, if there's a previous child with a cardiac anomaly or one of the parents has a cardiac anomaly, those are the cases where we definitely ask for a fetal echo.
Higher age of mothers and
diabetic mothers, of course. Any teratogenic things involved, including diabetic mothers and all, of course, again, goes without saying we have to do fetal.
Yeah, we prefer doing the 2D echo at least by 35 weeks, so that in the diabetic mothers will pick up some anomalies.
22 to 24 weeks is when
we can start 22 to 25 weeks. But sometimes when we miss, better to do a repeat 2D echo at 35 weeks. Sometimes.
Yes.
So here we have an incidence of about 80% of gestational diabetes running in our population in the hospital. So for us, not doing a 2D echo is quite very rare. So almost all the patients are either, fitting one criteria or the other. Higher order of age, higher order of, higher incidence of gestational diabetes, fertility, pregnancies, twins, and sometimes echogenic cardiac focus also. And these days, madam, the echogenic cardiac focus has increased. I don't know why it has happened.
So echogenic, you are very right. The incidence of echogenic intracardiac focus has increased because we are seeing the heart in a lot more detail. And that has been described in the textbook also, that the incidence of echogenic intracardiac focus will depend on the clarity of your imaging. Now, echogenic intracardiac focus per se is not an indication for an echo. But this is like, 3 birds sitting in a tree, you shoot one, how many will be remaining? So if you don't do an echo, you are likely to lose that fetus. You may not lose the patient, but you will lose that fetus. Because she will go to some other place, some other place, some other place. People will measure it and it is defined as a space occupying lesion and ABCD, everything she gets scared. So in those cases, the echo is mostly for their reassurance. So the patients ask, is this echogenic focus going to go away? So what you tell them, it won't go away, but the heart will grow and this will remain the same. So relatively, it will start looking smaller and smaller. And somehow telling them after 4 weeks that it is looking smaller makes them feel much better. So we do it only for that reason. There is no harm in doing that.
So single soft marker will not press much, but if we find other soft markers.
When we say there is an echogenic focus in the heart, we know what we are saying.
Yes.
But for a family, what is their exposure to heart problems? Their grandfather had cardiac bypass or the neighbor had a heart attack. So the moment you say heart or some child died of a heart disease, so you say something in the heart, they start thinking in that spiral. So you cannot, once you have made, so it's the first counseling which is very important. And how to counsel? There is no course. We have to learn to communicate with our patients. So how to counsel without making them scared is something which will come with practice.
And a very, very important thing is if you do a proper NT scan, whether it is double marker or a first trimester quadruple marker, and you have that document in place. And the document says it's all good. So you're looking at only structural problems later and not related, genetic problems associated. So that is again very, very important. So a very good take home message is do not miss your proper fetal medicine specialist done NT scans with a first trimester screening, whether it is double marker or first trimester quadruple marker, according to the risk factor analysis. We have switched over to first trimester quadruple marker from the last 4 years, and we have very good results, not only for genetic analysis and to assess the fetus for genetic problems. It also gives a very good analysis for preeclampsia screening. That is again very, very important. Genetics is one point, and preeclampsia screening is again as like a secondary point that we should not miss. And whenever preventable solutions are given, you should give. Thank you.
Identify the gender of the child. Will it give some
PCP and DT. PCP and DT.
Rules of India. It's not allowed.
In India, it is.
the picture? They can go and Google it.
No, sir, they cannot. No, sir. Sir, I think that is a complete no-no, that when we do a scan, we have to give a declaration that I have neither detected nor disclosed the sex of the baby to anybody in any manner. So it is also a deterrent for us, because in conditions like hypospadias or even any lower urinary tract obstruction, we are forced not to reveal the gender. So we have to use good vocabulary to explain things like, external urinary tract hyperplasia and things like that, which doesn't make any scientific sense, but that's fine.
In ovarian cyst also.
In ovarian cyst, we have to write this is a differential diagnosis of ABCD and gonadal cyst. So between us, we know if we write gonadal cyst, what we are meaning. If we write posterior urethral valve, what we are meaning. But we cannot reveal it to anybody under any circumstance. It's a non-bailable, cognizable offense.
We really thank the chairpersons, the moderator, Dr. Pragya ma'am, and the panelists for a very, very informative panel discussion. These are all very common situations that we all deal with. I think it had a lot of take-home messages for those of us who are dealing with mothers and babies and fetuses. We thank all of you for your time and for your valuable contribution. Thank you, chairpersons and the moderator. So we have one good news and one bad news. Good news is from 60 minutes late, we have slightly improved to around 35 minutes late. Yes. And bad news is we were considering having this short debate that we had postponed before lunch. If all of you are okay with it, we promise that we will relieve you by 1:30 for a short lunch break from 1:30 to 2, because we really do not want to keep the rest of the speakers waiting. We are joined by Padma Shri Dr. Manjula Anagani ma'am. She is going to speak to us on her innovations with regenerative medicine post-lunch. So if it's okay with all of you, do you think we can finish the debate? It's going to be a very exciting, and I'm sure you will not regret it in this pre-lunch hypoglycemic session. When you're hungry, that's the right time to have a debate. That aggression will be there. So we quickly invite the chairpersons, Dr. Sri Sailam, who is President NNF from pediatrician from Nizamabad, and Dr. Chandrasekhar, a professor of pediatrics from Mallareddy Medical College, to be the chairpersons for the debate. We have two interesting speakers today who are going to talk to us about a very common situation. We very often see a baby whose fetal heart rate was going absolutely well during labor, and we end up with a depressed newborn. So we wanted to discuss this in detail. And we have two obstetricians here, young and dynamic, Dr. Chandana and Dr. Ankita, who are going to speak to us about fetal heart rate monitoring vis-a-vis scalp pH to identify fetal distress during labor. So I'll request Sri Sailam sir to introduce Dr. Chandana.
Good afternoon to all. And so Dr. Chandana, she's
consultant obstetrician and gynecologist at the Ankur Hospital for Women and Children, gold medalist in Obs and Gyn, worked as associate professor in Venkateshwara Medical College. Her thesis guide to postgraduates. Her areas of interest: high-risk pregnancy, maternal and fetal medicine. Welcome.
Good afternoon, everyone. So I'm going to initiate a very controversial topic. Fetal scalp pH monitoring is value addition in labor. Whether it is a value addition or not is something which you will decide at the end of the presentation. So this topic has a lot of controversies. Different governments and different countries have various recommendations. So I'll just summarize. To introduce, fetal monitoring is very essential to reduce the adverse perinatal outcomes, and birth asphyxia is one of the leading causes of perinatal morbidity and mortality. Now, what we have seen is widespread use of intrapartum CTG has contributed to increase in the rates of cesarean sections and interventions. And we all know that category 1 fetal distress is the most common cause of cesarean sections. And almost all countries have exceeded the stipulated rate which is set by the WHO, which is 10 to 15%. Now, is CTG the best tool? It has the high sensitivity. It is very good at detecting true positives, but it is having very low specificity. Means there are a lot of false positives. Majority of the abnormal, pathological and non-reassuring CTGs occur in babies who may not be actually distressed. This we have seen in our clinical practice. So are we overdiagnosing fetal distress, and is this leading to increased interference? The FIGO consensus guideline on intrapartum fetal monitoring in 2015 released a document which said that CTG was associated with 63% increase in cesarean delivery and 15% increase in instrumental vaginal deliveries. So most of the unnecessary obstetric intervention also occurs from poor CTG interpretation. That's when the need for the scalp pH comes in. So a supplementary test was needed to increase the specificity of the CTG and to reduce the number of interventions. Scalp pH is a more objective test, and it aims to reduce intrapartum asphyxia, to detect intrapartum asphyxia and to reduce the births which are happening, leading to HIV. And in turn, it also reduces medico-legal implications. Now, a quick summary about fetal blood sampling. It was introduced in 1962, before even CTG was discovered, by Erich Salling in Germany. The indications for fetal blood blood sampling are persistent late or atypical decelerations on the CTG, persistent fetal tachycardia, prolonged persistent decelerations, grade 2 or 3 meconium with CTG abnormalities, and prolonged period of loss of baseline variability. There are some contraindications we need to keep in mind. There is risk of infection transmitted if the mother is HIV positive or hepatitis B or herpes. Bleeding diathesis like von Willebrand disease, it is contraindicated. Preterm less than 34 weeks. Fetal scalp pH monitoring is not indicated. Breech non-vertex presentations again. And if there is a clear sign of fetal compromise, there is no point doing a fetal blood sampling and delaying the delivery. So a small summary about the procedure. The patient is placed in lithotomy position with the lateral tilt, or you can also put the patient in left lateral position. Cervix has to be at least 4 centimeters dilated with the membranes ruptured. An amnioscope is introduced and the scalp is dried with a sponge or swab. Basically, we are cleaning it, and then we introduce a ethyl chloride spray. This is to induce hyperemia, and we need to apply a thin layer of paraffin jelly so that the blood spot comes and it does not go away. A blob is formed. Then a small blade is introduced to make a nick, and we need to allow a droplet to form. And we need to take the sample in heparinized capillary tubes. Some studies recommend paired samples. So 2 samples are recommended. And after the procedure is over, a firm pressure is applied over the puncture site. So here we can see the fetal scalp. There is an amnioscope introduced, and we are cleaning it with a sponge holder. There's a swab there which is cleaning the area. This is a fetal blood sampling kit. We can see a disposable amnioscope there, and we can also see a blade which has control. So the depth is controlled. This is a closer look at the blade. You can see there is a depth control blade, and it comes with a mounted heparinized capillary tube. When we are doing this procedure, we need to be aware that prolonged collection time can cause changes in the pH value, and it can also cause clotting and blocking of the analyzer machine. Contamination with meconium, blood, all these things need to be kept in mind. If at all there is a large caput or there is scalp edema, we can again have errors in the pH. So it is found that if there is lot of scalp edema, the pH may be more acidotic. So it might give false values and maternal obesity. The disadvantages of this procedure: it is an invasive procedure, needs a dilated cervix, there is pain and discomfort. There is difficulty in collecting samples sometimes, and the fetal head, if it is high up or not fixed, there are difficulties. Risks again: continued bleeding from the puncture site, bruising and infection. So these are the results of scalp pH. Greater than 7.25 is normal. Between 7.2 to 7.25 is borderline. So we need to repeat if indicated along with CTG abnormalities in 30 to 60 minutes. If the scalp pH is less than 7.2, an immediate delivery is indicated. We also have fetal scalp lactate references here. I'm not going into the details, but what I need to tell is if the scalp lactate is more than 4.8, it is abnormal. And we also can study base excess from the sample. So base excess more than -8 milliequivalents indicates metabolic acidosis. So studies have found that the correlation of scalp pH is very good with umbilical cord arterial pH, umbilical vein pH, and the Apgar scores at 1 minute. The interpretation of results: some studies say that the scalp blood pH reflects the state of the fetus, but it is a single point in time. So we are not really sure like how it is. So some studies have advocated the rate of fall of scalp pH. So all these are under trials. And a lot of countries like the Australian guidelines and the Canadian guidelines recommend fetal scalp lactate levels because this is much more easier to measure and it requires very less blood. So 5 microliters of blood is more than enough. And some studies are evaluating base excess because this reflects a change over a longer period. So it is much reliable than the scalp pH. So here there is an example. So if there is a fetus with a pH of 7.22 but a base excess of -12 milliequivalents, this fetus is more at risk than a fetus which is having the same pH but with a lesser base excess. So coming to the studies, I'll quickly rush through it. So the fetal scalp pH has a high negative predictive value, but it has a very poor positive predictive value. So they say that it is good at identifying uncompromised fetuses with an abnormal CTG because we tend to overdiagnose fetal distress. Probably we still think that there is a need for fetal scalp blood sampling. Now, these are the recommendations from various countries across the world. The Australian and New Zealand guidelines say that there is a role for fetal blood sampling, especially in units where electronic fetal monitoring is used and we are detecting equivocal CTGs. And if fetal blood sampling is indicated, we can either use the scalp lactate measurement or the fetal pH. The Canadian guidelines also recommend fetal blood sampling. And sometimes, excuse me, digital fetal scalp stimulation, if it does not result in accelerations, it is indicated. Now, a lot of Scandinavian countries like Denmark, Finland, Switzerland, these countries are very pro-fetal blood sampling. And here we see that there are some studies, but most of the consensus are based on expert opinions. So they say that expert opinion from more than 25 years of daily use of fetal blood sampling, they recommend that it is needed because it has prevented unnecessary emergency cesarean sections. Now coming to the practice in US, again here there are a lot of debatable studies. Some studies say that fetal scalp pH sampling is debatable because it is a measurement of pH of the peripheral blood. It does not really indicate the central oxygenation. So during fetal hypoxia, most of the blood is diverted to the central organs like brain and less is flowing to the skin. And what we are measuring is actually from the skin. So it may not represent the actual oxygenation, and this technique is nowadays practiced less in US. The interesting thing is about the UK. This is the last slide. Just give me a minute. So in UK, until recently, the NICE guidelines has been recommending fetal blood sampling, but the recent NICE guideline in 2022, what has come out is they have omitted the recommendations totally. So they are now reviewing a lot of studies, and what they have found is fetal blood sampling has not really made a clear difference in decreasing the intervention. So the guidelines may change, hopefully maybe in future they may come out with new evidence, but currently this is the updated NICE guideline. And the FIGO recommendation, they say that as it is an invasive method, scalp stimulation has a much better utility in labor. So scalp stimulation can reduce the necessity for fetal blood sampling in approximately 50% of fetuses. So the conclusion, fetal scalp pH testing varies widely among hospitals and countries, and most of it is based on local protocols. The sampling can be used as a complementary test in conjunction with CTG to indicate whether intervention is required due to loss of fetal well-being. So we need to individualize, and it is done on a case-by-case basis. The true value of fetal blood sampling needs larger trials. Thank you.
Ankita Chauhan, she is graduated from SRMS Raebareli with masters from Maharashtra and fellowship in laparoscopy. She is a consultant obstetrician and gynecologist, presently working with the KIMS Cuddles. And her academic achievements include high-risk pregnancies and minimal invasive surgeries, tubal reconstruction, tubal recanalization, myomectomies, and laparoscopectomies, and she has areas of interest on ovaries is working on. And she's working with KIMS Cuddles since 2017. Over to you, Ankita, for your talk.
So hello everyone, I'm Dr. Ankita Chauhan, and Dr. Chandana has already discussed about fetal scalp monitoring. So I am going to discuss about CTG monitoring in the labor. So first of all, what is CTG monitoring? It is tracking of fetal heart rate along with uterine contraction. So basically when the patient is in labor, we monitor the changes in fetal heart rate in correlation with the uterine contraction. So this correlation helps us to understand the oxygenation status of the fetus during contraction and help us as a clinician, as an obstetrician to make the necessary interventions whenever required. So what actually happens during first two stages of labor, that is the first and second stage, the fetal circulation, it tends to get compromised sometimes, and compression of the fetus during different position and uterine contraction can lead to hypoxia or acidosis in the fetus, and which can induce fetal distress, giving us a poor outcome. So monitoring this status help us to make a necessary intervention at right time. So now in the CTG, what are the things which we are going to monitor? Fetal heart rate, variability, acceleration, and deceleration. So baseline baseline fetal heart rate and variability are influenced by the central nervous system activity of the baby, the volume status, baroreceptor stimulation, and chemoreceptor stimulation in the baby. So fetal heart rate accelerations, like I told, it is associated with CNS stimulation of the baby and a period of increased fetal motor function. The normal baseline fetal heart rate is between 110 to 160, and the variability, when we talk about the fetal heart variability, we look at the window of 10 minutes, and it should be between 10 to 15, or I would say 10 to 25. Anything less than 5 is minimal, moderate is 6 to 25, and anything which is more than 25 is known as marked variability. There are multiple causes for in each category. What can be, causes of moderate variability? I'm just going to quickly go through. So moderate variability is absolutely normal, and it excludes hypoxia or acidosis. We can be sure that baby is completely okay. So decreased variability, which can be absent or minimal, it does not, clearly indicate that it is a marker of hypoxia or acidosis, but it helps us to stay alert and make the necessary this intervention. Uncomplicated loss of variability can also be caused by central nervous depressants like certain medications, morphine, diazepam, magnesium sulfate, and there's a long list. And uncomplicated loss of variability can also be signifies no risk or minimally increased risk of acidosis or low APGAR score. Now, fetal tachycardia. So, like I said, anything between 110 to 160 is completely normal. We count it as a fetal tachycardia when it is more than 180. It can be because of any infection in the baby or the mother, certain medication, hyperthyroidism, abruption, or fetal hypoxia prematurity. Similarly, fetal bradycardia, which is less than 120, also has a different set of causes. So fetal bradycardia in between the range of 100 to 120 with normal variability is not associated with fetal acidosis. This is most commonly seen in post-dated gestation and the fetuses with occipito-posterior or transverse position. Bradycardia, which is less than 100, can also be seen in babies with congenital heart anomalies and myocardial conduction defects. And moderate bradycardia, that is between 80 to 100, is a reassuring pattern that is known as non-reassuring NSTs or CTGs. Now, severe prolonged bradycardia, which is less than 80 beats per minute, which lasts for more than or for 3 minutes, is a bad sign indicating severe hypoxia and is termed as a terminal event, which means that we should be thinking about or we should go for delivery immediately. There's a list of causes like cord compression, cord prolapse, vigorous vaginal examination, severe uterine contraction, maternal seizures, sometimes spinal or epidural anesthesia can also lead to something like this. Now, what is acceleration? Acceleration is a sudden rise in the fetal heart rate, and it is usually because of fetal movement, and it is a reassuring factor when we talk about CTG. Its absence is not necessarily concerning, and it is a good thing which we see. Now, next thing is deceleration. So there are multiple different varieties of deceleration: early deceleration, variable, or late deceleration. Okay. So early deceleration is usually okay, and it is because of head compression. Variable is, again, it is a concerning factor, and late deceleration is usually because of uteroplacental insufficiency. Now, there are different kind of category when we talk about fetal heart rate. I will quickly go through this. So category 1 is completely normal with normal baseline, moderate variability, no or variable deceleration or late deceleration. Early deceleration may or may not be present. Acceleration may or may not be present. This is completely normal. Category 2, when we see tachycardia or bradycardia, reduced or marked variability, or there is an occasional variable or late deceleration. This indicates that we have to be alert and we have to continuously monitor the patient and see if the patient is going into category 3 or not. Again, there's a list of causes which I'm not going to go because we are running short of time. This can also be because of fetal sleep cycle, and it can be corrected with fetal scalp stimulation. So, but if the pattern persists, then we have to think about the the causes and we have to look into the different categories. Now, category 3. So this is the category where we need to deliver the baby immediately. Absent variability with bradycardia, absent variability with recurrent late or variable deceleration, sinusoidal pattern, or there's a pattern are predictive of, these patterns is predictive of severe hypoxia or acidosis. What can we do about it? We have to see if there are certain drugs which we are giving to mother. We have to make sure that we are stopping all those medications. Try and give left lateral position to the mother. Reassure mother. Give IV fluids. Give oxygen supply to the mother. And look for the causes which can lead to a pattern like this. Do an internal examination. Rule out cord prolapse. Rule out meconium. Okay. Now, in short, what is the take-home message? So, there's a growing evidence which suggests that when properly interpreted, a fetal heart assessment is equal or superior to fetal blood pH in predicting good or bad fetal outcomes. Fetus with normal pH that is greater than 7.25, they respond with accelerations, at least with fetal scalp stimulation. Fetal scalp sampling is, I would say, is recommended if there is no acceleration, even with scalp stimulation. There are certain limitations to scalp pH monitoring, like cervix has to be dilated at least 3 to 5 centimeters. It requires a certain level of skill. It cannot be done by a nursing staff like a CTG, which can be done by anybody and everybody who is in the labor room. And I think these points have already been covered by Dr. Chandana, but I would still say about it that we all know when there's a hypoxia. Here we are talking about the fetal hypoxia. So whenever there's a episode of hypoxia, there is intense peripheral vasoconstriction. So here in fetal scalp monitoring, we are checking a peripheral tissue, that is fetal scalp. We are collecting blood from there and there's a vasoconstriction. So we are almost sure that we are not going to get a correct value of the pH in the baby. Another thing I would like to tell here is when we talk about fetal scalp monitoring, we are taking a sample and we know that this is baby's condition in that particular moment. If we have to continuously monitor the baby, we have to take multiple samples. But when we talk about CTG, we can monitor the baby for hours and hours together without any intervention, without any invasive procedure. So, and the result of fetal scalp monitoring can also be affected by meconium or contamination from maternal blood. The site of the puncture, when we talk about fetal scalp monitoring, is important. Like Dr. Chandana has already mentioned that if we take the sample from a capper, then we are going to have a wrong reading and we will not have a correct result. Fetal scalp monitoring can also lead to certain complications like CSF leak in the baby, hemorrhage, scalp abscess, and in some cases, hemiplegia is also noted. So it is upon us to decide what is beneficial for our patient and what is more important. But I personally believe that yes, when we go for proper interpretation of a CTG, it's enough. And in present times, I would say trying to avoid unnecessary section is not that important compared to giving a better fetal outcome to a mother who has been waiting for that baby for 9 months. Thank you.
Hypoxia is a multifactorial, right? Rather than looking at the single parameter, you need to look at multiple parameters. When you are looking at the scalp pH, rather than looking at the pH alone, when you look at the lactate levels as well as the base excess, it makes some sense. And ultimately, it doesn't give any evidence. That's what the previous presenter has presented here. Rather than looking at the fetal scalp blood pH or anything else, instead of looking at umbilical arterial blood gas analysis do give a better prediction of a fetal hypoxia, and it should be a conclusive evidence with multiple multiple things, because CTG has ultimately went into unnecessary cesarean sections. That is what the literature says. So when you have multiple things, you interpart. Only interpart. Right, right. So what I mean is, we need to look at multiple modalities so that we can have a better evidence. If you have a better studies looking at all these things, one can plan these studies in future. So you have a better evidence to formulate a proper guidance for the obstetricians. Thank you so much for your wonderful talks on fetal scalp pH as well as CTG. Thank you.
Both the presenters have argued very well. I think the debate has ended, but the discussions will be continued. I think even after 10 years more, we might have such discussion. And as we must accept that in true academic spirit, there is no winner or a loser. And out of enthusiasm for excellence, I think such invasive procedures, more so in our country, should be very cautiously approached. I know as a practicing pediatrician, I see many of the babies sometimes with some deformity of the nose and ear. They even come and blame that the obstetrician was so rude enough, putting the stethoscope, she pressed, might be because that has caused the nose. So leave alone the procedures. So not to discourage you to go ahead, but I think it should be individualized. So
I just wanted to add something in continuation of what it is. It is a litigant word. And I think the whole scalp pH came up from the countries where insurance was ruling and they had to prove there is distress to do a cesarean. So luckily we are not in that country. So any invasive thing, think twice, because anything you are going to be at fault. In the world of litigation, you do that, that is also a problem. You do this, there is also a problem. Try to avoid what you can avoid.
Very good.
Thank you, sir. Thank you, ma'am. For want of time, we are not opening this session for questions because I know it will probably stimulate a lot of discussion. But we are standing between all of you and lunch, and hence we'll break for lunch now. And we have a lot of interesting sessions post lunch, so please don't miss out on them. And we have also kind of decided that the certificates are strictly meant for everyone who attends till the end. So please do bear with us. Post-lunch, you have surgical conditions complicating pregnancy, as well as neonatology section and IVF. Now, I just request everyone to just be standing where you are for a brief group picture. Maybe you can just stand or sit in your places. Sitting might be better. Just for a second, so that we don't miss out on this opportunity, because we don't know whether we'll all be meeting back post-lunch. Some of you might be busy, so we'll just have a brief group picture. The cameraman will take them here and you can all visit.
Let's change this now. Well, let's see this.
Lunch is 2:15 okay with everyone? Short. What time is it now? 1:47. We originally had planned 1 hour for lunch, keeping some buffer. Shall we wind up in half an hour? So we all meet at 2:50, 5 minutes buffer. Please try to join us on time.
Request all of you all to please visit the stall on collagen. For all obstetricians, skincare is important, immunity is important. There's a stall on collagen that is available, and there is a stall by newborns also at the same area. Pick up your free samples of collagen without pay.
బియ్యం కాల్ తింటున్నా ఇప్పుడు ఎట్లా బయటకు వాళ్ళకి మనం అన్న కాల్ బియ్యం బడికి బయటకు ధన్మని ఆడు బయట అయినా కానీ అడుగు నేను
సార్ ఎట్లున్నారా? తింటారా?
అయిపోయింది
తినాలి కదా? చూడండి సార్, ఎంత కష్టపడి టెక్నికల్ బేటా अब काफी वन साइड जाने बैठे ఫోన్ మాట్లాడుకుంటే క్వశ్చన్ లెక్చర్ లేదండి మాట
ఇవన్నీ తీసేవాను గార్డు టచ్ చేయమని చెప్పారు.
నడుస్తుంది
చెప్పండి. శ్రీకాంత్ నేను ఒకవేళ ఇక్కడ రమ్మని చెప్పండి దగ్గర పెట్టుకున్నాను. లేట్ నడుస్తుంది ఇప్పుడు రిజెక్ట్ అయిపోయింది. హాఫ్ అన్ అవర్ లో లేట్ వచ్చేస్తే కలిగితే
మంది పోయే ఉంటారంట.
ఇది అయిపోయి దీని టెస్టింగ్ అవుతుందా దీని మాట ఎంతమంది తెచ్చింది దానికి నేనేం చేశాను దానికి ఫస్ట్ 2 రోజులు చెప్తారు.
Take the mic. Put its hand in.
ఆపేస్తున్నారు దీన్ని ఎవరుకున్నాడు ఆఫీస్ పెట్టేసుకున్నారు సరే క్వశ్చన్ చేయలేకున్నాను సంబరం సరిపోతా సంబరం సరిపోతా పంపించేయండి ఎక్కడికి
ఇక్కడ వాళ్ళకి హ్యాండ్ ఓవర్ ఇచ్చి అక్కడ నుంచి స్టోర్కి ఇచ్చేయమని చెప్తారు మనకే ఇమ్మని చెప్పను దిలీప్ గారిని మళ్ళీ స్టోర్ కి హ్యాండ్ ఓవర్ ఇచ్చేవాళ్ళు పోడియం కూడా తీసుకెళ్తారు
No, sir. I just want to see the slide.
నెక్స్ట్ ఎమ్మట మీదే ఉంది సార్ తొందరగా లంచ్ చేస్తాను.
విండో ఉంటుంది కదా సార్ గూగుల్ బాగుంది విండో ఓపెన్ చేస్తారు మీ విండో తగ్గట్టు ఒక అట్ట ముక్క కట్ చేసుకోండి ఓలు పెట్టండి స్లైడింగ్ డోర్లే కదా ఒక డోర్ ఓపెన్ చేయండి అట్ట ముక్క ఏం చేస్తారంటే ధర్మకబులు అట్ట ముక్క దానికి ఓలు కట్ చేయండి అందులో పెట్టేది అయిపోయింది దోమలో బయటికి లోపల రావు అట్ట ముక్క క్లోజ్ చేసేస్తే అయిపోయింది దాని తగ్గ హోల్ పెడితే సరిపోతుంది మరి అడ్జస్ట్ అదే కదా మరి అది అడ్జస్ట్ అంటే కండెన్సర్ అటే కదా పోయింది మరి మనకి అవుట్డోర్ ఏంటి బయట ఉండడం వల్ల మన కండెన్సర్ మీకు తెలియదు ఇది ఇన్బుల్ లో ఉంది కాబట్టి దీన్ని ఏది అడ్జస్ట్ చేస్తుంది కండెన్సర్ హీట్ మూడు వేరే పెట్టే ఉంచేసుకుంటాం తెచ్చా మళ్ళీ పెట్టాలి సాయంత్రం ఆడి దాంట్లో ఏ ఏసీ పెట్టినా స్మెల్ వస్తుందంట ఎన్ని పెట్టి ఎన్ని చేసాం చేయడానికి ఏది పెట్టి లిమిటెడ్ మార్చాం మేము మళ్ళీ వేరే తీసి వేరేది పెట్టాం అయినా స్మెల్ వస్తుందంట పైన అన్ని క్లోజ్ చేసాం ఏది పెట్టినా ఏదో స్మెల్ వస్తుంది ఇది పెట్టినా స్మెల్ వచ్చింది అంట ఇది పెట్టే సరే సర్లే ఇది పెడితే కొద్దిగా బాగుంది ఉంచేసేయండి అన్నది కనెక్ట్ చేయాలంటే వచ్చి అడిగేది ఆల్రెడీ మనకి ల్యాప్టాప్ తెచ్చుకున్నారు అదే ఇప్పుడు లంచ్కి వెళ్ళారు వస్తున్నారు ఫస్ట్ ఫ్లోర్ ఉంది కదా దాంట్లో ఇయ్యాలని చేసినాం కదా ఒక ఏసీ పోయినా కానీ లింక్ అప్ కదా అక్కడ ఎండోస్కోప్ ఇవన్నీ ఉన్నాయి కదా అల్ట్రాసౌండ్ ఇవన్నీ చూసినప్పుడు కూలింగ్ వస్తే పని చేయాలి మీకు ఎక్కడ మనం పెట్టేది అయితే అట్లీస్ట్ లాస్ట్ టైం అదే ఇష్యూ వచ్చింది పెడితే presentation free లో ఉంది అక్కడ. చూపిస్తాను మేడం చదువుతుంది. ఇందులో అన్ని పెట్టేసి ఈ అమ్మాయి పేరేంటి? ఓకే నడుస్తుంది కదా ల్యాప్టాప్ పెట్టేది సార్ ఏదంటే శివరాజ్ మనోహరన్ ఉంది చూసాం. ఈ ఫోల్డర్ మొత్తం ఆ డెస్క్టాప్ లో కాపీ చేసుకోవాలి, ఎందుకంటే కొన్ని వీడియోస్ ఉంటే ప్లే అవ్వవు రిమోట్ లోంచి. అదేనా ఏదో అలా వస్తే చెప్తాను నేను. మేడం వాళ్ళ హస్బెండ్ ఉన్నారు కదా, శివరాజ్ మనోహర్ పీపీటీ అనే ఫోల్డర్ వచ్చింది. ఆ ఫోల్డర్ ఇంట్లో ఉంది, దాని నుంచి కాపీ చేయండి. దాంట్లో ముందే కాపీ చేసి పెట్టుకోవచ్చు. ఇంకా ఆన్ చేయలేదు మీరు. So
we welcome you back session. And we have a very exciting module now on the surgical complications or conditions complicating pregnancy. Among us, we have Dr. Matula Anagani, Consultant and now laparoscopic surgeon teacher who is going to address you about something very unique and very interesting. And to do this, KIMS Cuddles Kondapur, Dr. Shilpi. It is the next pleasure to invite our esteemed guest today, Dr. She is a very well-known personality, not only for her medicine, for her activities also. And she is a person who never says no. She's always there whenever you meet, whenever you invite her, she's always there, first come first for all academic activities.
Final one.
This is her passion. In clinical work, it is also her passion. This is what she's learned over years. That very few clinicians do. And that quality is something that keeps her unique from others. And she is a passionate person in terms of medicine because she keeps learning new things and doing new things and pioneering new things so that there is discovery and there are certain things made just for her to do and give it a name and spread the word. That's Dr. Matula from my point. Thank you.
Dr. Shilpi for a wonderful. Thank you, Dr. Aparna, for having me for this wonderful CME over here. So I think today, post-op, I hope you're not going to sleep. And like somebody said, I will never allow anybody. I'm sorry, post-lunch. So this shows that. And like somebody said, I am one person who will never allow anybody to sleep. So that's where we are. And there's something new, innovations and creativity which keep coming, which is for the benefit of the mankind, benefit of us, the world where we are in. Unless we give the options, tomorrow somebody is going to come back and tell us that why was this not given? So saying this, I say that we are all taught from textbook and where we try to fit our problems into the solution, which is already known in the textbooks. But remember, as we go ahead and do, there will be a next generation which will come up and say that this is what is right. What was written in the textbook is something different. So we are not here to say somebody is right. We are here to just give them different options where future becomes the norm, and that becomes the norm with which they go ahead and give the options to the patients. And that's where we are here. And the quest for innovations is the need for the day. And it is us who led it here. So innovation is the one which differentiates between the leader and the followers. And definitely that is what we all of us want us to be, because that is where is going to be the future. So coming to the basic topic of the today we thought regenerative medicine, everybody knows in so many other fields, but in perinatology, where we always get worried about ethics, pregnancy, where even dolo in pregnancy, we think twice to think about it. That's where we are in about the ethical dilemmas and what go ahead with it. So is it fact or is fact fiction? And I like I always say, seeing is believing. So let us see what is it, what is there, what is happening, where we entered and what we could do for our patients in today's time. So it is, we all know Telugu, we always want to say we are the best, we are the best. We got the Oscar. We got Oscar for RRR, right? Triple R. So triple R is regenerative medicine. That is, it replaces, it regenerates, and it restores the thing. So this is what we need to remember, so we don't understand, we don't forget that what we are in for and what we're going to offer. So we have various things. I just put one slide about it because I don't want to tell too much theory. So we have stem cells, we have other cellular therapy like PRP and PRF, and we have all scaffolds which come from 3D printing, from technology, that is by tissue engineering. Then we have gene therapy, which is between stem cell and which is where in the cellular therapy. That is where we need all the this thing from the government. We need all the permissions. Whereas when it comes to stem cell therapy and cellular therapy, when we are using autologous, we do not need anything. Remember that first point. Second, tissue engineering also, we do not need any permissions when we are doing it for those things. So we are looking at innovative therapies, probably a cure. Till now, we always say these cannot be treated. Like endometriosis, only we talk about something which we can suppress. So can we do something where we can do, like I said, rejuvenation, allowing the tissue to heal itself. Replacing organ replacement. So future a day will come where, oh, you want a kidney? It's there, go take it. You want a heart? Go take it. So there is no rejection. This is what we are looking at, rather than looking for all the illegalities which happen and the kidney rackets which come out. So that's what we look at, and regeneration is restoring the tissue and organ function. So keeping these three things, what can we actually do in perinatology? So from a clinician perspective, like I said, I don't want theory which is there in the net. I'm not interested in that. So for me, what is important? What is the basis? Am I be doing the right thing by doing it or telling and offering it to the patient? What to use, where to use, how much to use, what is the technique to use, so that I do not overdo it or underdo it, and the results are not coming out the way we want. And then say it doesn't work. It's very simple to say it doesn't work. But are we doing the right way? Are we activating the cells? That all makes a huge difference about the outcome. So finally, you make patient pay, whether it is 75,000 or 1 lakh or 2 lakhs, whatever it is, will it work? Patients are ready to pay if you say that, yes, this is the only option left over and it is the only chance you have. And if you give out the results saying that it will work. So this is the basis on which I work. So this is what I look at. So it is definitely an emerging field. But definitely in perinatology, there are a lot of challenges we are looking at. One, we are looking at congenital disorders. Second, we are looking at anomalies, fetal anomalies. It can be structural, complicated anomaly. And we are looking at preterm births can be avoided so that the neonatology stays calm down, and the costing and the whole dilemma about what is going to be happening to the brain of the fetus is something which is going to come down. So regenerative medicine definitely promises it. And some videos which I'm showing here, all of you can take home and start doing it in your patients from tomorrow itself.
So applications would be first CRISPR technology, fetal therapy, which is I think not in India as of now. None of us have done it before. So amniotic fluid stem cells can be used for fetal injuries or abnormalities in US. It is not used because of ethical thing, but there is a pharmaceutical based company based amniotic fluid which is very expensive. We have the amniotic fluid in front of us when we are delivering. We use it regularly. Where do I use it? I will show it to you. Then we have placental repair regeneration. We look at IUGR, we look at preeclampsia. Can we just go ahead and do it something which we can help in preeclampsia? And then next, preterm birth. That's where I'm going to show you the videos how we can avoid that. So other things, neonatal brain injury, this is where the neuro guys started doing a lot of stem cell therapy, and they say they claim good results. So I have no idea about it. Congenital heart disease is where we have a scaffold on which the tissue is developed and that is put inside. So these are all the applications in perinatology where regenerative medicine can be utilized. As an obstetrician, we are looking at something for the preterm where we can decrease the maternal and fetal morbidity is what we look at, along with the scar and amniotic fluid where I can use it. And so challenges would be first, will there be an immune rejection? We are using autologous. So immune rejection is out unless, again, it's a completely different HLA typing which we are using. Second, if I use the cellular therapy in the form of PRP, definitely there's no question of immune rejection because I'm using the same maternal blood for PRP. Second, it is definitely difficult in replicating complex organs. So if you are looking at anomalies, making a scaffold, 3D picture, growing the stem cell on it and making the organ and putting is going to be a long way. There have been a lot of thing which has gone into it. And the first person who actually made a trachea is in the jail now. So let us be very, very skeptical when we are talking about things of organ replacement with a 3D picture and then making it for those, whether they function or not is the thing. That's where you have a replica model on which the stem cell comes. That's where it's supposed to function. But it seems that they have done a lot of testing in this and the projections were wrong. So that person was in jail. So high costs which come with stem cell therapy. So we came up thinking that can we do something where we don't have to make it costly and then do what it is? These have been a lot of our publications in various journals about our regenerative medicine and everything coming from there. In our practice, we started using it for PROM, pre-PROM, 20-22 weeks. Then amniotic fluid into the cesarean scar and the abdominal scar. So these are the two things where I've used, and we had very, one single case with the help of the neonatology unit of KIMS Cuddles. We did use it for it, which was not a success. So we just put it at the last because due to social reason, we could not continue the baby's intubation after that. So there's a rare case of bilateral diaphragmatic paralysis where after fundoplication, we did use the PRP. I'll show you that video also. So therapeutic focus for PPRM will be, we want it to plug. First thing we need is just like the CSF leak, how we do a spinal patch. We are giving PRP and PRF that is going to go and plug wherever there is something. It's an extrinsic factor phenomenon which we work for. This. Second, it replenishes the fluid because once that is done, rest automatically because it's a normal baby is going to replenish fluid and it should reduce risk. These are three things which we are looking at. We are looking at LICA should be normal so it does not cause any oligohydramnios syndrome to the baby and hypoplasia of the lungs. And we also look at repairing membranes. So we are having the amniotic fluid therapy, stem cells and PRP. PPRM, we hardly have amniotic fluid. But in US, people had used the pharmaceutical based amniotic fluid for it. What did we do? So PRP, how does it work? It works by anti-inflammatory, enhancing the collagen and the angiogenesis. For me, it is the growth factors, in fact. Once it comes a PRF, you have a delayed activity and the scaffold which will form. So in PPRM, it can be given nearer the rupture site or anywhere into the sac. It goes and blocks it. So in stem cells, if you are using it, it is tissue regeneration, paracrine effects, and anti-apoptotic and antimicrobial. We have not used it because we thought, let us try with PRP. If it doesn't work, then when it comes to ovarian rejuvenation, we use stem cell plus PRP. But when it comes to PPROM, our results have been good with only PRP and PRF only. So combination of PRP, PS stem cells also go a long way. So this is one case who had come to us with 20 weeks, 20 plus 2. It's an IVF, precious pregnancy, one abortion before, twin pregnancy. As usual, I tell 101 times, please do not do any C-months till 9th month. I think all of us should keep telling that. They go, they're so happy. They do C-month, next day leaking starts. Now comes viability part of it. The patient was admitted in some other hospital, 1 week conservative. They said, no, then the infection is going to come, terminate pregnancy. Then they listen from somebody, then come to us. We'll also try conservative for a week. It did not work. At 21 week, 3 days, this is the where licorice, there's absolutely no licorice T1. Then that's how we use the PRP and PRF. PRP is with activated citrate, whereas when it comes to PRF, it's a whole blood and it will be about 2200 RPMs. So once that is done, I'll show you the video. What did we do? I have the luxury of Dr. Chinmay Ratha, who is our fetal medicine specialist, to our hospital. So between both of us, we have done this case. We're under minimally invasive because it goes under ultrasound guidance. So where the licorice hardly, we could not get one single pocket with 1 centimeter also. But finally, luckily, we could get it into that. And then under ultrasound guidance, we can see the needle which goes. And then we had given the PRP and PRF, activated PRP. So it's the technique which is important. We need to activate it with the citrate, which is very, very important. Calcium gluconate with 0.1 ml with 1 cc of the PRP, which we make. So once we do that, and 1 week post-op, we have discharged her after confirming the licorice is absolutely normal. After 48 hours, first 24 hours, we did not make her move. After 48 hours, she was getting up, moving, and everything went on very, very well. So it's a simple procedure. That is what we did. Next, after this is the, as of today, she's 30+2 and ultrasound done 10 days ago, last Wednesday, is 2830, IFI is adequate, PPP 8/8, Doppler normal. So we could achieve, I don't know how long it's going to go, but something we have achieved is something definitely beyond viability and definitely something what neonatologists will be very, very happy about. So coming to that, we know that challenges would be that interpartum sepsis should be ruled out. So don't ever do it when there is infection which is there. That is something which we have to understand. And we are looking at PRP plus PRF because PRF goes a long-term scaffold, which gives a thickened, complete membranous thing which copes with it. So when it comes to things, sealing of the membranes, amniotic membrane healing and anti-inflammatory preparation, I just showed you how it is to be done. And then comes the potential benefit of long-term prolonging the pregnancy, decreasing the complications, and it is safe and it is autologous. So we do not need any permissions from any government ethical society. And it is from the mother's blood itself. Okay. And we don't need bigger equipment also. Your hematologist can do it. So benefits would be prolonged gestation, reduction in complication. It is minimally invasive. And challenges, I think in the future, it has to be standardized how exactly it has to be done. And that is what we are talking about. When I'm talking about ethical, it is not what we are using. It is about time to do. Are we too late in instilling it? Or maybe somebody will say, maybe you could have tried this thing and maybe we could have won. No, we tried everything and then do it. It should not be too late that infection sets in. It is not too early that we did not try any other method. That is what we look at. So coming to the next thing, that is the amniotic fluid in the cesarean scar or in the abdominal scar. So we started doing it a lot of these things because once I think when I was in US, that's when I had seen that amniotic fluid being utilized in it, but it's very expensive. I am like, why is it expensive? In India, luckily, we are not having all these people breathing down the neck who say that we should not be using it or anything. So same mother, same amniotic fluid, why can't we just, so we take about 10-15 ml when the baby is coming out into the thing and we inject into the scar, cesarean scar and the abdominal wall scar. So direct application, and then we can also use stem cell therapy into it. So take the amniotic fluid, separate the mesenchymal stem cells, and then put it back. But I think direct application is simplest, easiest. We don't have to waste time, and it is done. In the busy schedule of the obstetricians, it's much more easy to do. And then there are amniotic membrane traps which are used for many of the tissue healing and enhancing the thing. So, like I said, how does it work? It's anti-inflammatory. It is a rich in stem cell, anti-fibrotic. That's what we look at. And angiogenesis. So the scar can be tried for next delivery, trial vaginal delivery if you want to do it. So it is much more easier to do it. And second thing is, I will show you the thing. How do we do it? Into the cesarean, then and then. I just want this out. So we just along the scar, if I'm just going, because seeing is billing, I cannot show you the cesarean scar, how it looks afterwards. So I'm just showing you once the cesarean is done, we just go along in multiple points. We just keep giving it along the scar. That's it. And leave it. Within a week, we can see the difference. In 6 weeks, I will show you how it looks like. Doonte reh jayenge. You cannot see the scar. This is what this generation patients want. Absolutely, within 6 weeks, you cannot see. And after 3 months, where is the cesarean done? This is what it will be. So we are looking at no keloid formation, no hypertrophic scars. We are looking at good, adequate, no hernia formations. So please take advantage of the regenerative medicine, which is again, like I say, saying is believing. So this is the improved uterine elasticity and long-term complications. Like we are also looking at something which is increased incidence of isthmosis. This also will comes down once we start using this technology. Courtesy, the single layer, courtesy, whatever it is, we are seeing more and more scar ectopics and isthmosis. That also can decrease once you start using it. So challenges in future would be standardization, ethical consideration, and long-term safety. And there's always skepticism. This is one case which we did in this hospital. I'm just showing it to you. Unfortunately, like I said, we could not continue because of financial and social reasons. They did not continue ventilating the baby, but I wanted to show you this because we did try for this at KIMS Kondapur. So this baby, iatrogenic diaphragmatic palsy, the way the baby is removed. Unfortunately, true, it happens still in the remote areas. So when the plication of the diaphragm was being done, we went and we did a PRP into the diaphragm, which we did. And we could see after some time little movement of things, but then when the time came when we had to do a tracheostomy, they were not in favor of it. That's when they refused to continue the ventilation. So I really don't know how this would have gone. So I cannot tell you, but we did try all this with the help of the pediatric surgeon at KIMS. So in a nutshell, what do we have? We have some success stories and case studies. So please offer it. What are we in for? Future opportunities and challenges. What are we wary of is regulatory and ethical safety considerations. So there's a lot of studies, case studies which came for severe preeclampsia, which are very good for mother and thing. What do? Just put PRP or stem cell into the amniotic cavity. That's it. We don't have to go to the placenta and give it. We can just give it there. Then there are gene therapy and genetic anomaly, especially for spina bifida thing there. Both the things are done. Gene therapy for the CRISPR technologies for the gene which has to be changed, and also for the spina bifida, it has been the scaffolding of the 3D printing and using the stem cell technology has been utilized. Then also therapeutic for diaphragmatic hernia, but for this the collaborations are needed with the scientists along with the biomedical engineers. And there have been bronchopulmonary dysplasias and the studies for IUGR. I think in our, as a gynecologist, we can think of utilizing it for PIH, IUGR, PROM, and for the scars. This is what we are looking at. So ethical consideration is not about should we do it. It is here, it's going to stay, we should do it, but it's about right time of intervention, managing the risk, if at all, when you're going in and you end up touching something, whatever is happening, are you ready to take it for? And addressing the psychological concerns of the prospective parents. So again, like I said, it is an immune system maturity, low engraftment rates are what we have to look at. And such as sometimes fetal donor cells or engineering stem cells also can be utilized. So recent advances, what we look at is trials, more in trials, multi-central trials is what we all should come forward and do it. And technology integration along with the biomedical engineers and publications more and more, and collaborative research is what we look at. And future is about personalized care. Today I saw, I think, where world's first stem cell technology for type 1 diabetes is now successful and the patients are absolutely fine. So I think we are looking at personalized medicine. We are integration with the AI. It is here to stay, and global collaborations because we have numbers, they have technology, and we have technique. I think that's where we look at. So key takeaways will be there is a potential impact which we can do a lot of huge difference for the outcomes of the neonate and decreasing the morbidity of the fetus. So need for research is there, and collaboration importance and ethical vigilance. But science is discovering the unknown. There is so much more there which we do not know. So I think stem cell field is still in infancy, and we all should be thinking of how can we shape the direction of this particular thing in such a way that primum non nocere, we are not doing any harm to that. So let us pick up things which can only help and not do it. So to conclude, it is a game-changing area. We are looking at fully healing the damaged tissues and offering solutions and hope. And both the advances in developmental and cell biology, immunology, and other fields also will take a great way. And I truly believe there's a single light of science, and the shine it anywhere is to shine it everywhere. And thank you everybody for listening and giving me this opportunity. Any questions? Yes, please. Yes, sir.
It was an amazing talk.
Thank you.
And where do you inject this to the scar?
Into the
Is it subcutaneous or intradermal?
It is into just subcutaneous between the rectus sheath and the skin.
Amazing response. It was like a miracle.
Yes.
And what about this spina bifida and all that?
Yeah, that is all the issue. We have never tried into all that. So that's the reason I said when there's a collaboration here, we are also busy in our own fields. We all should tie up and think that we give the baby, we see this such a baby when somebody do not, for religious reasons also, they don't want termination, then we can offer this. So we should look at fetal therapies and we should look at patch with the biomedical. Spina bifida, first thing we need to rule out is there a genetic abnormality. If there is a genetic abnormality, then gene therapy comes in. Then spina bifida, the patch comes in. That's where, again, I know of one innovation center, Pranav Innovation Center, where we worked together, where he does a lot of 3D testing, where we do a stem cell scaffolding onto it. So we can all together take it to a different level.
What about BPD? Where do you inject?
PD.
Bronchopulmonary dysplasia.
That really, I don't know, that was a scaffolding thing. That is where they made the whole thing where they changed the completely from here to the day that made the day the unit is born. They have removed the complete tracheal and they put this the 3D thing, which was they already made. Once they knew there was a thing, they made a 3D imprint on which stem cells and they made it and they put it back. And they gave the results as if they have worked. But so-called it did not work and he was cheating. That is the case which went into the court and he was cheating.
Thank you so much, madam, for the new app. Thank you.
Thanks. Ma'am, are there any more questions? I'm not sure if I saw some hands go up. Okay. If not, we thank ma'am for that excellent talk, which was so informative. And ma'am, if you are going to be there, we would request you to chair the next session. 10 minutes. So for the next session, we invite Dr. Manjula ma'am to be one of the chairpersons. And ma'am will be joined by Dr. Girish. Dr. Girish is head of the Department of Anesthesia from KIMS Gachibowli. Yeah, any of this side. Maybe it might be. So I'll request now Dr. Girish to maybe introduce the speaker.
Hi, it's a very good evening good afternoon to everyone. So just it's my pleasure to introduce our esteemed speaker, Dr. Shivaraj, a renowned consultant, urologist and renal transplant at KIMS Gachibowli. So actually, sir is well versed in doing that urological emergencies and complications in handling the complications in high risk obstetrics. So it's over to Dr. Shivaraj.
Good afternoon to all. Thank you for having me here. And I'll be talking about this urological emergencies and complications being in a high-risk unit itself here. So my key discussions here will be about the urological aspects, physiology and anatomy related to the urologic, the high-risk obstetrics and urethral obstructions in the form of stones, infections, or any strictures kind of things. And I'll add about the iatrogenic injuries also and how to prevent immediate intra-op, post-op also. And I'll also touch about this placental anomaly, mainly about the placenta accreta spectrums and the minimal invasive surgeries which we can think. And I'll also talk about the medical legal considerations here. So anatomy and physiology, we'll always know that the uterus, growing uterus, the bladder is always displaced with lateral expansion and indentation of the domes. And there is also hormone changes, progesterone induced, the congestions and dilatations of the ureters and the bladders. And there is always incontinence also is there high. And there is increased plasma flow and the GFR. So the creatinine is always lower. So whenever the creatinine is high, there is something wrong. And as we know, there is elevated filtration load of sodium, uric acid, and this calcium citrate and all, which causes a high prevalence of stone incidence in pregnant ladies. And there's always a confusion between the physiological hydronephrosis and the hydronephrosis due to stones and other things. And we always see right side hydronephrosis more always due to this uterus dextrotation and left being cushioned by the sigmoid. And this hydronephrosis usually happens around the 7th week in 90%. It persists postpartum for 6 weeks. And not to forget, there is always a chance of acute urinary retention in pregnant women, which usually happens in 12 to 14 weeks of gestation. And this is usually due to the entrapment of the retrovative uterus with the entrapment of the fundus below the sacral promontory. And if there is fibroid, it's going to predispose. The problem here is this can lead to sepsis and other things if not attended properly. And also AKA and CKD can happen if you don't address immediately. And usually treatment is very simple with Foley's or clean intermittent cells catheterization. And sometimes manipulation of the uterus and temporary pessaries are being used. And coming to urosepsis, the main point I want to focus here is you identify and treat this asymptomatic bacteriuria. Because a single dose efficacy is 50 to 80%, it cures, and 3-day course almost 70 to 80% it cures this thing. But if the pregnant lady, if she goes into an acute pyelonephritis or acute cystitis, it has a high morbidity and mortality rate like maternal anemia, hypertension, preeclampsia, AKI, and there's high chance of AIDS also. And in fetus, there is preterm low birth weight and mortality is also expected. So a simple identification of asymptomatic bacteria is very important in preventing this complication. And antibiotics, as we know, penicillin and cephalosporins are very safe. And the other things, you all know these things, fetal dental stainings, cartilage damage with quinolones, and usually use in first trimester nitrofurantoin as a urologist. And regarding urolithiasis, the incidence is almost equal to a non-pregnant woman. And you also see this right and left ureter, the incidence is almost the same. And it is not like right, it is more common, left, it is more common. It's not like that. Both ureters can have equal incidence. And luckily for us, it happens mostly in second trimester only. Because we are able to save with a good obstetric team and NICU team, we are able to save both. We are able to handle all the stones along with this thing. And in a normal population, usually the stone is calcium oxalate, which are hard stones. But in a pregnant lady, it's usually calcium phosphate stones only. And this usually is associated, may be associated with the hypertension, preeclampsia, or it can lead to premature labor. So these are all theoretical things. Let me also, I'll talk as a practicing urologist here. So if a patient is being referred to us, usually we don't get referred. We just get a call and say, hydronephrosis is there, ultrasound, we are not able to find anything. Because the symptoms as such, a pregnant woman usually complains of a back pain. So they're not able to differentiate between this renal colic and this back pains. But if it is a urinary colic, the pain will be really severe. That one thing we'll have to understand. And then hematuria will be usually there because of the estrogen ureteric congestions. CE, there will be microscopic hematuria as well. But in stone also, there will be microscopic hematuria. But you will also have to see the pus cells also. Pus cells and these things you will have to collaborate and take a decision. And the ultrasound, when we send the patients for an ultrasound, they usually conveniently for normal non-pregnant patients, they give it as hydronephrosis and you can do a CT for correlation. But for a pregnant lady, they don't do that. They are always guarded and they give only a mild hydronephrosis. And we get into confusion whether to put a stent or try medical management because stones they are not able to see. How to overcome this is we always combine an ultrasound KB with the Doppler with the transvaginal ultrasound also. Then the accuracy improves almost to 80%, 70 to 80%. How we find out is we find the presence of hydroureter below the pelvic ring because actually the hydronephrosis will be above the pelvic ring, it is always it will be there. But when there is a hydroureter below the pelvic ring, usually there will be a stone. And there will be asymmetry, absence of ureteric jet. And people also should mention about the resistive index of the kidney. So the resistive index compared to the other, both we'll have to go ipsilateral and the contralateral kidney we'll have to find. If the resistive index is more on the stone with the hydronephrosis, then we take it as a stone. And CT can be done, but during the first trimester, usually we are all afraid to do CT only. But studies are showing that if it is less than 50 milligrays, then there is no fetal anomalies noted. And the MR urogram, we don't advise at all, but it's all fancy test only, the double king sign, because stone is not seen. But if we suspect some perinephric edema or pyelonephrosis or pyelonephritis clinically, And we wanted to document then if the patient insists or something, or the obstetrician insists or something, then we go for MR urogram. But most of the times we go clinically and with an ultrasound. And most of the treatment usually is hydration, antibiotics, and analgesia. Analgesia, we don't have anything, only paracetamol and rotavirine only we are going to use. So that's not going to help much. But you always add an antibiotic to it and see and hydrate the patient. Most of the patient they expert. Here, studies are showing that less than 9 mm, they pass around 70 to 80%. But in clinical practice, in the normal non-pregnant patients who are thin built or some, even 3-4 mm stones are getting stuck in the distal ureter. We see a lot of cases. So it's not about the size and all. We see the patient as whole clinically. History, ultrasound, all the blood counts, urine tests, everything you see, and then take a decision. And then comes the surgical intervention. Most of the time, thanks over. No, I think this will be useful for you. I'll take more time. So surgical intervention, most of the time it's like pain, if it is a solitary kidney, sepsis signs, if any of this is there, then we'll always have to go into the surgical intervention. No doubt about it. And these are key principles we use. Like we should have a proper gynecology team, obstetric teams and a NICU, everyone. Because in the second trimester, when it is around 26, 28 weeks, there is always chance of preterm labor, and we are able to proceed with the procedure as such. Because stones as such we see, it is not about going inside locally. Local meaning we say we just put jelly and put the scope inside, and it's not like that. When we go inside, sometimes there are chances that ureter might get avulsed, perifluid leak can happen, or we'll not be able to move the stone and just put this in. So always go with the intent that there is going to be some anesthetist who are here, and it should be done under spinal anesthesia only. And GA we are going to avoid it. So under spinal anesthesia, we have managed many cases. Like there will be some impacted stones, which we use laser only. Laser are very safe. We have Goldwing as well as thulium fiber lasers, which just blast so well, and just we create a space and then relieve the obstruction and then put a stone. That helps. So whenever you are going inside for these kind of cases, always inform your obstetrician. It's not just a stenting case. You're just going to put under local and come out. It's not that. If the patients are willing, we'll have to get an informed consent, break the stone, try to put the stent and then come out. If the stone is smooth in the proximal ureter, then we will be able to push the stone and put the stent. But most of the times when you go inside, what happens? The ureter is already dilated because the hormonal influence and the uterus compressing the ureter. The proximal ureter allows the ureteroscope to go easily. Once we cross the lower ureter, then we are able to go inside. And we have many flexible scopes, all these things. And these days, we are using supine PCNL also with ultrasound guidance. So if everything is possible in doing this, if we have a proper obstetrics, NICU and anesthesia, and if we plan that, we'll be able to do that. So these are some pros and cons of stents and ureteroscopy. The options are for stents, then ureteroscopy. I'll always prefer a ureteroscopy with a ureteric catheter placed and we remove it in 48 hours and the patient is fine. Or if something happens, always we put a ureteral stents and come out. If you expect some infection or the residual stones are there. So these are some videos where we have done the ureteroscopy and pregnant ladies. So with see, this is what we see inside actually. The stones will be impacted, if you see here. The stones will be impacted. It will not be easy to push, and if you try to push it, it will perforate and go into the ureter somewhere. So we always go with the intent that we forget that she is a pregnant woman, and these things will be taken care of by the obstetric teams. The baby will be taken care of by the neonatologist. We'll have to go inside, break it with laser smoothly. Don't touch the mucosa, just make a hole in the center of the laser. Laser settings are very good. They just dust very good. And then we'll be able to put a stent and come out. So no other option, then we go for a percutaneous nephrostomy, but it is very traumatic for the mother and other things, keeping the nephrostomy throughout the whole of the gestation. So always try to give a clearance. So I want to talk about this topic also. This is also an emergency. So the placental anomalies, you all be well aware with the definitions, placenta accreta, accreta, percreta, all those things. But the accreta spectrum, usually, it is in 1/500 of pregnancy. Actually, the accreta is increasing. As far as I am concerned, I have seen all these cases during my in Stanley Medical College in as a PG only, where we were resecting the bladder wall itself and repairing the bladder itself. So that time I was not understanding so much that these things are so common. So the risk factors are prior C-sections, IVF, prior uterine surgeries, more of maternal age. All these are complicated. I mean, the incidents are still rising. So bladder injury is more common in these things. It's not only about the bladder injury, the bladder infiltration is also the issue here. So once you go inside and try to mobilize and touch these vessels, it bleeds like hell. The whole field will be full of blood. So there comes this pre-op intrauterine embolization, ballooning, all those things, and we'll have to put a stent before. And if bleeding is not stopping, you just open the bladder and stop it from below. And on the other side, there's also vaginal packing. You should do uterine packing. So these are some pictures where we remove that uterus along with some bladder tissues also. And the urologic neoplasm is also, as an emergency, we can see in this, like in angiomyolipoma, there is always a risk of rupture and hemorrhagic shock. This you should keep in mind. And iatrogenic injuries, we all know vaginal delivery, episiotomy injuries to the bladder. And bladder injury, anybody can close. I mean, but it is that we can do a single layer, double layer closure. Just we need a watertight anastomosis. But thing is, you always keep a urologist with you there, because there is sometimes we take the suture along with the ureter near the trigone. I'll show videos of those things also. And the C-sections, ureteral injuries are there, bladder injury repairs are there. And depending upon the locations, and this thing I want to show, it's not, I'm not able to get this ureteral stent. These are transluminant stents where we can be able to put a stent inside and we are able to transluminate. The whole ureter blows like this. Only a blind person can injure the ureter if you go like this. So I think for any complicated cases, we should have this either a transluminant stent or a fluorescent stents. And this is like, people say that stenting prevents the ureter injury, but here is a case where they have put a 6 French stent, but the surgeon, they've thought it is a fallopian tube and they've cut along with the stent in situ. Actually, the stent is inside. It is one part of the stent is in the bladder, one part is in the kidney. So it's not like stenting always prevents this. If you can see that both here, this is the lower end and this one, it just looks like a fallopian tube. They were saying not able to identify also, but there's a stent inside. Then we did a Boyer flap. We did. So these are some key takeaways of ureteric injuries. And this, we always lower ureter. It is always better to do a reimplantation than an end-to-end anastomosis. Always Boyer flap and so as it should be in line. These are laparoscopically, we did some flap repairs, Boyer flaps. So delay presentation, vesicovaginal fistula, retrovaginal fistula, sphincteric injury can happen. And this thing you can see that inside ureter, there is a proline or vicarious stitch being made, which caused uretrovaginal fistula.
Thank you, Dr. Shilpi.
Thank you.
Yeah, it was a wonderful presentation. But
is very important.
Yeah, that is what I want to say.
Yeah.
We want to have a urologist just for the sake of medical legal thing because we have done. Otherwise, I think in today's time, if gynecologists know how to do it, they can do it. That is what you have. But you should have a thing. Second one point I have to say, ureter stents always causes problems. Stenting is only for intraoperative when in doubt that you have caused a cut, not to prevent. It makes it more rigid, so you will go and end up doing. If it is not rigid, you just have to open the posterior layer, it falls back, it retracts by itself. You put a stent, it is making it rigid, it is bound for two complications. So stenting is when you have a doubt you have created problem to know if you have created problem. That's it.
Yeah, ask a urologist to put a stent.
No, actually, they'll put the stent. So why do we have to call them unless when in doubt? That's it. Thank you, sir.
Yeah, don't keep us a secret friend. They keep us friends with benefit in a good way.
Coming to the anesthesia department, we have to take care of the two lives, the main thing, the mother and the child, and along with the emotion standing out of the operation theatre. So as sir said, we can't give all the drugs, whatever the necessary, what we think, but we have to keep mother and the more important, the fetus in our mind. So whenever you're in the medications while operating urological procedures or any emergency cases on a pregnant lady, we have to avoid which affect the fetus, and the outcome has to be the best for the mother and the baby. That is the thing. Thank you.
Thank you. Thank you, Dr. Girish and Dr. Shivaraj. We move now to another important surgical aspect complicating pregnancy. We request Dr. Girish to continue to chair this session. And we are going to be joined by Dr. Sai Lakshman Ane, sir. Can we have sir's CV slide on the presentation? Sir is Chief Orthopedic Surgeon and Joint Replacement Surgeon from KIMS Hospital, Kondapur. He has been trained in pain management from Johns Hopkins, USA. He's a Program Director of Minimal Invasive Surgery and Accelerated Recovery and Rehabilitation Program, Head of the Department here at KIMS Kondapur. And recently, they have ventured into robotic joint replacement surgeries and have completed many hundreds of them. And sir is also the Director of the Fellowship Program in robotic arthroplasty. So it's my pleasure to welcome you, sir, to chair this session. And he will be joined by Dr. Ganga Sirisha, ma'am. Request both of you to maybe come on to the dais here. Dr. Ganga Sirisha is consultant obstetrician. Maybe have ma'am's slide. Ma'am is the director of Sirisha Hospital in Chandanagar, a very passionate obstetrician. She specifically requested me to keep her introduction very small, sweet, and simple. And but she's full of hands-on experience with dealing lots of high-risk pregnant mothers. And we request the three of you to go ahead and chair this session. We request you to invite Dr. Venkatesh Bolineni for his session on embolization and complicated PPH.
By the time Venkatesh comes and sets up his talk, I would like to thank Dr. Shilpi and Dr. Aparna for this. I was not invited for all the CV that they have put up. So this is their way of getting back to me. Not even invited because I am the academic in charge for the academics at Kondapur. So, because we are on the other end of the spectrum. You are the welcome committee. Anybody who comes to this planet, you are orienting them. But we are like send off. As a geriatric specialist, we prepare them for the eventual. So thank you. And with that, Venkatesh.
Good afternoon, everyone. And my name is Dr. Venkatesh. I'm a consultant vascular endovascular surgeon here at KIMS Hospitals, Kondapur. And the topic given to discuss today is embolization in difficult PPH. So what makes it a difficult PPH or complicated is when the patient lost significant amount of blood, that's about more than a liter. And the patient had a significant hemodynamic compromise with the signs or symptoms of hypovolemia. And the most common reason being the uterine atony. That means that contributes majority of the PPH that complicates. And when it comes to significantly patient having a hemodynamic compromise, the first thing which we always consider getting a lab panels in the PPH is the basic of complete blood picture along which contains platelet count along with the coagulation profiles which contain PTNR and APTT. And beyond this, there is an fibrinogen which plays a major role not just in the quantitative analysis, but also it determines the outcome, the levels of fibrinogen levels. And we do often get the ABG levels to see the patient is in acidosis or to look after how's the carbon dioxide levels and along with that bicarbonate levels, because all these factors play a significant role in bleeding. And if the patient is exsanguinating, you might have to correct all these ABG levels, which are particularly acidosis, calcium, ionized calcium particularly, and bicarbonates. And when the patient is in DIC, and you might have to look for other causes, what is contributing to DIC. And in patients with RPOC, where the patient is in sepsis, look for coagulation profile with the fibrinogen levels to assess the severity. And there are plenty of studies telling us the importance of the fibrinogen levels, and along with the whenever the patient comes to you with exsanguinating and in hemodynamic compromise, along with the fibrinogen levels, you might have to consider how much blood transfusion was patient already underwent. So there is a significant amount of studies which tells us if the patient is already given more than 4 units of PRBC with a low fibrinogen levels, that too particularly in Indian scenarios where the less than 150 mg, 150 units, that is bound to have more bleeding tendencies, and the outcome is a bit poorer when compared to the other patients. So coming to the anatomy of the uterine artery. So as we know, the aortic bifurcation at L2, L3 levels and beyond that, it runs as a common iliac artery and divides into internal and external iliac artery. The artery of importance here is the internal iliac artery, and as soon as it gets beyond 2 to 3 centimeters, it divides into anterior and posterior branches. The posterior branch of not of much importance here because they supply majority of the gluteal and the iliolumbar and sacral arteries. The anterior branch, which is in the anterior branch, the first or second branch which comes out is the uterine, and it is very easy to identify because of its pores and the anatomy. It generally takes a U-shaped curve from the base of the cervix and reaching up to the top of the fundus. And so these in particularly the anterior branch of the internal iliac uterine artery. So it runs along the side of the uterus up to the fundus, and the main reason which I had to put this dissect more and then put this slide is because after doing plenty of uterine artery ligation and embolization, some people tend to bleed. So the reason being of extensive collateralization, because the uterine artery is not only the branches of internal iliac artery, it gets its blood supply from the ovarian artery, which is direct branch of aorta. And beneath, we often tend to miss the vaginal branches, which is also a different branch from the internal iliac artery. So all these are of particular importance, which I'm going to tell in the later about the place where we put a surgical stitch to stop the bleeding, and the place where we have to embolize if we have a particularly focal area of bleed or we want to knock off whole of the uterine artery. So angiographic picture, the uterine artery is very distinct. Any neck I can easily make out. These are the two uterine arteries which you can make out, 1 and 2 on the both sides. And it is very distinct from the rest of the internal iliac branches, very hard to miss in the even in the open approach or in the angiographic pictures. So as colleagues, you are well aware with the open surgical ligation, there are plenty of procedures where you do bilateral ligation with the different techniques, O'Leary's and triple ligation, 5-point ligation, everything is there. And these are very good at their success rates because they carry 90% success rates and low complication rates when compared to, so the second point when we do, when it's difficult to do this uterine artery ligation, the second thing which we go is completely knocking off the internal iliac artery. So ligation of internal iliac artery is more difficult to perform because of the bulky uterus. You need to go deep into this, close to the sacroiliac joint, and dissection at that time when the patient is hemodynamically unstable, taking much of time is quite tricky. So that's the reason it is more difficult to perform, and the effectiveness is also the same. So I have put a surgical slide where they demonstrated in this is a slide which I had taken from the ACOG ICOG Foxy article, and where they had mentioned high ligation, low ligation, and multiple 5-point ligation. This is as the embolization is just a radiographical image what we are doing as an open procedure. So the embolization here, when where do we want to do the So the embolization also, we have to choose which point do we have to stop blood flowing from, whether it is whole of the uterine artery or it is close to the point bleed. So this uterine artery embolization procedure is an invasive step for conserving uterus for the further future. So, and when the primary steps deemed ineffective, and then we need to proceed for the embolization. And this is not only in the PPH where there is and other situations where the patient has got a RPOC and then AVMs with bleeding and ectopic pregnancy with bleeding. And the success rate of this embolization is more than 90%, which is comparable to the open. It's a simple procedure carried under local anesthesia where we have to access one artery, that's a femoral artery, ipsilateral, where we can cannulate both the sides, and small sheath, 5 French sheath, and then The point of embolization is the thing which we have to see after taking initial angiograms. So here is the focal bleed, which you can see from the left side uterine artery. With here, you doesn't need to knock out all of the uterine arteries on the both sides. Selective embolization, getting the catheter into the bleeder side. But the problem is, this picture where you can see active blush here in the angiogram, very unlikely you will be see every time, because the patient is bleeding, patient is in hypotension on NORAD, multiple inotropes, where you can't see particularly these kind of bleeds. These kind of bleeds which you can see when the patient is a bit hemodynamically stable. Because if you have to angiographically appreciate a bleeder, it should be significant, at least 1 ml per minute. So very rarely might see these things, and we will be able to embolize a particular bleeder from one side of the artery. On the other side, these are normal angiogram. Before we go selectively do uterine artery embolization, we always take an image from the aorta to see how dominant is the ovarian artery. These are because the failure rates of uterine artery embolization all depends upon the collateral circulation from the ovarian artery. So selectively go and embolize if it is only the uterine artery contributing to the bleed, or you might have to knock out the ovarian artery depending upon, and might have to explain the family because you are knocking off the artery blood supply to the ovary, and then ovarian failure is imminent. So this is a dominant ovarian artery, which you can see as good as the uterine artery supplying, and this is a direct branch of from the aorta. So you ligate the uterine artery, you embolize the uterine artery, patient still continues exsanguinates, you put the blame on the DIC, but here is the target vessel. So the reasons for failure, which I said, is around 5 to 8% because of the extensive supply from the ovarian artery. How better is uterine artery embolization when compared to IA ligation? Yes, you are on table, patient is on table, the abdomen is open, it's easy to ligate both the internal iliac artery. And what is the implications of ligating both the internal iliac artery? Because as I said, there are anterior and posterior branches. You are knocking off the arterial supply to the gluteals and lumbar and sacral, and majority of our patient population are, I presume, they are non-atherosclerotic because of the engage. If the patient has significant atherosclerosis, where the spinal cord ischemia can set in very easily, leading to paraplegia. So that we don't want to see in situations like getting both on. We have not apprised the family about the situation, neither the obstetrician about that situation, and do bilateral internal iliac artery ligation when particularly have been called for is tricky. And you don't want to have the urinary bladder and the rectal mucosal necrosis when the patient has come for a completely altogether different problem. So how much different? What's the major significant differences between the open and embolization is? In the open ligation, the proximal is the ligation, and then whole of the blood gets arrested. And the uterine artery, you know where to embolize. Whether you want to ligate the, you want to embolize vaginal branches, cervicovaginal branches, or just the uterine branches, that depends upon the angiogram picture. And the success is after ligation, you might have to wait and watch, close the abdomen, close the uterus, and then wait and watch. If the patient exsanguinates in the postoperative period, again you are in a tricky situation, what to be done. But in the uterine artery embolization, you know immediately whether you take an angiogram, if it continues to bleed, and then you do embolization of the ovarian artery depending upon the findings. And the anesthesia, the embolization is carried out completely under local anesthesia, provided the patient is stable. And collateral supply, then you get an angiogram pictures. If the collateral supply is still there, you go knock out the vaginal branches, which is completely altogether a different branch from rather than the uterine artery, directly from the internal iliac artery, and the ovarian branches also. So the complications, yes, access related complications are always there. Now they can hematoma, they can clot in the access artery, and the patient particularly complains of post-embolization syndromes like pain in the lower abdomen and the fever, nausea, and there is ischemic uterus which can catch a bug, and patient will land with a sepsis. So you might consider putting long-term antibiotics to prevent this sepsis. And non-targeted embolization is the embolized particles sometimes retrogradely flow into other arteries, and that causes bladder, rectal necrosis, and the gluteal claudication, which is unexplained for particularly to the patient. So there are a lot of studies which had said the embolization, uterine artery embolization is superior, inferior, and coming to couple, I've picked around 5 studies which are chronologically there in the published in the different articles, different journals. So when we embolize, what we don't want is this particles going and occluding the ovarian supply. So unintentional, that's happened, and there are studies showing that ovarian dysfunction post uterine artery embolization. And inpatient, see, this is an article which I am not comparing uterine artery embolization with an traditional myomectomy, but I am trying to extrapolate the results which is being published here. I'm not arguing with my obstetrician colleagues regarding with the fibroids, the embolization is better or open surgery is better, but trying to extrapolate. So when there is the blood supply to the ovaries are stopped, there is a chance of getting menopause within a year after uterine artery embolization. And here is the study where they have compared with the pregnancy rates, complications, ovarian function, and reserve. They said the benefits for embolization and are better when compared to the traditional myomectomy. And this is a highlighted study where we mentioned the complications post uterine artery embolization. Then it can be offered to women who are desiring pregnancy with fertility, and miscarriage rates are comparable to that of age-matched general population. And finally, the open surgical techniques to the endovascular techniques to the other procedures, the uterine sparing surgical procedures to control postpartum hemorrhage, there is no evidence that the future fertility or subsequent obstetrical outcomes are impaired, and they are non-inferior to any other procedures when compared to the ligation of the arteries or internal iliac arteries. Thank you.
At the outset, I would like to thank you, KIMS Cuddles team, for giving me this opportunity, Dr. Aparna and Dr. Shilpi. Thank you, sir. You very well illustrated all the, even including the blood supply in detail. So to understand exactly where you're embolizing, like what is the process exactly, like what do you use to embolize the artery?
So what we use in postpartum hemorrhage, we use a temporary occluding agents. The air gel, the surgical gel, which we use to get hemostasis in an open procedure, we make it as a fine powder, kind of slurry. And then we inject in typically selectively into uterine artery, depending upon where exactly is the bleeding. These temporary agents will get dissolved in a couple of weeks time, maximum 3 to 4 weeks. I've seen certain people where uterine artery recannulation happened beyond later than 3 months. But not more than 3 months. The uterine artery will get recannulated, and then what we use currently is a temporary blocking agents.
So this can be a savior. We all get scared of PPH. So if it is well, or if you know the placenta accreta already, if you can anticipate and can well inform the patient and counsel the patient, this can be a life savior, and you can avoid unnecessary hysterectomies. This can be a boon to the patient. Thank you, sir.
No orthopedic intervention, you may leave. Now, a department of orthopedics will interfere, and I see most of the smarter people leaving the hall. So because orthopedic stands between you and a good cup of tea, I invite Dr. Pratap to come and start his talk.
So, good afternoon, one and all. Today I'm going to just brush up about what is do orthopedics has any intervention during pregnancy, intrapartum conditions and all, and how do you manage it, and how simple or how complicated the things can become. So I'm Dr. Pratap. I'm a consultant orthoscopy and sports medicine counseling in KIMS Kondapur. So coming to the brief objective of my presentation is, as I said, to discuss the diagnostic approaches, and treatment strategies and surgical conditions which an orthopedician intervention is required when during an intrapartum or during the 9 months of pregnancy. I'm going to go on a brief a few conditions which are very commonly encountered by every gynecologist in their OPDs. The first one is low back pain. This is the most common condition where all the pregnant women keep complaining about the low back pain. It affects almost 72% of all the pregnant women. The main reason for this is when there is enlarged uterus, there is anterior shift of center of gravity, which happens naturally. So that generally causes increase in the lumbar lordosis. A normal lumbar lordosis, normally the lumbar spine is in lordosis, but it is exaggerated. That is the reason why there is severe strain on these paraspinal muscles, and that leads to a intravertebral disc. They generally come with a small annular tears and all that cause severe pain. But this condition is absolutely nothing to worry, and can be treated with the basic acetaminophen and exercises. And we just have a follow-up with the patients. The second condition is the SA joint. This also because of enlarged pelvis and asymmetrical laxity, and only the simple way of diagnosing this is give a positive pelvic plane provocation test. Just simply compress on the SA joints, patient complains of pain. Even this, just give her a pelvic belt and make the physiotherapy. The disc herniation. This is a rare condition, but this all the journals show around like 1 in 10,000 pregnancies will lead to this. So this is little considerate condition where you require an orthopedic intervention or a spine specialist. So patient complains of continuous radiculopathy, and they will have mainly a positive straight leg raise test and a diminished reflexes. So this is a point where you have to get worried. So definitely there is no acute surgical intervention in these conditions until and unless patient comes to your OPD with a cauda equina syndrome. So the most important thing, this happens only most of the conditions during the time of delivery. That is especially positioning the patient on the OT table or for the normal table. So the most outcome is when you handle this condition properly, they come to the baseline function immediately once the delivery is done. So this is one condition which every gynecologist to take it as an emergency when they find especially the cauda equina syndrome during the delivery of either as a normal or a cesarean. Scoliosis during pregnancy. This is another cosmetic condition where patient keeps complaining they have a bent spine, they have they're tilting towards one side, they're having any problem with their spine. But this is just idiopathic and it progresses with pregnancy. But once after the delivery, everything gets back to normal. It doesn't require any X-rays or any intervention. But when patient has short stature and exaggerated scrotal deformities, it is a challenge for the anesthetist to give an epidural in these conditions. So this is also nothing to worry. Carpal tunnel syndrome. Most of almost 60% of pregnant women will come with this condition. This is generally what is carpal tunnel syndrome. It is a median nerve compression. This generally happens in the waist due to exaggerated severe weight gain, increased body volume, and hormonal changes. And this condition, we just give her a splints and give her a pain relief and a steroid injection. Surgical decompression, avoid 99% until the symptoms are worsened, and even the NCS studies show the severe compression. Next thing is femoral head osteonecrosis. There are only 40 reported cases due to pregnancy as far as now, and most of the condition is due to they might be having an underlying vascular conditions like hypercoagulability or venous congestion. And for these conditions, definitely get an MRI, which is safe. And the management, how to treat is early intervention with limited weight bearing and postpartum surgical intervention. So transient osteoporosis, there are 500 cases reported as of now. And you have to get an MRI. Symptoms are like unilateral hip pain. The difference between this condition and this is only because this will have a unilateral hip pain and they'll have limited range of motion. And once it gets worse with weight bearing. So you have to give a protective weight bearing, and most common complication, patient lands up with a subcapital fracture, that is femoral head fractures. So pelvic ring injuries, this is again during a spontaneous vaginal deliveries during C-section. And this is also doesn't require after the delivery, this can be managed by an orthopedician. So coccyx fractures commonly caused due to when the patient is delivered on a hard surfaces, and symptom generally it's like pain during sitting and hip extension and all. And nothing, this is also can be treated with a simple coccydynia pillow. Sacral stress fractures, these are very rare, and this is mainly due to the baby positioning, and only if there is a neurological deficits, we have to intervene, or else there is no intervention required for these conditions. So finally, what I conclude is pregnancy specific or required tailored diagnostic and management strategies, and early intervention and simple disciplinary care improves the outcome. You really don't have to worry in most of the conditions. All the conditions are most of them self-resolving, except the fractures and cauda equina syndromes. Thank you.
Thank you, Dr. Pratap. Nicely summed up. Madam, all your pregnant ladies are safe with Pratap. So after it's been more than 50 years with thalidomide, and then we are not still out of the woods regarding what painkillers can be used safely in pregnancy. Any takes on that?
So most of the patients, first day they come for the scan. I'll ask what symptom you have. First day itself they'll say I have back pain. This commonly we see back pain. So do you all agree? First symptom they say every patient. I don't know, because I think most of the time they're all overweight or they're not active, and preconception no exercise because they want to conceive. After conception no exercise because they've conceived. So we have not left with any options to tell about anything about exercise. So maybe only local oils or something.
For fermentation,
yes,
and back strengthening exercises, and adequate intake of vitamin D and calcium. That is very, very important.
More than that, focal therapy, ma'am.
Yes.
What you are giving?
So our patients, actually, we have a lot of secret ingredients in our practice.
Yes, it's not
so,
a how you deal with the patients, and yes. I won't say patients, are mother.
Except in the first trimester, most of the drugs, NSAIDs, even including NSAIDs, are safer from second and third. This thing only that we don't have to necessarily take special precautions in pregnant ladies from their fourth month of pregnancy. So they can be safely used, but with a word of caution. It's only that there is a lot of probably in the first trimester, you have to be a little careful with most of these pain medication. Now that
you are taken local sprays that they are using.
Yes, madam, you're
the diclofenac sprays especially.
Yeah, all of us are not blessed with the kind of voice and the command you have on the subject. So for you, it is vocal therapy. For the rest of us, it's sprays. Now that the pregnant ladies have delivered, I would like to invite Dr. Suresh to come and take care of the babies.
A small note regarding anesthesia. Not necessary local anesthesia is the best. This comes to the regional anesthesia. So it have a minimal effect on the fetus. Then if not possible, if you have any contraindication regarding regional anesthesia, the patient hemodynamically unstable regarding embolization or any thing, we have to go for the general anesthesia. So it will risky, but
so we have a lot more experience in such cases with the general anesthesias, because most of the referred patients who come from outside are really hemodynamically unstable, and it's a very dreadful thing to give spinal anesthesia to them. We need pregnant or post-delivered mothers to be at least hemodynamically stable to give regional anesthesia.
Now I would brief introduction about Dr. Suresh. He's an arthroscopy and arthroplasty trauma surgeon. And his special interest seemed to be, he is very much interested in pediatric. So as a practicing group here, we make sure that we cover all subspecialties and pediatrics being one of them. And because of the high volumes, thanks to Dr. Shilpi and Dr. Aparna, we get quite, and probably we actually started brushing our pediatric textbook after a long time. And Suresh happens to be the lead person on this one. Whenever there's a pediatric, whether be it CTEV, postpartum woman coming with pelvic diastasis, or whether be it any congenital deformities in this thing, then we have Dr. Chaitanya who does the spine pediatrics. So, but Suresh takes the leads, and now I would request Suresh to continue with his talk.
And Dr. Suresh is our cushion for post-delivery pubic bone diastasis that at times happen with bigger babies. He is the one who gives the exact counseling that the patient needs so that they don't barge at our offices. Thank you.
Good evening and thank you for the nice introduction. And I thank the organizing committee for giving me this opportunity. So these are the postpartum musculoskeletal disorders we often come across, and majority of them have been discussed by my colleague. I am just focusing on pubic symphysis separation or a diastasis. So PSD or a symphysis pubis diastasis following childbirth is a rare orthopedic condition that can be debilitating in postpartum period because it's a cartilaginous joint and there are ligaments around. So in front and the back around the SA joints, and there is ligamentous relaxation at the symphysis and the widening of sacroiliac joint due to relaxin and progesterone, enabling normal vaginal delivery. And we define pubic diastasis more than 10 mm. We term it as a pubic diastasis. And what are the risk factors associated with PSD? The incidence of pubic diastasis is reported to be 1 in 300 to 1 in 30,000. The disparity in the incidence is because of the underreporting. So now there is a lot of cases being reported because of the increase in vaginal deliveries now. And the risk factors are multiparity, macrosomia, CPD, previous trauma to the pelvis, osteomalacia, chondromalacia, rickets, tuberculosis, which commonly affects the cartilage part of the symphysis. And if there is a rapid progression of second stage of labor and a rapid descent of the presenting part, epidural anesthesia and forceps deliveries are the common risk factors for the symphysis diastasis. And what are the symptoms? They do present with pelvis pain or the lower abdomen, a pain that radiates to leg, thighs, groin, or perineum, a pain that worsens when walking, bending forward, or going up and down stairs. There'll be difficulty standing, getting up from chair, and rolling in bed. These are the common symptoms they do present with. And they do often complain of clicking, grinding, or snapping sounds in the pelvis because of the diastasis. And they often complain of fatigue and difficulty in bowel and bladder movements. And they typically have a waddling gait because of the separation of the symphysis. And when it comes to differential diagnosis, we should always think of lumbar radiculopathy, osteitis pubis. It is a non-inflammatory damage to the symphysis, and infective is osteomyelitis. These are the three differential diagnoses we often keep in mind when we think of other than symphysis diastasis when they come with the above symptoms. So how do we investigate? So in prepartum, ultrasound is a safe measure. In postpartum period, X-ray can define. So anything more than 10 mm of separation, we call it a PSD. And CT is basically to look for SA joints because X-ray might not give an accurate measurement of the SA joint separation. So CT is preferred. And MR is basically to rule out any associated conditions like a herniated disc or any infective pathology. And how do we treat it? So majority of the PSD, if it is about 1 to 3 centimeters separation, we can treat them, majority of them, with conservative measures. We can give them pelvic binders. We can temporarily immobilize them. We can advise bed rest and pain medication. Majority of them do settle without much complications. In case patients who have continued diastasis resulting in pain, instability, and debility, which affects their daily living, other methods, that is surgical interventions, can be offered. So one of them, the operative management when there is a separation of more than 4 centimeters, we do recommend surgical fixation. It can be either external fixators or a symphysis. The symphysis is anterior fixation of symphysis pubis with a fan steel incision. We go retroperitoneal bladder, we separate the bladder and fix the symphysis pubis as it's shown in the picture there. So we can percutaneously fix the SA joint too. And one of the thing to be remembered is vaginal delivery is contraindicated once you operatively fix the symphysis because you lose that flexibility of the pelvis. So this is a case where there is a wide separation of symphysis. We fixed with symphysis plate there, and patients do good. And at the same time, we need to evaluate them for SA pathology if there is. So if we fix the SA joint, they're completely symptomatically free. So the take-home message is PSD is not rare in a patient complaining of recurrent low back aches or waddling gait or pain not relenting to any other measures. Always think of symphysis diastasis. So anything more than 10 mm separation is defined as symphysis separation, and patient with persistent pelvic girdle pain need to be evaluated. And if it is more than 4 centimeters, surgery is the ideal thing to suggest. Thank you.
Thank you so much for clearly illustrating all the points regarding the problem and the management. I wanted to ask you, like, is the screws which you have shown, will that be fixed
into the bone, into the symphysis?
Yeah, it's not again removed.
No, it is just
Permanent. So next time they will not be able to allow a vaginal. That is a contract.
That's the concept.
Thank you, sir.
So we had an experience of, I think 4 to 6 cases of pubic symphysis issues in the last 8 years that we've been practicing. One very important thing that I have observed as an obstetrician is that snap, thud sound will come when you are trying to extract the head. That sound means you have to call the orthopedician as soon as possible. Second thing is another very, very important finding that if the woman is not trying to walk, is not able to walk, then you should not force them to walk. Better get an X-ray done and send a notice for a referral by the orthopedician. They'll come and see the X-ray and then let us know what has to be done. If it is normal, then probably you'll get the physio department coming in and they do the walking and everything. But if she's not walking, if she's not able to get up from bed and put her foot down, then it means that this is the right time for an X-ray. This is before even we give referral to them, what I have observed, these 2 things. And we've had, yes, 4 to 6 cases like that. In 4 of them, we had forceps that was applied, and 2 of them, it was just a normal delivery without any forceps.
You forgot to mention the other sound. One is when you hear a fuck, then you know the mother is in trouble. So when you hear a chuck, the child is in trouble. Then you have to, based on that, you call Pratap or Suresh.
Any questions? Any questions on the floor? Anybody can ask. So I have the luxury of practicing with so many specialists and super specialists. There is a PPH, there is a vascular surgeon, there is an orthopedic problem, there's an orthopedician, there's a cardiac problem, we have a cardiac lead. But what I feel is every one of you all are also empowered to take the right decision at the right time and use the multi-speciality services. Gone are the days that we were multitasking. Nowadays, I don't even give a prescription for cold, cough, and fever. It is obsolete. Before, as a family physician that I practiced for years together, I used to write all prescriptions. But once I realized, especially post-COVID, there is nothing called a normal cold cough. It can become a disaster if it increases. So better go and take help from your colleagues, because nowadays even
cold cough fevers are just not going. In a similar way, there is a problem that is in depth in every specialty, and we need to take the right decision at the right time. And every decision that we take, our patients will definitely thank us for. It's very, very important. 2 days before, one pregnant woman, 26 weeks, she was coming into the OP like this, like this. This is a very classical symptom of acute appendicitis. She entered my door and I told her husband she is having acute appendicitis. I just want to see her cervical length. I want to send her to the first floor for an ultrasound. I checked the cervical length, it was 31. I sent her to the first floor where the ultrasound was done. They have given a diagnosis of acute appendicitis. I called the surgical gastro. I told them it's acute appendicitis. They told we might observe her for at least for a couple of hours to check whether she is going to be responsive for antibiotics. But I told them that this kind of picture doesn't respond for antibiotics. They did a laparoscopy. And by then also there was a lot of pus pockets and it got ruptured. But timely intervened, timely surgery done. She's recovering and she's there in 4:30, 4:27 go. She's fine now. So this is something that every, one clinical picture, just have to catch it. If we did not think about a multi-specialty approach, if we would have thought maybe, short cervix or preterm, or we just kept her, observing her. The next day she would go into fever. The next day she would go into sepsis. The next day she would, distension, whatnot. And her husband told me, how did you recognize it was acute appendicitis? I told, I operated 2000 appendix when I was in periphery. I know how it is. So that is there. But yes, you have to take your surgical, counterparts' help, because medicine is a vast subject. There is nothing wrong in taking one step forward and calling it the other specialty. It is going to be tremendously helpful. Thank you all so much. Thank you, sir. So we will go ahead with the neonatology recent advances. I call upon the chairpersons, Dr. Amit Upadhyay, who is from the NNF, and Dr. Sri Salem, Dr. Swapna, and Dr. Sivaranjani. And I would call upon our moderator, Dr. Aparna, who is a very passionate neonatologist. And if I wouldn't have been an obstetrician, probably I would have been a neonatologist if I would have been a doctor, because I have half knowledge of obstetrics, I have half knowledge of neonatology. Nowadays, it has become equal. So we both talk in the same terms that we understand each other's problem. I made her an obstetrician, she made me a neonatologist. So it's like that. And we never have a difference of opinion. We're always on the same front. And in terms of her passion for obstetrics, passion for running an obstetrics CME, that is what is Aparna. And she is a voracious reader and she's a voracious person in terms of determination and updating her skills and teaching. And she's got fellows always on the tips of their toes, and she keeps running around several hospitals that she covers and several districts that we cover in terms of, in utero transfer. And she's a strong believer of in utero transfer, where we can really do justice. Justice delivered is justice given at the right time. So in utero transfer is something that is a magic portion that we can give to every pregnant mother in an emergency, because if there is a preterm there, the survival rates, the recovery rates, the overall benefits are tremendously varying when you get the baby to the hospital or the mother to the hospital. And welcome, Aparna. Here's your session. Thank you.
Thank you, ma'am, for being so kind and supportive, not only in the clinical sense, but also in the sense of introducing us so warmly in the CME. We are indeed blessed to have a multidisciplinary team which works together like family. And as ma'am said, we understand the complications and the perceptions of families
seeking out the obstetrician, and Dr. Shilpi understands what is the expectation when it comes to the neonatal care. And for today's panel, we are going to discuss about perinatal interventions that have been shown to improve outcomes in extremely preterm neonates. We are extremely thankful to the chairpersons, Dr. Amit sir, who has come from Meerut. He is the Secretary of National NNF now. Dr. Sri Selam sir, President of State NNF this year. Dr. Swapna, who is the Secretary of Telangana State NNF, and Dr. Shivaranjani Santosh ma'am, a passionate pediatrician. To take us through this panel, I'm extremely pleased to invite the team of panelists. We have two obstetricians, two young and dynamic obstetricians, and two neonatologists. I would first like to call upon Dr. Veena, MS OBG and Fellowship in Obstetrics, Consultant at KIMS Cuddles, Kondapur. Thank you, Dr. Veena, for joining us. We also have with us Dr. Anu Vardhan. She is again a very young, dynamic, enterprising obstetrician. She is currently pursuing her fellowship in high-risk pregnancy from Fernandez Hospital. Welcome, Dr. Anu. Please do join us. We have with us our passionate team member, Dr. Aravinda, with whom I've had the pleasure of being associated for more than 4 years now. Dr. Aravinda is a DNP from Pediatrics and Fellowship in Neonatology. She works as Consultant Neonatologist at our team in KIMS Cuddles, Kondapur, one of the strong members in our team. She has developed her expertise in working in level 4 NICUs, and she handles extreme preterm babies starting from 24 weeks, and is trained in high frequency ventilation, inhaled nitric oxide therapy, therapeutic hypothermia, and the armamentarium of NICU services. She is very passionate with point of care ultrasound focus in neonates. Dr. Srujana will be the fourth panelist for our day, a young neonatologist. She works as clinical associate in our team. She did her fellowship training from our own center, and today she has blossomed into a neonatologist, managing complex extreme preterm cases, post-cardiac, post-surgical cases, term newborns with hypoxemic respiratory failure. Thank you all 4 of you for joining us today. I hope you have mics, wireless mics. Can the team please provide them 2 wireless mics? So the reason we are having this panel today is because we know that India, with a burden of close to 13 to 15% prematurity, is the home to the largest number of preterm deliveries across the world. Amongst this burden, 4% births happen to be extremely preterm, less than 28 weeks, where all the difference between the sky and the earth can be achieved by the quality of care in the golden minute and in the golden hour. Now, when we talk about neonatal mortality today, as we speak, it stands at 20 per 1,000 live births. Prematurity and preterm related complications and morbidities account for the highest proportion of neonatal births, and neonatal deaths in turn account for the largest proportion of infant mortality. So further reduction in our IMR and further reduction in our under 5 mortality rate is going to be impossible without achieving reduction in neonatal mortality. And in turn, it cannot be achieved without improving survival among extreme preterm infants. Now, when we talk about perinatal interventions, we are talking about a continuum of interventions starting from pregnancy or antenatal phase. Particularly, this deals with the management of chorioamnitis or PROM, appropriate administration of a complete course of antenatal steroids, and about antenatal magnesium sulfate, about which we will be discussing a little bit in detail. Then it continues with optimal delivery room management in the form of thermal bundle to maintain a good admission temperature, cord care, with the advent of delayed cord clamping and other strategies to improve placentofetal perfusion, appropriate oxygen saturation targeting, early CPAP, gentle respiratory support, early appropriate use of selective surfactant replacement, and dedicated personalized teamwork with close debriefing. When it comes to the postnatal management capsule, it includes continued management of RDS with gentle ventilation, avoidance of invasive ventilation as much as possible, permissive hypoxemia, which means targeting saturations which are conservative. Usually we talk about SATs target of 91 to 95% when we are talking about preterm population, appropriate management of sepsis, early aggressive enteral and parental nutrition, and prevention of complications like ROP and IVH. So these are some of the proven strategies extending across the spectrum, and I shall be discussing these with our panelists one by one. The first that we are going to discuss is something that we all know. It's one of the silver bullets in perinatal medicine, an intervention that has given the Cochrane collaboration its logo, antenatal corticosteroids. Now we all know, and I'm not going to go into the well-known literature. I'm sure everyone here is aware that antenatal steroids are indicated for pregnant women who are at risk for preterm birth between 24 to 34 weeks of gestational age. This is what the NIH recommends. And what is to be given? It is either betamethasone or dexamethasone. The dose is either 2 doses of beta, 12 milligrams, 24 hours apart, deep intramuscular in the thigh, or 4 doses of 6 milligram each of dexamethasone given 12 hours apart. When 24 hours have been completed from the last dose to the delivery of the baby, there are innumerable benefits, which include a significant reduction in almost all neonatal morbidities, starting from perinatal deaths, neonatal death, a 34% reduction in respiratory distress syndrome, 45% reduction in intraventricular hemorrhage, a nearly 50% reduction in necrotizing enterocolitis, need for mechanical ventilation, and the incidence of early onset sepsis. Now, the question here is not on the benefits of antenatal steroids, which are well proven. The question here, Dr. Veena, to you is, despite all this evidence, where is the gap in the translation from evidence to practice? And what are the obstacles, in your opinion, that hinder the translation of this important intervention? And how do you think we can overcome them?
So, good evening, everyone. As an obstetrician, we do face on a day basis to complete the therapy of steroids, and in emergency situations, it is a challenge for any obstetrician to complete the dose of steroids for 20 and waiting for 24 to 48 hours in these conditions like advanced preterm labor, infections, diabetes, hypertension disorders, coagulation failure, and in severe lung and cardiac diseases, in active bleeding conditions like placenta previa, abruption, trauma, accidents. So also in the fetal conditions where the fetus is already compromised with evidence of abnormal CTG and severely compromised Doppler umbilical artery compromise. So, so we do usually face challenges in considering steroids in acute chorioamnionitis, but there are different schools of thought. One is depending on the severity of the infection and depending on the condition of the patient. So they too consider giving the steroids in such conditions with a good antibiotic coverage. But but there is a flare-up of infections because of the steroids. So hence, steroids are not usually recommended in case of proven infection. In cases of diabetes, it's a challenge again, definitely to consider steroids because steroids cause transient hypoglycemia. So a continuous blood glucose monitoring has to be continued when you are considering steroid. So there should be a increase in the baseline dose from the baseline dose of 40% on day 2 or day 3, and simultaneously there is a slow decline in the need of insulin later on. Because the steroids have as early as 12 hours, the steroid has a physiological effect on glucose as early as 12 hours.
So I think the point that Dr. Veena is trying to tell us is there are very few absolute contraindications for antenatal steroids. You can give steroids in gestational diabetes. You must be aware of a slight modulation in the dose of insulin or oral hypoglycemic agents. It can be used in hypertension and it can be used in mothers with PROM. The only absolute contraindication for antenatal steroids is clinical chorioamnionitis, which is an extremely rare entity. In most of the other situations, it is quite safe to go ahead with steroids. So this possible fear or a little suspicious or doubt about the potential efficacy and safety is probably one of the concerns behind one of the low coverage for antenatal steroids in Telangana state, particularly in the SNCUs. It is said that less than 10% eligible pregnant mothers get a complete course of antenatal steroid despite having the time. Now, another common question that is asked is, we anticipate only 1 to 2 hours for this preterm mother to deliver. Do we still go ahead and give a shot of steroids? What do you feel, Dr. Veena?
So actually, the physiological effect of steroids start as early as 6 hours when introduced to the first injection. So if the impending delivery is within that 6 hours, there is no point in considering the steroid. But because the steroid has a beneficial effect of in reducing the IVH and CP.
So there are non-genomic and genomic effects of antenatal steroids. The non-genomic effects can start in within a few minutes. So probably it's not necessary to hesitate to give steroid, even if you believe that there is not enough time to complete the course. Even a single dose of rescue steroid may be better than not giving anything at all. The next doubt here is, which is better, betamethasone or dexamethasone? Now, there are very few head-to-head comparison trials. There are few RCTs that have compared directly betamethasone versus dexamethasone, but we have indirect comparisons, beta versus control, dexa versus placebo, which do indicate that there is perhaps a lower risk of respiratory distress syndrome or HMD when beta is used over dexamethasone, and probably there is a advantage towards better reduction in IVH when dexamethasone is used. But none of these are quite well substantiated, and using either of them is pretty fair. But now the problem in India, which has been sort of realized recently, is that we do not have the traditional combination of betamethasone phosphate and acetate, which is what is recommended in Western literature. All the studies in the Cochrane review have used 12 milligram of betamethasone, which includes 6 mg each of beta phosphate and beta acetate. And this is not the preparation that is available in India. And hence, the government of India in 2014 came up with this operational guideline, which recommended that a single course of injection dexamethasone must be used preferably in India for pregnant mothers with imminent preterm delivery between 24 to 34 weeks. So this is something that has come in new, but in centers where you are comfortable using betamethasone, it is as well safe or efficacious to use either of them, provided we are giving as much of antenatal steroid coverage to our babies as possible in view of the innumerable benefits that it has. Now, question to Dr. Aravind Lochani, neonatologist, is, now what do you think about the use of antenatal steroids outside this traditional recommendation, outside 34 weeks, particularly in babies born late preterm, between 34 plus 0 to 36 plus 6 weeks of gestation? Are you, as a neonatologist, concerned about this use?
So good evening, everyone. So we all know that both the WHO and ACOG endorse the steroids in the between 24 weeks and 34 weeks of gestation. Coming to the late preterms who are born between 34 plus 0 to 36 plus 6 weeks of gestation, there is a trial called antenatal betamethasone in late preterm trial, that is the ALPS trial, which was published in NEJM in 2016. In that, they have studied these late preterm babies who constitute around 8% of the total newborns that are being born. So they are also subjected to like a lot of respiratory morbidities, needs for NICU admission, need for respiratory support. So in the study, it was proven that so when steroids, antenatal steroids are given to late preterm infants, it decreases the need for respiratory support, be it either CPAP or heated humidified nasal cannula or oxygen therapy, and also decreases the need for mechanical ventilation in the first 72 hours of life, and also decreases the mortality. So this is 11.8% in the babies who are subjected to the steroids versus the control group, which is around 14%. That's why the ACOG recommends the late preterm steroids between 34 plus 0 to 36 plus 6 weeks of gestation also. In this trial, it was found that the only limitation being the neonatal hypoglycemia, which can be, if we adequately monitor it, it can be easily avoided.
So one concern with the use of antenatal steroids in late preterm infants seems to be neonatal hypoglycemia. This needs to be kept in mind whenever it is used for infants between 34 plus 0 to 36 plus 6 weeks. So either one should ensure appropriate feeding, enteral feeding, or if the baby is not eligible for enteral feeding, then in the form of intravenous alimentation and close glucose monitoring. So Strujana, what is your view about repeat courses of antenatal steroids, and is there any long-term concern with the use of fetal exposure to antenatal steroids?
Coming to repeated courses of antenatal steroids, ACOG guidelines and the WHO guidelines, they are saying we can repeat single repeat course of antenatal steroids if the first dose it is taken for more than 14 days as per ACOG guidelines, and gestational age is less than 34 weeks. As per WHO, if the first dose is given more than 7 days, then we can go for the single repeat course. But multiple, there are few studies like a multiple MAC study, which is multiple antenatal corticosteroids in the preterm babies. So this study, it has shown that there is a somewhat compromise in the anthropometry at the birth. So they are saying that it's better to go for the single repeat course of antenatal steroids.
So a single repeat course of antenatal steroids may be considered if the mother remains undelivered for more than 14 days, provided she is less than 34 weeks of gestational age. But repeating more than one course of antenatal steroid or more than 2 complete courses is going to predispose the fetus to anthropometric concerns as well as long-term neurodevelopmental issues. There is also a concerning trial that has come in from the low middle income countries. This was ACT trial that actually showed a borderline increase in neonatal mortality with the use of antenatal steroids in a community-based setting, where the symphysiofundal height was used for the calculation of gestational age. So with the inherent limitations of this technique for the assessment of gestational age, including the assessment of some SGA or IUGR fetuses as preterm, the results of this study remain debatable, but this is a word of concern, especially in countries like ours, where the risk of maternal infections and sepsis is particularly high. Now, coming to the timing of steroids. Now, in order to do all this, one needs to have accurate gestational age assessment. So, Dr. Anu, what do you think is the accurate technique for the identification of gestational age to decide whether the mother needs to be given steroid versus not? And can we predict the risk of preterm labor?
Good evening, everyone. So accurate identification of gestation is a prerequisite before we do any interventions fetally. So traditionally, we use LMP to calculate EDD, but this may not always be ideal if the patient doesn't exactly remember her LMP or is confused because of early pregnancy spotting, or if she doesn't have regular cycles, 28-day cycles with ovulation on day 14. So we have to resort to scan EDD. So according to ACOG guidelines, the most accurate gestation comes from the first trimester scan when the CRL is less than 84 ml and the scan is done less than 13 plus 6 weeks. And then the question arises as to which EDD do we consider, the LMP EDD or the scan EDD. So when the scan is done between less than 8 plus 6 weeks, we'll only consider the scan EDD only if the discrepancy is more than 5 days. And when the scan is done between 9 to 13 plus 6 weeks, we will only consider the scan EDD if the discrepancy is more than 7 days. Otherwise, we always go for the LMP EDD. Coming to the risk factors of preterm labor, this is a pretty busy slide, but in a nutshell, the most important risk factor for preterm labor is a past history of preterm labor. So there is a 14% risk of preterm labor in the present delivery if the woman has history of one preterm delivery, and it increases to 28% with a history of 2 preterm labors. So the other risk factors being uterine overdistension, secondary to multiple gestation, polyamnios, macrosomia, infections, uterine anomalies, cervical incompetence, advanced and teenage pregnancy. So basically both the extremes of maternal age and also maternal comorbidities such as PIH, GDM, APLA. So in these cases, the preterm labor may be spontaneous or it may be iatrogenic induced. There could also be fetal factors such as congenital malformations, FGR, IUDs, and in most of the cases of preterm labor, the cause is idiopathic. Prediction of preterm labor. So how do we predict preterm labor? So firstly, we look for the presence of risk factors. In high-risk cases, we can also look at the cervical length on ultrasound. If it is less than 1.5 centimeters, then there is a 50% chance that she will deliver by 32 weeks and a 90% chance that she will deliver by 34 weeks. Whereas if it is more than 3 centimeters, the risk drops to less than 8%. Then there are also some biomarkers which, when present in the cervicovaginal secretions, are pathognomic of imminent preterm delivery. The most important ones being FFN, fetal fibronectin. So this is basically a glycoprotein that facilitates the attachment of the decidua to the placenta, and it is normally present in the cervicovaginal secretions up to 20 weeks. So when this is being detected after 24 weeks, it does become pathognomic of imminent preterm labor, but this test has a very high negative predictive value and it is poorly specific. The other two markers are placental alpha macroglobulin, and the other thing is phosphorylated insulin-like growth factors.
So among all these markers, Dr. Anu, which is the one which is most practically used? Because there might be a lot of
What
tests.
is commonly used is actually fetal fibronectin, but what should be ideally used is placental alpha macroglobulin, because it has the ideal ratio of positive and negative predictive value.
So there are multiple tools to predict preterm labor and to probably anticipate a high risk of preterm labor and probably be ready for coverage with antenatal steroids and Maxelf in probably in those mothers who are at high risk. But again, this is a very tricky ball game and there are always surprises. We move on now to another interesting domain, particularly relevant for low middle income countries like ours, fetal growth restriction. So Dr. Veena, back to you. What, in your opinion, is the incidence of FGR or fetal growth restriction? Is this an important cause of stillbirth in our country? And what can you do as an obstetrician to reduce the incidence of FGR?
So identification of FGR is an integral part of antenatal care these days. Though the stillbirth rate in countries like us has declined, shows decline in the past 2 decades, but still FGR stands second in the etiology of stillbirth rate. So there are few strategies to reduce the FGR and stillbirth rates. Definitely by firstly by establishing an accurate EDD. This is to first continue the fetal surveillance and optimize the timing of birthing and address the modifiable risk factors, which includes reduction in the pre-pregnancy weight and cessation of smoking, alcohol, and to enhance the education about contraception, fertility, family planning, so that to defer the pregnancies in the extremes of age in the very young and elderly age group, and detection of maternal medical conditions and close fetal surveillance to optimize birthing, and availability of basic and comprehensive emergency obstetric care. And there is a good evidence to support the low dose aspirin in high risk pregnancies with the risk of preterm birth, which reduce the risk of preeclampsia, preterm births. So do you know that half of the stillbirths in our country and low-income countries are due to the lack of skilled birth attendants at birthing? So that has to be there, and implementing an audit obviously has a significant improvement in the reduction of preterm births and FGRs and stillbirths.
So since we are running out of time, so I'm going to request all the panelists to restrict the answers to maybe 30-40 seconds from now on. So we know that FGR is an important problem in India. There are some strategies that can be done, things that can be monitored to reduce the incidence of FGR. And Dr. Anu, we had a whole talk in the morning by Dr. Chinmay Rath on the utility of Dopplers in deciding the termination of pregnancy. If you could quickly summarize 2-3 important carry-home messages for all of us, how do you think Doppler is useful in this particular population?
So firstly, the take home is that Doppler is a mandate currently for FGR. It is absolutely necessary. So it is not only used to detect FGR, but to identify the etiology, the type, and to stage FGR so as to plan the mode of delivery and the time of delivery, and also to anticipate the neonatal complications. So, and the other most important thing is we not only stick to uterine artery, umbilical artery, and the MCA, but currently guidelines recommend the use of CPR ratio, which is more sensitive to mild insufficiency in especially late
FGR, where the umbilical artery Doppler may be normal. So we always have to look at CPR, and usually, normally it is more than 1. If it is equal to 1 or less than 1, that is when we know it is alarming and we'll have to intervene.
Yeah, so helping us to decide the timing of labor, and for the neonatologist, we anticipate a 2 times higher risk of necrotizing enterocolitis when we are dealing with a preterm baby, especially a baby less than 34 weeks with an abnormal Doppler, as Dr. Anu has elucidated. Not to forget the role of venous abnormalities, which are kind of pre-terminal anomalies, which have a very high risk of impending or imminent fetal demise. Now, Dr. Srujana, it is often believed that SGA babies are stressed babies and probably are at less risk of some complications. Do you agree with this, or do you in fact contradict this?
No, I will absolutely agree with this, because the extreme preterm and the IUGR babies, they are already compromised in utero and they burn with the malnutrition and interact with growth restriction features. So these babies, they need some intensive care as well as the prolonged hospital stay due to some risk factors, like prolonged risk factors like hypothermia, hypoglycemia, and severe respiratory issues like BPD, feed intolerance like NEC and ROP. So all these risk factors they are more commonly seen in especially in the IUGR and the extreme preterm babies. So
she's actually telling that she doesn't agree with the dictum that SGA babies are not at risk of complications. They are as much or perhaps at a higher risk of some complications, particularly asphyxia, hypothermia, necrotizing enterocolitis, polycythemia, and hence they need more vigilant monitoring. They are also at a slightly higher risk of perinatal and early neonatal mortality. Now, Dr. Veena, tell us something about antenatal MACSILF. Please keep it very brief. What are the adverse effects in mothers and neonates, and what are the benefits?
So the candidates who are predicted or are at high risk of having preterm births has to be initiated with the magnesium sulfate within 24 hours of delivery. And the contraindication obviously is the myasthenia gravis, and also cautiously used in cardiac and kidney function when impaired. And the upper and lower limits would be 24 to 32 weeks of gestation, with a regular dosage of 4 grams should be given as a loading dose, followed by a maintenance of 1 gram. And it should be initiated within 24 hours and continued up to 12 to 24 hours. So, we all know the mechanism of action and advantages according to the 2024 Cochrane. They emphasize on giving magnesium sulfate to reduce the risk of the preterm births. So there is no need, do not re-administer the dose of MACSILF again if the delivery is delayed after giving the first dose. So the side effects are the same to the MACSILF when given to the preeclampsia. So you have to keep the monitoring of all the signs of magnesium toxicity. And for the fetal heart rate, there definitely is a changes in the fetal heart rate variability, and the baseline is changed. Obviously, additional benefit of antenatal steroids can be given along with
So
our
4
own
grams
therapy.
followed by 1 gram per hour for 24 hours or until preterm delivery, whichever is earlier. And this is obviously different from the dose that is used for pre-eclampsia. So Dr. Aravinda, do you anticipate a higher risk of depression when MACSILF has been used in mothers? How do we counteract this kind of depression if found?
Yes, ma'am. Babies are found. Means we should be ready with the resuscitation equipment, everything to counter the depression. And
calcium is used as an antidote
Calcium is
when
used.
MACSILF has been used for mothers. There is a slightly higher risk of neonatal depression, but numerous other benefits like lesser risk of cerebral palsy. So Dr. Aravinda, you are a neonatologist and you are dealing with babies starting from 24, 25 weeks with good outcomes. Now, would you prefer in utero transfer when you're anticipating extreme preterm delivery? And can you tell us briefly what is the advantage of delivering such a baby in utero?
Yes, in utero transfer is definitely advantageous to all extreme preterm babies. But here the some of the things need to be kept in mind when we are referring a mother. So because like what is the stage of labor she is in? If she comes in impending labor and she is about to deliver, then we may not be able to transfer such a mother. And if the CTG is not normal and the baby is having any lethal anomalies, then we cannot refer. So next, if the mother is able to be transferred to the higher center
center, then we should counsel the family, give emotional and support the financial constraints that they might have. And we should also have a good transport team where during the transport some anticipated complications like respiratory support, surfactant deficiency and all need to be taken care of. Ventilator should be available in the transport ambulance. So after seeing all these logistic difficulties, we can categorize the babies, like babies who are less than 30 weeks, 28 to 30 weeks, definitely if they are transferred to a tertiary care NICU, they fare far more better, because in studies it has been shown that babies who are born outside and then transported have a higher 19% higher risk of mortality than babies who are born after the mother has been transferred and delivered at a tertiary care center. Then between the 30 to 34 weeks, if a neonatologist is available at the referral center, then based on their confidence level, the babies can be treated there. And coming to the conditions where the transfer needs to be done, it can be based on maternal indications. Where the mother also needs multidisciplinary support, and the baby's condition like needing any cardiac interventions or any other surgical interventions, and obviously preterm babies, they fare better because there will not be any maternal neonatal separation, like we will be discussing further about early expression of
less than 28 weeks and neonates with cardiac and other complex surgical conditions would benefit from a in utero transfer, lesser incidence of mortality, intraventricular bleeds, etc. So Dr. Srujana, can you tell us, when you are preparing to receive such a baby in your delivery room, just tell us the things that you would need other than the routine things like ambu bag, mask and suction apparatus. Just tell us the additional prerequisites that you need.
First, to maintaining the temperature, especially in the preterm babies, we need along with the normal things, polyethylene wrap and then thermal mortars, especially if they are less than 32 weeks. And heated humidified gases we had used. Oxygen blender, it has to be used to provide the oxygen. And transport incubator, it has to be there. And TP's resuscitator, it has to be used to deliver the early delivery room CPAP, which has many advantages.
Yeah, so TP's resuscitator, a polythene wrap, early CPAP equipment, blender, pulse oximeter, these all are going to go a long way in helping us save these babies with intact outcomes. So Dr. Arvinda, 30 seconds, brief answer. Delayed cord clamping benefits in preterm infants and how much delay is delay?
So according to NRP, 30 to 60 seconds, we have to delay the cord clamping. According to WHO, 60 seconds, we should delay the cord clamping. Yes, it is beneficial very much in both the preterm and term babies. For preterm babies, it leads to increased circulatory blood volume, increased cardiac output, decreased need for transfusions, decreased mortality, decreased IVH. And in term babies, increased oxygen, increased iron stores and myelin content and cognitive and motor skills in the infancy. So these are the benefits of delayed cord clamping, and everyone should aggressively practice the delayed cord clamping, which leads to transfer of 25 to 30% of the residual intraplacental circulating blood volume to the baby.
Dr. Veena, are you concerned about delayed cord clamping in from the point
Yes,
of
there
view
are
of
certain
maternal
conditions where we cannot consider this like in abruption where unstable newborn and placental circulation is happening, like in abruption cord avulsion, and we cannot follow this in when the baby is born limp, and in conditions like HIV, HBCG infections, and in monochorionic twins, which is contraindicated for delayed cord clamping.
So few contraindications, but in most vigorous term and preterm newborns, delayed cord clamping is safe and doesn't increase the risk of postpartum hemorrhage. It also doesn't increase the risk of neonatal need for double volume exchange, hyperbilirubinemia, or polycythemia. And we are evolving the concept of doing delayed cord clamping even in babies who are having depression with these kind of warmers, mobile resuscitation trays, wherein resuscitation with an intact cord can be initiated. And probably this is going to be one of the most important changes that may come in the upcoming editions of the neonatal resuscitation. We also have the option of cord milking in babies who are more than 29 weeks, where the baby may be depressed and you may want to initially start the baby on resuscitation. So Dr. Srujana, what are the components of thermal bundle and why is admission temperature an important outcome for us?
That thermoregulation bundle usually it contains like a pre-warmed the incubator should be pre-warmed radiant warmer, then pre-warmed linen clothes, cap should be there. There should be polyethylene wrap for preterm babies, and there should be thermal mattress with heated and there should be heated humidified gases and transport incubator. And delivery room temperature should be maintained like between 23 to 25 as per NRB guidelines. These hypothermia in the newborns, it is very important because hypothermia at the time of admission, there is studies have shown that for every 1 degree fall in the admission temperature, there is 28% increase in the risk of mortality and 11% increased risk of late onset sepsis. Along with this, there are also increased risk of complications like hypoglycemia, metabolic acidosis, BPD, feed intolerance, mortality.
Thank you, Srujana. So I request all the obstetricians who are running their own maternity homes and setups here, kindly do think of investing in a blender, a pre-warmed warmer, and heated humidified gases, polythene wraps if you have a large incidence of preterm births, because this is something which can straight away improve the baby's admission temperature and reduce the risk of mortality and morbidities, and also a TP's resuscitator, which can help us to provide early CPAP, which is also something that is used for providing gentle early respiratory support, better management of RDS, and reduction in the need for surfactant. So for want of time, I'll probably leave some of the other questions which are core neonatal oriented, which may not be of much interest for the obstetrician predominant delegates group that we have today. These are all the summary points, and together as a team, there is a lot of difference that we all can make for improving the survival of particularly of babies born between 24 to 26 weeks. In utero transfer, antenatal steroids, complete course, antenatal magnesium sulfate, appropriate delivery room care, and providing non-invasive support in the NICU as much as possible, having bundles and checklists to prevent infections, to prevent sepsis, IVH, retinopathy of prematurity, having human milk bank, and trying to decrease the incidence of necrotizing enterocolitis. I thank my esteemed panelists for a very, very kind of illuminating discussion, and hand over back to the chairpersons.
First of all, I would like to compliment all the panelists for effectively conveying the message. And I think in such a platform where obstetricians and neonatologists and pediatricians sit together, a common consensus has to be brought. And the concept of the word delayed cord clamping might convey a different message. I think we should have an appropriate cord clamping. So the term delay can be negatively thought of. And excellently talked. And regarding the steroid, I think we should come to common consensus. I wanted to know about where is Dexamma, we started this campaign Dexamma in Telangana. I don't know. So I was secretary. So I don't know whether all of them know about that initiation. Madam, please Pali.
So this was one of the initiatives.
For Dr. Anu, you were mentioning about the fibronectin factor, right? So one of my cousins, like no risk factors, they've checked that and said that she's going to go in for preterm labor and asked her to get admitted. She wasn't convinced, so she delivered normally at full term. So my question is, what is the specificity and what are the indications? When do you actually check for that factor? Do you check for all pregnant women?
Ma'am, FFN test has a 95% negative predictive value. So it is useful in patients who keep coming with symptoms of pain abdomen with no vaginal changes. In that case, it is appropriate to go for that test, because in that case, we can surely tell that they may not go into labor if that test is negative, but it is very poorly specific and very poor positive predictive value.
It was a wonderful moderation by you and excellent panelists. So overall, a very amazing panel discussion. The debate on dexamethasone versus betamethasone just continues. But which one is available? Our obstetricians use that one. So at least some of it should be available. And repeated courses, IVF people, they love repeated courses of steroid. And as neonatologists, we often see that 5 courses of beta or dexa have been given since 24 weeks of gestation. And so that has to be discouraged early. And late in pregnancy, between 34 to 38 weeks of gestation, use of dexa is also very rampant. There are people who love dexa and they just don't want to not give it even at 35, 36 weeks. So they also have to be cautioned at times that hypoglycemia is something, it's a silent killer. And increasing risk of hypoglycemia in settings where we can't ensure monitoring blood sugar very efficiently. So that can be very counterproductive. Recently, a paper was published in which at 5-year-old, developmental delays were examined and MRI was done, and hypoglycemia came out to be one of the most important causes of developmental delay. So all these things could be, contributing a little bit that development of hypoglycemia. Thank you.
So this topic is almost included in all the perinatal or neonatal CME, the same antenatal steroids, delayed cord clamping. We all know the benefits of various interventions, but still we see that all these not being practiced in many centers. So we should see that we have a very good survival rate of the babies and long-term neurodevelopmental outcome also. So better we all should implement all these in all the centers. Maybe it's a tertiary care or a small centers. We should see that all these things are getting implemented. Thank you.
It was many times we get a call that 29 weeks or 30 weeks and there is leakage of membranes and we are taking up for cesarean. So how appropriate is that once leaking is there at 30 weeks and rupture of membranes is there and taking up for cesarean immediately? So
I think the absolute indications for termination of obstetricians could answer this better, of course, but these would include presence of fetal compromise, non-reassuring fetal heart rate, presence of active signs of infection in the mother in the form of fever, leukocytosis, maternal or fetal tachycardia, or if there is absolutely nil liquor potentially compromising the baby's well-being. Or in some cases, the mother might proceed into active preterm labor as well. When she is in active labor, it becomes difficult to prolong the pregnancy, especially when there is oligohydramnios. We may feel that it is better to take her up for a cesarean section. Barring these indications, I think most obstetricians would wait and give some time for antibiotics and antenatal steroids and Maxelf to work. But then again, it really depends upon the gestational age. If the same situation arises beyond 34 weeks, I think most of the time obstetricians will be comfortable to deliver the baby. And you can correct me.
So, according to RCOG, so if the woman comes with a leaking at 29, 30 weeks of pregnancy, then firstly, assessment has to be carried out. If the mother and baby are stable, we can do the weekly, after admission of observation for 72 hours, she can be discharged with educating what are the signs of infection and when she has to report to the hospital. With all these things, she can be monitored on weekly basis or bi-weekly basis, depending on the maternal and fetal condition, with regular leukocyte count and with scanning to look for the AFI, and continue the pregnancy till 34 weeks. And then we can consider delivery after steroid covering.
So point was medical legal aspect of every decision which we take also should be taken into consideration. And written counseling for both pros and cons of each of the steps which we take should be explained in detail.
Yes, this has to be considered after explaining to the couple and family. Only with their continuous compliance we can continue this.
Thank you.
Thank you again on behalf of the KIMS Cuddles team, all the panelists and the chairpersons. The mementos will be given away in the area beside the lift. Thank you, everyone. And we'll now move on to the next session, session on recent advances by Dr. Vamshi, and it is going to be chaired by Dr. Surendranath sir. PPT. Surendranath sir is a senior consultant pediatrician, has worked in numerous official roles in the Indian Academy of Pediatrics and recently conducted the successful National Pedicon. Sir works as a senior pediatrician at Vijay Mary Hospital, Challa Hospital, and is a passionate teacher and trainer in neonatal resuscitation. Sir, we'll pass on the mic to you to introduce our young speaker, Dr. Vamshi.
Yeah, that was a wonderful panel discussion by Dr. Aparna. And I thank Dr. Aparna for including me in this faculty of perinatology CME today. And we have already discussed two most important aspects of the neonatal survival preterm babies and the infection. The next most commonest cause of death, neonatal mortality is birth asphyxia. Almost 1/3 of the babies who die of birth asphyxia in the neonatal period. I mean, we have a wonderful program of the NRP program, which is going on since almost 13 years. IAP has been conducting NRP workshops for those who attend the deliveries, apart from the advanced NRP for the pediatrician. So when I started my NRP workshop in 2011, compared to those days, there is a lot of changes which have come as far as the management of the baby during the first 2-3 minutes is concerned. To deal with the recent advances, we have our Vamshi, who is a young neonatologist from the KIMS, and is a consultant neonatologist pediatrician from the KIMS hospital. And he has been a faculty for most of the neonatology workshops and the teaching programs which have been done by the KIMS and elsewhere.
Thanks for the introduction, sir. So now we have gone through all the major recent changes that have been done in the neonatology and the essential antenatal and the postnatal care that required. So briefly, we'll discuss the 10 changes that happened in the NRP over the last decade. So we know that majority 85% of the babies doesn't require any pediatrician support. They will born usually cry and initial breathing within the first 10 to 30 seconds after birth. Nearly around 10% will require some amount of early initial steps in the form of drying and stimulation, and 5% babies or term babies require positive pressure ventilation, and only 2% need intubation, and only 0.1% require cardiac compression, and rarely 0.05% of the term babies will require the adrenaline support. So coming to this pyramid, nearly most of the time the babies require when the warm, drying them and stimulate and for the breathe. And nearly rarely babies less frequently need supplemental oxygen and also the positive pressure ventilation and the intubation. And very rarely needed is the chest compressions and the trachs. So if you know how to do the basic initial steps, nearly 85 to 90% of the babies will be solved. So these are the 10 topics that I want to briefly review. This has been changed in the last decade. So the first is delayed cord clamping. We had an extensive discussion of delayed cord clamping. So all the term babies and the preterm babies who had cried should be done the delayed cord clamping of around 30 to 60 seconds, because it doesn't not only have the benefits in our babies, they also have a benefits in the mothers also. So because of the delayed cord clamping, the placenta and the uterus will be loss of the will be less amount of the blood will be stay back in uterus and the placenta. So there is a decreased chance of postpartum hemorrhage, the need for the uterotonic drugs, and the incidence of anemia in the mother. The baby terms and the preterm baby, the hemoglobin will be more, the chance for the bleeds and the chance for the NEC and the mortality will be less. A mild increase in the bilirubin is there in the preterm baby, but it doesn't translate into providing the extensive phototherapy or extent transfusions. So the guidelines say every preterm baby and the term baby require at least of 30 seconds and preferable of 60 seconds of delayed cord clamping. The babies who require resuscitation, the evidence is not yet concrete that whether the delayed cord clamping should be done or not, but there are multiple studies have been happening for intact placental resuscitation. So the theory is when the baby is not born and doesn't cry, if you delay the cord clamping until the baby starts cry, so the maternal blood supply, the oxygenated blood from the placenta will be still supplying to the baby. So that is the thought process for doing intact placental resuscitation, but evidence is still not yet concrete for this thing. So as of now, we are not doing any delayed cord clamping for the babies who didn't cry after birth. And there is another thing is like umbilical cord milking, which is the milking of the umbilical blood from the placenta to the baby side. This can be done in the situations where the baby has cried and the baby does not, there is no time for the obstetrician and the neonatologist to do the rest of the process, where we can do the umbilical cord milking, but is not advised less than 28 weeks because it leads to more amount of intraventricular hemorrhage. Then delivery room temperature is one of the most important things. So the newborn babies inside the mother room will be around 37 degrees centigrade. All of a sudden, if you bring the baby to the environment, which is around 18-20, which usually keep in adult OT, can lead to so much of hypothermia. But at the same time, we need to work in that temperature with all the OT drugs, scrubs, and the caps. So and around of 23 to 25 degrees is the optimum temperature. The delivery room temperature is good for the babies in order to avoid the hypothermia. So all preterm babies nowadays, we are less than 32 weeks. We are using these plastic wraps. These are food grade biodegradable plastic wraps. If you use these plastic wraps, the insensible water loss will be less, and there will be microenvironments created around the baby, and so that it acts like a provider to the humidity also, and the temperature loss will be less. And the studies have shown that by using the plastic wraps, the mortality and the temperature loss is much less in the babies who are being used the plastic wraps. So the one is the normal temperature maintenance is a paramount for the baby. In the compared to the adult, even for the pediatric, the PABC is the thing that we'll see for the newborn. Temperature, airway, breathing, circulation. So maintain the temperature is most important. For less than 32 weeks, we prefer to use you take the baby and directly in the plastic wrap even without drying the baby. And the radiant warmer, thermal matrix, these are also needed to maintain the temperature. One important thing is we should never avoid we should avoid the hyperthermia, because hyperthermia more than 38 degrees centigrade can lead to cerebral blood fluctuation that can lead to IVH and also can increase the basic metabolic rate and can lead to more amount of neural damage in the case of asphyxia. So in your resource poor settings, at least we can use a clean food grade plastic bags to cover the baby's neck and swaddle them after drying. And if the resource limited setting where we don't have a radiant warmer, we can use the Kondapur mother care instantly that provides skin to skin contact and better amount of heat transfer from the mother to the baby, and the baby remain eutheric. Then this airway and tactile stimulation. So if the babies have a good respiratory effect, the unnecessarily tactile stimulation is not required. However, if the baby doesn't have any effective respiratory effect, the tactile stimulation is still reasonable because it's one of the initial steps that we do for the baby. And if you don't have any visible secretions and the baby is crying, there is no need for routine oral, nasal, and the ET suctioning. So that can lead to more amount of trauma to the oral and the nasal cavity, and it can lead to the stimulus of vagus that baby can go into the bradycardia and the respiratory arrest. And previously, maybe around some 4 or 5 years before, when we are doing our MD, we used to be told that whenever any meconium state liquor is there and the baby is not crying, we need to intubate the baby, do the suctioning by putting the suction tube directly into the trachea. Nowadays, the studies have shown that by doing this, majority of the babies have been delayed in the initiation of the breathing. So any meconium stain liquor, if the baby is not crying, there is no need directly to the intubate. We need to follow the routine steps. We can do the initial step to the positive pressure ventilation. If you feel that any obstructed airway, your pediatrician feel, then we can intubate and do the tracheal suctioning. So routine intubation suctioning is not needed in the babies who have a meconium stain liquor and non-vigorous. And nowadays, we are able to provide the respiratory support even in the labor room only. So by providing the heated and the humidified gases for the resuscitation itself, the studies have shown that the intraventricular hemorrhage, severe grades, grade 2 and above, the chances are much less, and the hypothermia incidence is also much less. So it's always preferable to use the heated and the humidified gases even in the resuscitation. And next, so if the baby has not cried after the drying and stimulation, so the next thing that we'll do is the positive pressure ventilation. So as we discussed, maybe around 3 to 5% of the babies require resuscitation with the positive pressure ventilation. So how can this be provided? So the routine thing that what majority of the centers are having is self-inflating bag. This will also called as AMBU. AMBU is actually artificial manual breathing unit. So the routine name is self-inflating bag. And we have a flow inflating bag, anesthetic bag, which we don't use for the newborn babies, and the TPS resuscitator. So we prefer to use the TPS resuscitator in all the neonatal resuscitation program, because the TPS resuscitator, the evidence shows that by using the TPS compared to the AMBU bag, the chance of the positive pressure ventilation duration is less, babies requiring intubation is less, and high proportion of neonates could be resuscitated with just the room air without additional oxygen support. Because the TPS provide both the PEEP and we know how much amount of the PI, that is the pressure that we can give. So previously, in the maybe around a decade or 2 decades back, when the baby doesn't cry, the traditional way is to provide the oxygen therapy for the baby. That's without unregulated oxygen therapy can lead to more amount of oxygen, free radical damage, more amount of the brain damage to the baby, lungs damage, and also the more amount of bronchopulmonary dysplasia, the more amount of necrotizing enterocolitis. So there are multiple studies have done, and they found that by the effect of the neonatal mortality is much higher if you use very high FiO2. So we need to have a proper blender in order to provide the appropriate amount of the oxygen. So there is no need to give the 100% oxygen. We should have a blender. The blender is a device which regulates the how much amount of the oxygen can be given to the baby. So if the preterm baby is less than 35 weeks, you need to start with 21 to 30%. In the term babies, there is no need to start oxygen therapy for the baby for resuscitation. We can do resuscitation with a plain bag and mask or a TPS resuscitator with blender with a 21% FiO2. And any FiO2 more than 65% should not be given because it is more hazardous to the baby than rather than saving the baby. And the oxygen saturation should be monitored after starting the oxygen therapy to the baby. Always we advise to use the preductal saturation, that is the right upper hand is preductal. We always put the pulse oximeter before as soon as the baby is being started of providing any respiratory therapy form of post-prandial ventilation or CPAP, and the preductal monitoring saturation should be done. So these are the minute appropriate saturation targets. So it's to be so surprisingly 1 minute the baby saturation will not reach beyond 90. It is around 60 to 65%. In the intrauterine life also baby saturation may be around 45 to 50% only. Once the baby has born, the first minute is 60 to 65, then slowly from 65 to 75% will increase, and it almost take 10 minutes for the baby to reach a saturation level of 90 minutes. So don't get panic when you apply the pulse oximeter probe to the baby, and don't increase the FiO2 too fastly. We can wait 1 to 3 minutes or 10 minutes. If your saturations are minute appropriate level, you can still continue the same oxygen level. And previously, if we were to see any preterm baby who has been born directly, the baby has respiratory distress or not crying, we used to apply the baby directly, intubate the baby and apply the post-to pressure ventilation with the bag and tube. Now, because of so many studies have happened, any baby who has cried breathing spontaneously or having labored breathing nowadays, rather than intubation, we are applying the delivery room CPAP. Delivery room CPAP is the one where we apply the CPAP through the positive pressure, positive and expiratory pressure through the mask that is including both the nose and the mouth. So in this way, the positive pressure will be transmitted to the lungs and it will open up the lungs so that the babies can have a breathing comfort, and the chance of collapse of the alveoli is less. So the application of CPAP, and the evidence is very strong that by using the delivery room CPAP, the chance of the bronchopulmonary dysplasia 36 weeks is less, the death is less, need for the mechanical ventilation is less, and even the use of surfactant is less. So hardly now compared to the previous decade, nowadays the use of surfactant is much less. If you do the antenatal steroid application of the delivery room CPAP, we are able to avoid majority of the babies giving the surfactant. Next, previously the guidelines used to say that we need to stop the resuscitation after the 10 minutes after the failure of the resuscitation. Nowadays, the recent in 2021, the changes have been happening that we need to withhold and discontinue resuscitation after the 20 minutes after the birth, that after the discussing with the family members. So after the 20 minutes of resuscitation after the birth, the baby is not crying, you can discuss with the parents and we can continue the withholding of the discontinued resuscitation, because after 20 minutes the chance of the return of circulation is less, and also they found that the morbidities are much higher even though the babies have been salvaged. So in this way, these are all the 10 changes, the recent changes that have been practicing in order to have a better outcomes in the baby. Thank you.
Thank you, Vamshi. I think you have covered the most of the points. So as far as the gynecologist is concerned, this is enough, I think. For a pediatrician, maybe some good things are required. So delivery room CPAP is preferable.
Yes.
Or TPs is also preferable. Once you learn how to use the TPs, that is better for a preterm baby. Thank you.
Thank you. Any questions? Thanks.
The last panel discussion of this, I think, long and exhausting day, we have a panel of infertility experts. I invite the chairperson for this panel, Dr. Vandana Hegde ma'am, who is director of Hegde Hospital, to kindly take her seat in the chairperson's chair. Since we are not joined by Dr. Hema Deepti ma'am because of her son's illness, we'll have to be skipping the talk on optimizing recurrent pregnancy losses. I also take great pleasure in inviting Dr. Anupama Rao ma'am from Anupama Hospital for co-chairing the session. I'm not sure if Dr. Shraddhanjali ma'am has come today. Probably she could not come due to personal commitments. So over to Vandana ma'am and Anupama ma'am for chairing this panel discussion. It's going to be a very interesting panel on optimizing the take-home baby rate in assisted reproductive techniques. And to moderate this panel, we have Dr. Shilpi Reddy here. She is an infertility expert and director of Shushruta Children's Hospital in Kukatpalli. And she has prepared a set of very interesting questions and case scenarios to run this panel. And I request ma'am to introduce her panelists and to begin the session.
Good afternoon, everyone. And thank you for giving me this opportunity to moderate this session, optimizing take-home baby rate in ART. I now invite the panelists, Dr. Runa Acharya ma'am. Dr. Chandrika ma'am from KIMS Cuddles. And Dr. Archana. So as all of us know, after conception, the ART pregnancies do not differ much from natural conceptions, except for few complications. But the approach differs in that these couple have already undergone multiple ups and downs during their fertility journey, be it socially, economically, or emotionally. And I think these are the couple who require a bit more empathy and compassionate care and moral support. And we as obstetricians should be able to render that extra compassionate care with empathy and moral support in order to enable them to make their dreams of parenthood come true. So with this, let us start a case discussion. Coming to the first case, a 32-year-old lady, anesthesiologist by profession, married for 5 years, non-consanguineous marriage, regular cycles, started planning for pregnancy from first year after marriage. She was hypothyroid since 10 years on Thyronorm 200 mcg. She was diagnosed to have mixed connective tissue disorder 1.5 years post-marriage when she developed rash over the face and small joint pains. She was put on high dose of steroids, GCSF, azathioprine, in view of leukopenia, severe arthritis, and myositis. She was intolerant to azathioprine and was switched over to HCQS 400 mg. As the symptoms subsided, steroid dose was tapered. On fertility evaluation, male factor was found to be normal, USG pelvis normal, her AMH is 2. She underwent 3 cycles of ovulation induction with timed intercourse. HSG was normal and tried 3 cycles of IUI, but with no luck. First cycle of IVF was done with ANTAC protocol. 7 oocytes retrieved, but there was only 1 transferable embryo of grade 3 BB. She conceived, but it ended in missed abortion at 6 weeks, 2 days, which was terminated. Immediate post-abortion, there was flare-up of symptoms with malar rash and severe restriction of movements of small joints. Steroid dose was hiked, and as the symptoms subsided, the dose was gradually tapered. Now, she has come to you at this stage. How do you go further from here, and when would you like to start the treatment? Dr. Runa.
was genetically or the autoimmune way there. So the entire balance have to be done because even with the autoimmune conditions, there could be something multiple or full positive antibodies. And anti-TB antibodies is one of the very well studied these days for having certain testicles. Also, it could be genetic. It's not always an MCPD endocrine abortion. So these abortions, the MCPD has to come down into a remission stage because any pro-inflammatory stage which also affects the genitals. It's known that individual markers do change epigenetic changes, they do this change and inflammation and all effects come onto these genes. And these form a good-looking embryo, but they have the tendency to abort. So you have to get the disease into the complete minimal stage of remission for the two reasons that the pregnancy will go better. The first 3 months of pregnancy has an effect. The disease has an effect on the pregnancy, but once the immunosuppression is established, then it is good for the pregnancy or the mother with the MCTD. The second is the minimal dose of medicines for any autoimmune conditions is best in the pregnancy, especially in the organ 6 to 9 weeks. So our main concern is from the disease effect on the pregnancy and the pregnancy effect on the disease. So both of them would be better if the woman is in the complete quiescent. And if she cannot be in the quiescent phase, maybe if her reserves are less, you can go ahead with a fertility preservation. See to it that she comes in a very good remission for maybe a year or so, and then go back with the embryo transfer. So segmentation IVF is sometimes useful in such conditions.
Yes. So we need to wait till quiescent phase, and during that time we have to plan for pregnancy. So then what treatment would you like to start with from now on?
See, this may be not a direct indication for IVF. She has tried actually little, so we can step back. And always I say that one IVF pregnancy may be a reset button. So, you cannot have to jump again to an IVF because there's a lot of mental stress. So a lot of things, the stress, the autoimmunity, and already in a borderline reserves all affect the genes of the oocyte. So it's better that you wait, let her try naturally. Maybe your support with the steroids to, prevent the autoimmunity in its peak, all that, and take care of you treat her like an RPL. Though she has had one abortion, but it's been an IVF, she has an autoimmune condition. So maybe we treat her like an RPL and do all the necessary investigations and take care of the initial stage of pregnancy. Let her try maybe for a year or so. Keep monitoring her fertility indices. And if all good, I think I would step back to level 1 or level 2 of fertility again.
She has already tried multiple cycles of OI and IUI as well before going for IVF. And then IVF was tried. So here she was actually keen for conception. So we have opted for another cycle of IVF. So, and again, counseling about diet and lifestyle modification is very important. So as she is for responder falling in for CTN group 1, what would be your strategy and what is your take on growth hormone addition in this cycle?
See, growth hormone, if you go by books and papers, there's no role. But there is one condition, hypogonadotrophic hypogonadism, but it doesn't fit here. So in case the testosterones are low, you may try growth hormone. So I do serum total testosterone monitoring, and if sometimes, but I think Positive 1, you don't need anything. You can as well, because they're good responders.
Yeah. So here, and we need to add some antioxidants, adjuvants for quality improvement. Growth hormone, again, as you said, there's not much evidence according to Ashri. So in this case, but we have given growth hormone. The stimulation was done with Antac protocol. 6 oocytes were retrieved, out of which 5 REM2, 1 was empty zona, 4 fertilized. We have frozen 3 blastocysts on day 5. First FET, we have transferred 2 blastocysts. She conceived, but it again was a biochemical pregnancy. On evaluation, her TSH was found to be 10. So endocrinologist's opinion was taken, but it was found to be maybe because of drug interaction. She was taking Tylenol and estradiol Valerie together. So that might be because of drug interaction. So correction was done. Second FET, we have transferred 1 blastocyst. She conceived. Now, what are all the medication you would like to add post-transfer in this case?
See, in the first FET, you said the thyroid shooted up to 10. So she would most probably going back could be an anti-TPO positive. So these women have a very unstable TSH. So they will have 1.5 at the time you start your HRT, and when the time you transfer to beta HCG, they will shoot up to say 14, 10. So this woman, maybe the steroids do help in the post ET treatment. Antioxidants is what we give, and definitely the progesterone support. There's no much evidence or role of ecosprin blood thinners, but because she's been a mixed connective tissue, maybe the coagulation profile can be changed a little with anticoagulants. But the mainstay here would be antioxidants more to avoid the stress induced or the RAS effect on the embryos.
Yes, because any case of autoimmune disorder, there may be some immune related this things. So in such cases, methylprednisolone would actually help, steroid would actually help. What is your take on IVIG and intralipids in such cases?
I use intralipids because I started believing in it, but IVIG, I use the IMIG because it's no harm. IVIG has a lot of side effects, so you have to weigh it. I have only used IVIG in ITP cases where you really need it. It's a mode of treatment. See, if IVIG is a treatment for the disease per se, you have to use. But just because it enhances your implantation rates in IVF, I would not recommend.
Okay, and if more randomized trials required for that. Post-conception, after 8 weeks of gestation, when she comes to you, how do you manage, Chandrika?
Till up to 12 weeks, I would like to continue with the same treatment as IVF specialist. Apart from that, as you told madam, that she's a case of connective tissue disorder. So she becomes a high risk to develop preeclampsia and placental insufficiency. So I would like to add on aspirin as well as heparin.
Yes.
Like aspirin till up to 36 weeks, 150 milligrams once per day, and heparin like low molecular weight heparin, 5,000 international units. 70 days.
Okay, low molecular weight heparin or aspirin. So, and she requires frequent monitoring.
High risk case, she needs a frequent monitoring rather than normal OBS cases. And definitely because of her history, IVF and all, she needs a screening, first trimester screening.
Yes, she requires frequent monitoring during first 12 weeks for fetal cardiac activity because she already had a history of 2 abortions previously, and first trimester screening along with NT because she's already prone for preeclampsia and IGR. Yeah. In case if you go for low molecular weight heparin, how long would you continue the low molecular weight heparin and aspirin?
Low molecular weight.
Yes. Dr. Archana.
We continue these 24 to 36 hours prior. And as please continue till delivery 150 and recommended by AC.
So about what should you be vigilant considering history of MICT, Chandrika ma'am?
Because she may develop preeclampsia, what I should be vigilant is maternal and fetal surveillance should be regular, ma'am. One is we have to look for, first thing is I'll go for 16 weeks soft markers, then TIFA scan, then Doppler to check for the uterine artery flow, then 2D echo. And put her on regular supplements as well as ecosprin and heparin.
In the MICT, these people are more prone for leukopenia, so frequent blood works are required, CPC and even creatine phosphokinase levels to look for flare. The creatine phosphokinase levels usually indicate the flare-up of infection. That should be done frequently. Do you continue steroids? Stop them, Archana?
So I would like to continue steroids because they have immunosuppressive and anti-inflammatory properties. So they help in reducing the symptoms and decrease the risk of flare in the future, in the coming weeks of pregnancy.
And they have a beneficial effect in terms of FGR as well. So do you recommend any special investigations considering her treatment with HCQS? And when do you plan delivery in such cases, ma'am? Chandrika ma'am.
Hydroxychloroquine, it can affect the heart rhythm and rate. So fetus can develop heart blocks or conduction defects. So we need to monitor that. And delivery at ma'am, as you told, 38 weeks.
Yeah, in case if she's
Everything is going well.
asymptomatic, we can deliver it 38 weeks, or based on the symptom development, it can be planned accordingly. So going to the next case, she's 38 years old, Mrs. X, married life 12 years, non-consanguineous marriage. She underwent few cycles of ovulation induction during first 5 years of marriage, but she didn't conceive and stopped treatment. 7 years post-marriage, she conceived spontaneously. She underwent regular antenatal care, but had IUD at 16 weeks, for which termination was done. Second was again a spontaneous conception 1 year later. She had regular ANC, but this again has to be terminated at 25 weeks in view of severe preeclampsia, resulting in stillbirth. She took a break for 4 years and came to you at this point. On evaluation, her AMH is found to be 0.3, FSH 10, LH 8, E2 70. And husband semen analysis, total count is 30 million per ml. Progressive motile count 15%, rapid linear motility 1%, and normal morphology 1%. So now, what more investigations would you like to do before going for IVF, and how do you go about in this case? Dr. Gupta.
Yeah, she is now, I think, a positive 4. AMH is low. Yeah, 0.3. So I first will try to understand what is her AFC count, so that you know that how many have to counsel them that this is the success rate for the IVFs. And first, before going to pregnancy, you have to understand that there were two things. One was an unexplained IUD, and one was a preeclampsia. Becomes an APLA. Correct. So you have to consider an APLA, and from that angle, it's very important that your pregnancy in the first 3 months to be taken care properly, because that's how the placentation happens. And IVF, it's a big challenge because it's an artificially given placenta. So in such a woman, I would definitely give her a month or 2 of antioxidants and pump her with calcium, because again, it is going to be, calcium is known to be a treatment for preeclampsia, and it would improve the quality of the eggs. So maybe a month or so of a pre-treatment, prime her for a month. Maybe start with the same ANTAC protocol and look to obtain the oocytes, do the embryos, and prefer a fresh with a fresh transfer, because that would give her a corpus luteum, though it's a little damaged, but that's okay. And also that give a good support in the pregnancy, even if it is a fresh transfer, because the people with fresh transfer have a little risk for a little higher chance of a little preterm. So trying to go with that, give her all the support with the blood thinners in the post-ET period. And maybe if in case I can't do the fresh transfer, I would prefer to go for a modified natural cycle transfer, because the main aim to prevent preeclampsia as an IVF specialist is that I give her a corpus luteum, which would definitely be the beginning stage. And if nothing works, then there is always an artificial cycle frozen embryo transfer. And here, where we stop the estrogens at around 10, sometimes 11 weeks, I would see to that I taper it down by 9, 10 weeks. So that again, the risk of estrogen on the preeclampsia. Monitor her uterine artery PIs in her around 15, 16, and maybe continue heparin, or give her low molecular heparin from the time our ET is done. So this ways you can help them have a little less chance of preeclampsia. And I think a big challenge again is to get, but because she has a proven fertility, maybe she may conceive easily, even if the AMH is 0.3, if she gets 2 to 3 good embryos also.
What's your take on sperm DNA fragmentation test in this? Considering
if you look at DNA fragmentation, so it will come high in urban population. But the first could be an IUFD, explainable, but the preeclampsia is not well explained by DFI. So yeah, there's no harm in doing a DFI because now your whole, maybe the genomics is the oocyte genomics. So trying to give a better sperm genomics will help. So if the DFI is more, you can try to rule out the causes of DFI, correct it with antioxidant therapy, or if there is a varicocele, correct the varicocele. So try to compensate the sperm would be the role of DFI there.
Yes. So then post embryo transfer, would you like to give only ecosprin or low molecular weight heparin or both combined?
I think combined, maybe not a therapeutic dose of LMWH. I mean, maybe a prophylactic along with ecosprin, because history is there. She's older and low oocyte count again would be corpus luteum will not be that great.
Yeah, so we have done APLA in her and she was found to be ACL positive. We have done IVF with self-oocyte. Here we have counsel for PGDA considering her age, but the couple were not willing for that. 4 oocytes were retrieved, 2 blastocysts were frozen in view of high progesterone levels. Frozen SED was done. She conceived a singleton pregnancy. So now when she comes to you at 8 to 10 weeks of gestation, how would you go about and how long will you continue low molecular weight heparin in her, Chandrika?
Ma'am, till I planned her delivery 24 hours before her delivery, I would like to continue the heparin.
Yes, and suppose in case, because low molecular weight heparin, as it doesn't have any antidote, do you prefer shifting to unfractionated heparin at 36 weeks or would you continue with low molecular weight heparin?
No molecular weight heparin. So regarding the antenatal thing, of course, because APLA, once again, she is a high risk for developing hypertension in pregnancy, growth restriction in pregnancy, and also IUD also. So needs more of a intense monitoring throughout the pregnancy.
Yeah. Low molecular weight heparin, actually the risk of bleeding is less compared to unfractionated heparin, but some people tend to change to unfractionated heparin 36 weeks later, because in case if there's any unwarranted bleeding also, unfractionated heparin has an antidote. So can you please elaborate on lab and clinical criteria for obstetric APS, Archana?
Yeah, the clinical criteria includes the vascular morbidity and the pregnancy morbidity. So the vascular morbidity includes 1 or more clinical episode of arterial or venous or small vessel thrombosis in a tissue or any organ. Of course, this should be confirmed by the imaging studies or Doppler. And next, coming to the pregnancy morbidity. So 1 or more unexplained deaths of a morphologically normal fetus beyond 10 weeks of gestation, 1 or more preterm births of a morphologically normal fetus at 34 weeks of gestation in preeclampsia, eclampsia, or placental insufficiency, and 3 or more unexplained consecutive abortions beyond less than 10 weeks of gestation due to maternal abnormalities or hormonal abnormalities. Then coming to the lab criteria, it includes anti-cardiolipin antibody, lupus anticoagulant, and anti-beta 2 glycoprotein 1.
Yeah. So antiphospholipid antibody syndrome, it has again non-criteria obstetric APS as well as obstetric APS, and there's another one called seronegative, wherein the antibody levels may be very transient or the antibodies were present initially but again weaned off. In such cases, only ecosprin would be enough. So in case of low molecular weight heparin, would you prefer prophylactic or a therapeutic dose? And when do you give a therapeutic dose, Chandrika ma'am?
I would like to give prophylactic in this dose because she didn't give any history of thrombosis before. Of course, if she would have given the history of thrombosis, then definitely therapeutic dose should be given.
Yes. So therapeutic dose is in those with antiphospholipid antibody syndrome with thrombosis, and prophylactic dose in those without any thrombosis. So what is your goal on prophylactic encirclage in this case, Archana?
So prophylactic circlage is done when there is any history indicated where there are previous mid-trimester losses or preterm births between 16 to 34 weeks, or it could be scan indicated where the TVS done at between 16 to 24 weeks, where the cervical length is being less than 25 mm. In this case, there are previous 2 pregnancy mishaps. So I would like to go for a prophylactic encirclage.
Yes, considering her age and very low AMH, and because it's a very precious pregnancy, prophylactic encirclage. And what is your management strategy till term regarding the consultation visits, USG monitoring, and when would you plan to deliver and by which mode? Archana,
Every 2 weeks, ma'am. Management is like because she belongs to very high risk and with MIOH and IVF conceived, I would like to give her more frequent visits. Like every 2 weeks, I would like to have And of course, after TIFA scan, along with the Doppler, I would like to, every month, I would like to do a Doppler checking for all the vessels, MCA, umbilical artery and uterine arteries. I have to see, depending upon her critical condition, how long can I will, but my intention would be to cross her beyond 34 weeks.
34 weeks, yeah. In case if it's uncomplicated, usually
Then
37
usually
completed
38 weeks. Term.
37 completed, 38 weeks. But in case if there's any development of complications based on that, we need to take it as
we will have to 30.
So coming to case 3, she's a 33 years old lady, married for 7.5 years, non-consanguineous marriage, irregular cycles, planning for conception since marriage. 3 years after marriage, she underwent 3 cycles of ovulation induction, after which she conceived spontaneously, but had a spontaneous abortion at 5 weeks, 5 days. Underwent hysterolaparoscopy and right ovarian cystectomy for large right ovarian cyst, where she was told, except for ovarian cyst, all the other findings were normal. She again underwent 2 cycles of ovulation induction and 1 cycle of IO, but with no luck. Second, she conceived spontaneously, but again this ended in a missed abortion at 6 weeks, 4 days. Termination was done by medical methods, after which she underwent 2 cycles of IO. The last conception was 3 years back. Her AMH is 3.5, FSH 4.1, E2 54, and her BMI is 30. So she comes to you at this stage, and USG pelvis was done, which showed normal sized uterus with a broad fundus, normal external fundal outline, with internal fundal indentation depth of 14 mm at midline and indentation angle of less than 90 degrees. So how do you proceed further in this case regarding the investigations and treatment? Dr. Lunam.
She had 2 abortions, so I think you have to again go into the entire genetic workup, the autoimmune workup. You would label her as an RPL. Now infertility also is coming into picture. You said about the broad fundus. I think I would prefer to do a 3D first. 3-dimensional ultrasound mid-cycle, if possible, so that you have a good view. And if, okay, so you have a septum there. So I think it's there, but septum usually would not cause a first trimester abortion. It looks like this, both the abortions have been a non-viable, could be in genetic, because this category would come into 50-60% genetic. Unfortunately, it is not more than 6 weeks. Otherwise, you would have done a WS or a microarray or a karyosec on the chromosomes, products of conception. So septum, yes, should be treated. Subseptum should not be treated. But if there is a septum, go ahead. But I'm still wondering that hysterolaparoscopy was already done.
Yes, hysterolaparoscopy.
So if hysterolaparoscopy is done, I mean, something has been missed there.
Yeah.
It could be an Asherman band. If in case it is not there then and now, which is, we sometimes see that it pulls the fundus down. Yeah. If somebody has done a curate, which the history has not been given.
Yeah, but she didn't underwent any DNC.
Yeah, so could be that they missed a history, they missed a septum, and then I think you go ahead with the septum resection, and then give a, I usually don't put property there. I just give a E+P. So you can give something to just build the 9 over a month or 2. And if the septum resection is a very thin, flimsy septum, you can plan pregnancy after 2 months, or you give a little more gap. Yeah, so to provide good healing to the uterus.
Yeah. Here, actually, when we have done the hysteroscopy, there was a thick septum. Thick septum was extending up to the mid cavity. Septal dissection was done because she, after septal dissection, we have tried 1 cycle of IUI, but she didn't conceive. In view of prolonged married life and multiple OI and IUI cycles, which she has already undergone, IVF is done. She was stimulated by fixed antac protocol, freeze-all, and day 5 blastocyst transfer was done in a HRT cycle. So now, any extra medication would you like to add post-CT in view of recurrent abortions?
In recurrent abortions, we add a little bit of steroids. HCQs do play some role. So, in that, and progesterone support. The first was a spontaneous abortion. So this IVF pregnancies usually don't have spontaneous abortions because too much taken care of. I think Vandana will agree. Too much of luteal phase support. So we don't end up having spontaneous, but missed is not in anybody's hands. So the spontaneous abortion, again, I think the progesterone should be given on a little good dose. The blood thinners, again, the encospirin and maybe a low molecular weight heparin. And I think
would you prefer natural progesterones or diprogesterone?
I prefer diprogesterone
because of
sometimes, I mean, usually in such cases, I prefer natural micronized progesterone vaginally. So in cases where you have a cervical issue, Natural progesterone is more of immunomodulatory is what I believe. So vaginal progesterones and the combination. In fact, the recent, I think 2023, there is one big study, right, Vandana, which says that NMP plus dydrogesterone is better than dydrogesterone alone or NMP alone. So better put a combination of both in special high-risk cases, right?
So natural progesterone along with dydrogesterone can help in immune modulation. So she conceived, it was a DCDA twin gestation. So if FET in a HRT cycle, when do you stop E2 and how? Do you taper it or do you stop it abruptly?
I don't stop abruptly, maybe 3-4 days of tapering and stop. Somewhere around 9 weeks we start.
Okay.
In case the chorionic reaction is good, if the endometrium has been good, you can stop it earlier also. But sometimes because there's no corpus luteum, you may need a little estrogens until the 10 to 11 weeks.
Yeah, still 10 to 11 weeks. But usually stopping early,
you may have
beneficial effect.
You may have a breakthrough if the chorionic. See, thin endometriums, there is chorionic reaction is not good, and they're again prerequisite for, they become predisposed for the preeclampsia.
Yeah.
So the whole game is making a good placenta.
Yeah. So patient had recurrent spotting PV during first trimester. Supporting medication was given. First trimester screening was normal. Cervical length was 2.8 centimeters. And what is your go now, Chandrika? So cervical length is 2.8 centimeters. Do you prefer encerclage or
No, ma'am. I don't prefer encerclage.
Okay.
I strictly go by books. So especially RCOG guidelines. In fact, I have got some little bit of experience where actually I received a patient from Abu Dhabi and she was referred to me only to put an emergency encerclage. I explained her pros and cons and I was in a medical college. So I continued her for 6 weeks without any encerclage just by giving this natural progesterone and sustain every 72 hours. I've given her injection. And after 30 weeks, she signed LAMA and she went to Vijayanagar. That is one where I have continued her without putting an encerclage, because I told her even if I put an emergency encerclage, the chances that you will still deliver. You want it, but if I do it, sometimes I can even rupture the membranes because the moment I have put the speculum, I could see the membranes coming out. So I told you decide if you want me to do the heroic thing and do an encerclage, you might lose the baby also. So she told I'll wait. So it was my personal experience, ma'am. She went till up to 6 weeks. And after 6 weeks, she got tired of staying in a same bed and she went home. But after that, she didn't contact me. But still, I pulled her till up to 30 weeks, which was a viable period. And this was in 2017.
Okay.
And now also, one of my colleagues' own brother's wife, she was diagnosed to have a cervical length of 1.5 centimeters. So of course, we are also having two school of thoughts because she was IVF conceived twins. One of the consultant told, yes, we'll go ahead with the encerclage. I don't not require. She is 25 weeks. My aim is to pull her till up to 34 weeks. I think she'll pull because it is Y on the ultrasound. So we waited, ma'am. She had she went till up to 36 weeks without anything. She went till up to 36 weeks. So as far as my experience, I have never put encerclage, even if she has undergone operative hysteroscopy.
Yeah, but and if you're because operative hysteroscopy for a thick septum, sometimes it requires prolonged dilatation and all. So they may be damaged to the cervical fibers.
Yes.
Yeah.
If she would have continued the pregnancy with septum, maybe I would have put because preterm, but you have already removed the septum. You created the cavity.
Yeah.
So that's my goal.
Yeah, and yeah, the length is actually 2.8 centimeters. If it's less than 2.7 centimeters, encerclage would be ideal. But in view of operative hysteroscopy, we have done encerclage in her. And yeah, you said you'll not be going for encerclage in her case. She has gained 6 kg weight in first trimester. Considering her pre-pregnancy BMI and excessive weight gain and multifetal gestation, how will you monitor further? Actually.
So gaining 6 kgs in first trimester is definitely more. The ideal weight gain during pregnancy is 11.5 to 16 kgs. So she is more prone for GDM preeclampsia. So I will also advise her to go with good diet, add more proteins in her diet and decrease the carbohydrates. And I will also advise a good lifestyle modification. And I'll ask her to keep monitoring her weight and ask her for regular scans and checkups. And ask her to come for regular visits.
Yeah, regular monitoring of her sugar levels and blood pressures is recommended. USG at 18 weeks showed twin live fetuses with twin discordance of 13%. Internal loss of the cervix was open 6 mm with closed length of cervix 2.4 centimeters. What will you do at this stage? Will you opt for second cerclage in case if you've already put?
No, ma'am. I will wait.
So actually, we had waited for 1 week, but since it was progressing, we had to put a second cerclage with the anterior dissection in her. So serial scans were done at 20 to 23 weeks and 26 weeks showed increase in the discordancy of 18% and 24% in estimated fetal weight respectively. Other findings like AFI and Doppler are normal. How do you monitor her further, considering the discordancy of the fetuses?
So I would like to get scans every 2 weeks for AFI, Doppler, and estimated fetal weight. And along with this, I would advise strict glycemic control so that she will have good sugar monitoring at homes also. And ecosprin will be continued.
Yeah, ecosprin, in case if it was a low dose ecosprin, the dose has to be increased. So if one of the fetus has oligomnios and estimated fetal weight 900 grams, the second fetus 1.8 kg at 30 to 33 weeks, how do you counsel and when do you plan delivery? Archana, sorry, Chandrika ma'am.
Ma'am, already as you have told, she has come to 32 to 33 weeks. I would explain the pros and cons because one baby is already oligo on 900 grams. I would like to give steroids first, give antenatal corticosteroids. Aim is to take till up to 34 weeks, ma'am. And the moment I plan to deliver her, I would definitely, if I'm deciding that if the patient says that if she chooses to continue for 1 more week, then okay, fine. But if she chooses to deliver and she's between 32 to 33 weeks, then definitely magnesium sulfate and then deliver her.
Yeah, we can give 2 options because the smaller fetus already has got a prognosis. We can wait for another 1 or 2 weeks so that the larger twin has a good prognosis.
Because we have to keep the neonatologist, in such cases, we have to keep the neonatologist in picture and check for all the 3 Dopplers, NCA, umbilical artery, most important, whether it is a reversal or absent. So depending on that, ma'am, all the case scenario as a whole.
Can I continue? Another 2 cases. So case 4, she's Mrs. X married for 32 years, married like 10 years, non-consanguineous marriage, regular cycles. She has history of severe dysmenorrhea, underwent 2 cycles of ovulation induction after 1 year of marriage, underwent laparoscopic endometrioma resection for large right ovarian endometrioma 8 years back. Both fallopian tubes were normal. 2 years later, operated for recurrence of bilateral chalk cysts, after which she underwent 2 cycles of IUI and stopped treatment. After 9 years of married life, she comes to you with a recently done HSG showing bilateral gross hydrosalpinx. Her AMH is 0.4, FSH 6.8, FSH LH 5.3 and D2 52. So day 2 USG pelvis shows AFC 2 in each ovary. Both ovaries adherent to each other and to posterior uterine surface and large fluid-filled tubular structures adjacent to bilateral ovaries. So do you recommend laparoscopy before proceeding for IVF in this case, Dr. Rundu?
The AFC is very low.
AFC is very low.
So the first most important is you try to understand how accessible is the ovary. Correct. FSH doesn't match to the AMH though and the AFC. So if the ovaries are accessible, I think I would first go ahead with IVF because she's already undergone laparoscopy before. You know the diagnosis. And if you can take out, the oocytes easily, why not do a pulling if she wants? Because again, you are going to go do a laparoscopy. You're going to again, remove the hydrosalpinges. Again, the blood supply to the ovary is going to go down. You're going to remove whatever the cyst is there. Again, from this 2, it may slip down to 1 or 0. Fibrosis is going to be there. So it's better you do the preservation first, then do a laparoscopy, and then proceed with the.
So first oocyte retrieval followed by laparoscopy. And then, so among laparoscopic salpingectomy and salpingostomy, which one you prefer?
With all due respect to, I always feel if there is no damaged tube. This is a different story. Here, salpingectomy has to be done because it's all damaged. But in case wherever you can preserve in ectopics, I have done salpingostomies also. But rather, if you cannot see, we have a lot of cases where they do salpingectomy. They come back to us and still we can see some part of the hydrosalpinx remaining. So better to clip. If you can't do justice to the surgery, just clip off at the corner and do a good clipping so that you don't have corneal pregnancies. And I think come out. Because our main aim is only disconnection.
So post IVF, she conceived DCDA twin gestation.
In such cases, I think we should do single embryo transfer.
Yeah.
Twinning rate should be almost, I think,
here
zero in such cases. Even the last case, if you have done a hysteroscopic septum resection, I think it's our moral to do only one embryo transfer.
Single embryo transfer.
Single embryo transfer. If you want, counsel the patient for the money she has to spend on the NICU. It's better she does genetic testing of the embryo, put an euploid embryo. You know, as an IVF, I think it's our moral this to support the obstetric team in the best way. So, I mean, we follow the norm of single embryo transfers only in our unit.
Yes, single embryo transfer is preferred, but because the patient was willing for 2 embryo transfers, we have done 2 embryos. So she conceived, it was a DCDA twin gestation, and cerclage was done in view of short cervix. USG at 26 weeks shows single fetal demise. It was a fresh IUD, and the other fetus was normal. So does this fetal demise have any effect on the live fetus, and how do you counsel and monitor her during rest of her pregnancy? Chandrika.
As you told, it is a DCDA twin. I would like to do every 2 weeks fibrinogen levels, ma'am. Give her steroids. Check whether the other baby is developing. Generally, it will not develop, but if it is developing any symptoms of failure, I will monitor weekly. In fact, actually, in a colleges, we used to keep the patient with us only, but of course, here it will not be possible. So weekly, I would ask her to come check for the fibrinogen levels, coagulation profile, CTG monitoring, do the Doppler of the line until take till the time if possible 32 to 34 weeks now.
Yeah, because it's a DCDA pregnancy and it has 2 separate placentae. There's no sharing of the circulation, and hemodynamically, because they are independent, this IUD fetus may not have effect on the live fetus actually. So this is the last case, 30 years, Mrs. X, married life 12 years, consanguineous marriage. She's a known case of PCOS with irregular cycles, with history of withdrawal only after taking pills. She got married at the age of 18 years. 1 year after marriage, 1 year after which she started taking treatment for fertility, she underwent 5 cycles of ovulation induction, followed by 4 cycles of IUI 10 years back. She underwent 1 cycle of IVF with ANTAC protocol. 20 oocytes were retrieved, 10 fertilized, 6 day 3 embryos frozen in view of OSFS. She underwent 1 day 3 FET and second cycle FET, 1 day 5 blastocyst was transferred, but with no luck. So she did not take any treatment for 8 years. Now when she came to you, her AMH was 15, LH 14, FSH 10, E2 29. How did you plan treatment for her?
One thing I feel is if you've seen the genomics of the ovary, it is a hyperbolic curve. So the fertility rates are reduced in the initial 18, 19 teens and the later. So if she has had all this treatment and she was having a teen, 18, 19, 20, I think I would again try to work on her LH metabolic, which is her AMH is 15. And so this is again showing that there would be definitely very severe PCO. The quality of oocytes may not be great. So even if you retrieve 20, 30, you may not have a good blastocyst with a good pregnancy. So maybe work on her, try to change her lifestyle, reduce her weight, give her PCOS, I mean, whatever the minus metformins. I think here there would be a role, do a HOMA-IR, try to figure out if there is real insulin, try to rule out other metabolic conditions, because these women do have Cushing's and all this. So try to get up the entire workup for a metabolic syndrome. With all, try to correct as much as you can, because you have good time with her. I know she's married for a longer time, but doing an IVF in a hurry and ending up with no embryos or no pregnancy, better to wait for some time. And then maybe you can plan her IVF if she doesn't conceive. I would rather again try for a couple of, because there's been a lot of change in the last 8 years. So try a couple of IUIs with gonadotropins, and if she doesn't work, then go for an IV again with an ANTAC protocol, definitely.
So Yes. And,
PPOS, I don't know, people are doing, but antagonist is more better in terms of OHSS. And we don't know the effect of progesterones on the epigenetic changes is already a compromised oocyte.
So, in your experience, PPOS, you don't recommend in such treatment.
Antagonist is preferred because it will again, you can continue that post pickup also because already a risk for hyperstiffness.
So here, actually, we have done few cases of PPOS. The OHS risk was minimal. We had better oocyte quality actually when it was with PPOS compared to antaxide. So for this lady, we followed PPOS protocol, retrieved 18 oocytes, 12 fertilized, and 12 embryos were frozen on day 5. She conceived after FET. So it was a singleton pregnancy. She has a case of severe PCOS and high LH, has increased risk of abortions. So any special medication do you suggest or routine supportive medication?
Same as we discussed, the low aspirin, the progesterone support.
So this lady has normal pre-pregnancy BMI. Now she has conceived with IVF and comes to you at 10 weeks. First trimester screening shows increased risk of uterine artery PI with high resistance flow with increased risk of preeclampsia. What do you do at this stage, Dr. Rajkumar?
Yeah, since it's a high risk for preeclampsia, considering the increased PI, where there's high resistance, I would like to add aspirin 150 mg. And according to ISSHP, the role of calcium above 1.5 to 2 grams has been shown to decrease the risk of PE. And others like vitamin E, vitamin A, vitamin D need more studies to show that they decrease the risk of PE.
So last question, 28th week USG shows estimated fetal weight of 10 centile, AFI 10, Doppler normal, BP normal. 30th week, estimated fetal weight less than 10 centile. And 32nd week, it is 3rd centile. Doppler was normal. How do you follow up and monitor her and time fidelity?
Ma'am, all like umbilical artery, MCA, ductus venosus, every 2 weeks. We need to see, even though the percentile is less than 3rd percentile, if the Doppler is going well, then I will wait. But if there is an absent or absent means also at least for a 1 week, I will give her steroids, at least give her a steroids, wait for a 1 week and then I can. But as if it is a reversal, then definitely I will terminate, counsel her and terminate, keep the neonatologist in picture.
So based on the Dopplers, we need to decide. Thank you, ma'am. Thank you.
I just wanted to ask you, I mean, people routinely do a pentamarker or a rumella for such patients who are high risk. I mean, see, IVF we give for everybody, we give thinners. I mean, we have that, so because we have an artificial placenta. But I do pentamarker very routinely if the woman is more than 35. For all, it's a norm that we do it because my doctors ask that please do pentamarker. So lumella is expensive, but pentamarker, I think we do routinely for any woman who is advanced maternal age, high risk pregnancy, who is autoimmune profile goes left and right center in fertility center. So the moment one antibody comes positive, any high risk low, see premature ovarian aging is a sign of preeclampsia again. Same, something is changing, placenta, placentation will be problematic. So, wherever you have anything apart away from the norm, I mean, we do recommend pentamarker, but in the entire discussion, I didn't hear about pentamarker or the lumella.
I just do, man.
Yeah. So I think one of the very good tests which gives you a risk calculation, you'll be more vigilant, increase the dose of antioxidants during the placentation at least. So, majority of the times this is a crux, 12 to 16 weeks, half fertility percentage or so I think that's very important that part between the fertility to obstetrician to pediatrician should be very smooth. So from the fertility specialist, when it is going to the obstetrician, the things what can be missed should be taken care maybe by a fertility specialist because we are obstetricians first. Okay, and then after that, the obstetrician has to take care from the neonatology point of view also.
Thank you for your answer. I think, yeah, we are all moving towards the answer to go. And the very concept period, yes, these all the cases that are presented, sometimes we need a multidisciplinary approach where we need to take the help of our immunologists and all And the ideal time for a cancer, stimulation, there is no problem at all with it. You have very good fertility preservation, preservation techniques. Our core rates are 99.9%, I would say. Very good freezing. That's something that we can do, and cancer, that never been a. So, cancer will be done, okay, now, all the endocrinologists, all of them, okay, that's when we can do the cancer. And the most crucial is time of the 8 to 10 weeks they are with us. So definitely we need to ensure that that phase is taken care correctly. Because today I think the video presentation of pregnancy is changing. Because today whatever we call pregnancy modeling, everything is happening during that phase. So we are sitting it right and then giving it to the obstetrician. As long as we give a single pregnancy, as far as the ART law, we should be aware. It always be medical legally right. It's an evidence-based practice. So as long as we follow this, and ART law today supports single embryo transfer. Up to 2, but very rare. I think that we need to stick to that. And medically, very sure whether the results are large. Because every procedure that we do, we can have complications. Whether it's an anesthesia related complication, procedure related complication. So if we are taking the patient of procedure, very sure it is indicated for that. Because it's very easy to put a surclage. There is nothing that we lose. But if there is a complication, then we are answering. That's something that we need to take care of. Indicate I think hydrostatic people are communicating and not communicating hydrostatic. Terminal ones, very see other than if you can probably freeze the embryos further. There is an endometrial fluid. And we can take the visual decision the patient as a physician. Whether you can try probably one transfer without going in if you already have 2 laparoscopies in the past. And that should go ovaries were very stuck and all that. So there is no endometrial fluid you can try. But there is a failure that requires for a more detailed laparoscopy. Something that is prefer if you have got adequate embryos clothing. So then you can just go and get the sample.
You have this hysteroscopic cut. This is earlier we used to have. Now it is not always not there. It is very easy. I had one patient with 4 or 5 laparotomies, gridiron. So we did a hysteroscopic diesel and she conceived after that. So now it's not.
We are having more and more high-risk pregnancy. So I think the team that manages for delivery should be shortly the tertiary center. But I think just for ART pregnancy itself is the high-risk. With respect to what is the
definitely, ma'am. It goes beyond 3. More than 3 doctors will go beyond 3.
Yeah, what's it is there? Pregnancy is a high-risk.
Age becomes 4, she becomes 2.
Yes. That itself we have to anticipate a lot of complications, even though it looks normal. So that is the reason an obstetrician should do a little part of infertility. They should know what are the AMH value. You can't just write IVF presence. You should know what are the indicating for IVF. What is the tubal factor? Because if there's a tubal factor, at least there's risk for any infection to spread. If you look for preterm, there's a good increase in there is a cytokines along the path. So these things are complications should take care, and we as obstetricians should take care of this together. And the NICU doing a very good job today with handling the premature thing. As far as anticoagulant steroids, as a vaccine pregnancy, I would definitely.
Yes, definitely.
But you do have as obstetricians, your own assessment. You always tell patients that prophylactic steroids. So those should not participate when they land up with the complications. So, yes, very, very rare participants. But they have patients, not always going to be becoming more and more common.
Along with magnesium sulfate.
Yeah.
Because I received one case last month from IVF specialist only, ringing up that the baby is in vagina. So actually, it was fetal reduction which was done in the 13th week, and when I did PV, it was a dead fetus. So not even a single shot of steroid was given. So I told that I will try to pull. If I could pull only for 12 hours, also at least 1 dose of steroid matter. So we started. I gave her steroid, and then we gave her magnesium sulfate. Informed the NICU team, and God's day she pulled for 5 days. She pulled for five days, and then she delivered. And nicely, baby was given after 1 month to them, and IVF conceived. Of course, we were all very happy.
I know that you're all bound by the law for normal delivery today, but I think judicious use of cesarean has to be done.
Yes,
because that's something that we see that if it is not managed correctly, because the most important is the peripartum period, and that's something that because also all the histories they are all very prolonged married life, repeat failures, such difficulty and success rate around 60-65%. So going back and restarting. And especially as they see, women are coming later to us now.
Yes.
They are coming at the fag end of their reproductive career. And with just the last remaining oocytes, they are trying to conserve the pregnancy. At that moment, if they are not taken, to the delivery, that can be very challenging for the person, especially.
Definitely.
The
Yeah,
most
definitely.
difficult for us is patient coming back without a kid.
Yes.
You send a pregnant woman and she comes back without a child is the biggest challenge for an IVF specialist. Because then, you have endometritis in picture, you have again conceiving, naive endometritis is a blessing.
Yeah. That means judicious because cesarean also needs to be,
Apart from any malpresentation, we have to deliver by cesarean. It's an indication.
Right. Going to the vital district, the number of IVF centers that the patient has undergone, she may have absolutely no risk of pregnancy. But still, a judicious because cesarean we can consider. Still like normal delivery. I'm very much constant regarding the sampling because she plans the next pregnancy. I may go to national cancer. Even if only for doing an IVF 3 years space is 2 years from now. So that's the only patient reduction. If she is not convinced about removing it, not they are emotionally attached to the IVF problem. That is the main issue, and she has just chosen the IVF for 2 years that she is not coming back. That's what the literature evidence of telling that this is the success rate. Please, it's a evidence that is literature. She's very happy to pay for the 6 months. I don't know what is the about. But she's reluctant to go for the salary. The patient is still, I think, with the.
That's what there's a fear of sterility. Totally. See, a woman always hopes
for fertility. You are very. It's very, very difficult to answer the patient.
But actually says if the IVF doctor feels that the endometrium is good without the fluid, and she can do a 3D to see how the ostia is. So the best part of the newer machines is you can see the initial part of the ostia. So if you see that it is narrow, you can go ahead with an embryo transfer. Dilated, see, if you do hysteroscopy, you find types of ostia. Posteriorly placed is more risk for ectopic. Anteriorly placed would be high risk for the hydrosalpinx. They're stuck up. If it is nicely laterally placed, small, normal size, then the chance of pregnancy intrauterine is more. If they are dilated and coned up, they will suck them. So the many things you learn in hysteroscopy. So if you do a hysteroscopy, you'll get some idea. Maybe if they're dilated, then yes, hydrosalpinx were.
Along with Ramla, we can so a relatively probably yes, because we are seeing the incidence of protein deficiency on the hepatitis and protein C. That also could be eradicated in patients that are.
These patients have protein C and protein C and has come into higher level to the RDS and the RI. In fact, it should be the most.
Finally, literature.
Thank you.